Good morning, everyone. I'm State Representative Jillian Gilchrist, and I am kicking off the Human Services public hearing for February 28th. Today, there was a snowstorm in Connecticut, and so many people will be virtual, but it is a hybrid meeting. And so if folks want to join us at the legislature and feel safe doing that, please feel free. Before we get started, I want to turn it over to my co-chair who is not yet on his way in, but on his way in soon, Senator Lesser.
Yes, thank you, Madam Chair. We got a lot of people scheduled to speak today, so I will not make any remarks. Be safe out there.
Thank you. How about my good ranking members, Representative Case?
And good morning, Madam Chair, and let's get the ball rolling.
All right. And is Senator Seminara with us? I don't think yet.
She's in children.
Okay. So we, as Senator Lesser said, we have quite a few people signed up to speak today. And so I would ask my committee members, of course, feel free to ask questions, but let's be mindful that we want to be able to hear from everyone who has signed up. So with no further ado, I'm going to jump right in and turn it over to the Commissioner of the Department of Social Services, Andrea Barton-Reeves.
Morning, and thank you for allowing me to be here today. So good morning, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Andrea Barton-Reeves, and I'm the Commissioner Designate for the Department of Social Services. Thank you for the opportunity to appear before you today to offer remarks on several bills on today's agenda. And I know that we have quite a few, so I will try to move through them as quickly as I can. The first is Senate Bill 978, an act concerning expansion of the covered CT program. As you know, this bill proposes to expand covered CT, or covered Connecticut, or we also call it covered CT, to include families and individuals with incomes up to 200% of the federal poverty level, and then to create a plan to create a second tier to provide more state-assisted health coverage for individuals whose income exceeds 200% of the federal poverty level, but not greater than 300% of the poverty level. So while we understand and really do appreciate the committee's support and interest in this, there are a few things that we'd like to bring to your attention that are concerns that we have about the bill. So essentially, to start with just as background, the program has had lower enrollment than we had originally anticipated, I think just generally, but in many ways that's good news because it means that because of the moratorium or the support that we received during the pandemic, people actually then were eligible to enroll in other programs. And we were actually, as an agency, required to suspend most of our discontinuance of Medicaid enrollment. So we had a lot of people experiencing continuous enrollment under the current Medicaid standards. We understand under the unwinding, this is necessarily going to change. But the covered CT program itself actually operated under a number of conditions that over time would actually cost the state more and not covered under the budget. So we know, for example, that it receives substantial federal financial support through its subsidies, and those subsidies have been enhanced through the state-based market, through qualified plans during the state-based marketplace, as well as through our 1115 waiver. So those enhanced subsidies actually will only be in effect until the end of 2025. And then our federal participation through the waiver will only also be in effect until 2027. So that would mean that after those particular timeframes, then we as a state would have to find the additional resources in order to continue the program in the way that the bill proposes. So essentially, expansion would mean significantly more money that is really not in the budget right now. Right now, our estimate is that the expansion of the program financially would be in the range of $30 to $40 million. So, and that assumes several things, including the approval and expansion of the federal funds under the waiver, as well as the continued additional funds for the cost sharing under ARPA. And so while we can't really guarantee that those particular funding streams will remain available, and we believe in concept that expanding medical coverage for people is a really good thing. We don't have any issue with that, of course, that is what we do, and that's our plan, and we have a great partner in Access Health. We just wanted to bring to the committee's attention some of the concerns that we have about that particular bill and some of the financial implications that it has and timeframes that it has on it with respect to federal funding. So now moving to Senate Bill 991, an act concerning Medicaid reimbursement for community health workers. This bill would require the department to amend the Medicaid state plan by October of this year to provide Medicaid reimbursement for services provided by certified community health workers. We believe that community health workers are highly valued, and we are in great partnership with them, and we value that partnership for a very long time. The challenges that we have and that we like to bring to the committee's attention about this particular bill is that it is quite broad in the way that it is currently drafted, so that we don't have specific things that we would be asking community health workers to do. That in particular would be Medicaid reimbursable, and that really is very critical. Because the state funding that we have, as we know, is limited. So we would like to ask for a more focused approach that we can understand what services and supports we would be asking community health workers to deliver that would be Medicaid reimbursable or Medicaid match. And as it stands right now, we don't have any particular allocation in the governor's budget as it's been proposed to cover an addition of the community health workers and any reimbursement under Medicaid for them. So we'd like an opportunity to have further discussion about that so that we can create some more parameters that can give us some certainty and that we can do it in a way that would help us to try to guarantee a more federal match. With respect to Senate Bill 1109, an act concerning Medicaid reimbursement for community living arrangements and intermediate care facilities and individuals with intellectual disabilities, and what we call RCFs, our residential care facilities or homes. These are really, we're just looking for some technical revisions that will allow us to be in alignment with the federal rules. So as you know, we have identified certain technical revisions to the statutes that are necessary for us to facilitate, for us to be able to make sure that we have a proper Medicaid reimbursement that supports high need nursing home residents. Nursing homes, as we know, are extremely important, and more than 70% of nursing home residents receive Medicaid, and 198 nursing homes in Connecticut care for Medicaid workers. So to start with, the bill asks for a technical revision to Section 17B 340 that would allow us to continue to establish specialized rates for those populations with specialized needs. So just to back up just a bit, we're already in the first year, actually going into the second year of a 3-year transition into an acuity-based reimbursement system. So rather than just pay for individuals who are in nursing homes with no consistent approach, I should say, or consideration taken into the acuity of the needs that they have, we've moved into an acuity-based system, and we're going into the second of the third year of that. So these technical changes actually would allow us to continue to establish specialized rates for those nursing homes that are taking care of people that, for example, may have acquired immune deficiency syndrome, may have traumatic brain injury, or need other specialized services. So this actually would incentivize those nursing facilities to provide a higher quality of care, better care, more consistent care, because they're caring for people that have very acute needs. This technical change would also allow us to recognize reimbursements for fair rent increases for community living arrangements and allow them to continue to improve the quality of those properties. I think many of you know my background, so I know I used to run CLAs. This is so critically important, and having money available to improve those properties is really essential. It also allows us to rebase every 2 to 4 years after the end of the transition of the acuity-based program. So that we can have the ability, essentially this one allows us to have more consistent rebasing guidelines after our acuity period has ended. And then finally, the technical updates would include an alignment between the statutes and the regulations regarding inflation changes for the community homes and for nursing homes. So our existing regulations allows for inflation updates based on the percentage of gross domestic product deflator, but the statute uses the consumer price index. So we're actually using 2 different measures to figure out what the inflation rate change should be, and we'd like to just be able to align that by using the gross domestic product index. So thank you, and we ask you if you can please pass this bill. So we're urging passage of that particular bill. So now, let me move to Senate Bill 1110, which is various revisions to our own statute, and this is extensive, so I do appreciate your indulgence here. So first, for Section 1, it would require us to submit an annual report to the legislature detailing potential Medicaid waivers and amendments that would result in a cost savings to the state. We are identifying this particular issue as duplicative and respectfully ask that it not be passed because we actually already do this through the budget option process. And there already exists an existing obligation through the statute for us to provide any changes that we make to our Medicaid waiver. In any case, that those are always subject to legislative review. So in essence, we are already doing what is being proposed in this section of this proposed change to the section of the statute. So we're just asking that we not make that change because it already exists. Now, sections 2 and 3, we're asking for an alignment with federal rules, and this language can be very complex and not particularly transparent. So just to make it very simple, essentially what we're asking for is that if a cost is reimbursable through a third party through Medicaid, that is just as good as that cost being reimbursable through Medicare, instead of having to have a hierarchy between the two. And that is what we're struggling with now. So we're really asking that change be made. And I'm actually, when you ask questions about this, and I would encourage you to do so, I'm going to actually defer to Matt Antonetti of our legal team to describe it more succinctly and much more clearly than I can. Section 4 makes references to CONMAP. We haven't used CONMAP in quite a number of years, so we're just asking that just be removed. Section 5, and we'll be speaking to this again under another bill, proposes a revision to our CEAP program, our Connecticut Energy Assistance Program. This is actually asking that vendors be paid within 10 days after they received an authorized invoice. It had previously been a 30-day period. Vendors were unhappy with that. We understood why. There was a significant delay in payment, and they identified that as an impediment to being able to run their businesses profitably. We really value the fuel vendors and wanted to make that change. So we're asking if you can support that. Section 6 is actually something that we are particularly excited about, and Guy may speak to it. Wilson, our Medicaid director, may speak to it more directly. This allows us to implement a bundle payment for maternity services, or to use any kind of alternative payment methodology to improve the health quality and health outcomes, particularly when it comes to maternal care. So what we're trying to do here is really move away from more of a fee-based, service-based process for providing maternal care, so that the mother comes in and the doctor or the healthcare provider pays for one thing, she comes in again, they pay for another thing, and so on and so forth. We're really trying to encourage providers to provide a more holistic approach to care, and we think that having this maternity bundle will encourage them to not provide services on a more piecemeal basis, but to really make sure that we're attending to all of the needs of that mother while she is carrying her child and after birth as well. So that is what that section is about. And we are actually finalizing the details of the maternity bundle. And we're hoping that we'll cover more than 40% of the births in the state. So actually right now we cover more than 40% of the births in the state. So we really understand this and really actually have a deep investment in moving this forward. Now, Section 7 removes the reference to emergency housing, repealed by Section 10 of the bill. So let me move on to sections 8 and 9. So what we're asking for here is to align the verification of the availability of any other payer for insurance purposes and for Medicaid purposes, as you would do for any other Medicaid recipient who is documented in the United States. So in other words, right now, if you're on Medicaid and you have any other kind of insurance, we have the right by statute to look at any other payer that might be available to cover the cost of your care. So that could, if you were in an accident, that might be another insurance company. It could be that the person is covered under their parents' insurance if they're age 26 or under. If a person has a different immigration status, an undocumented immigration status, we right now don't have the ability by statute to be able to look for those other payers and to to approach them and to apply for that payment. So we're asking only that everyone that we cover, regardless of their immigration status, give us the same ability to look for and verify possible additional payers under Medicaid to maximize state dollars. All right, so under Section 10, we are looking to establish a health quality improvement program with other departments, including the Department of Children and Families, to improve the delivery and access of health services to children, and to report to the legislature for these findings. So here is the challenge here, however, is that we have already moved from a managed care model to a managed fee model. So we have what we call ASO, which is an administrative services organization. So this particular part of the statute actually is no longer applicable to the department. So we're asking for it to be repealed. Moving on to Section 17B 807, and I apologize for the speed with which I'm moving, but I know that there are a lot of people and we have a lot of legislation in front of you. This particular section of the statute would not allow state funds to be appropriated for special needs benefits for recipients of housing under temporary family assistance to be in anything other than a hotel or motel under the conditions in which they are displaced because of a natural disaster. So we really don't think actually that we're able to limit the use of motel and hotels as a source of emergency housing strictly for natural disasters, because there may be some and man-made disasters. So we're asking that this section be repealed so that there are no obstacles. Families find themselves displaced for any number of reasons. So limiting it to natural man-made disasters really limits the ability for us to be able to provide emergency housing for families under many circumstances. So we're asking that particular portion of the statute be repealed. And so we're urging the passage of our bill in general. All right, so now moving to Senate Bill 1111. This is an act concerning excess nursing home beds and payments for non-patient care in nursing homes. And I will summarize this as quickly as I can. Essentially, we no longer want to pay for excess beds. We really want to encourage the nursing home community to de-license excess beds. They are now paid on essentially a capacity basis. So there's not an incentive to either fill the beds or de-license them. And what this bill is proposing is that there be an incentive to either fill the beds or de-license them, because we will then decrease their A&G, their administrative and general costs, if those beds are not de-licensed within a 12-month period, so that we are no longer paying for empty beds that aren't actually providing additional care and providing more capacity in the system. So that is what that is really about. So it essentially means that we're no longer paying for non-patient care, that we're actually asking you fill the beds or you de-license them, or you will see a reduction of 10% in your A&G costs and payments. Related to this, we would also like to begin, starting in July of 2024, that nursing homes would be placed in a peer group depending on their licensed bed capacity. So this would allow for more fairness in ratings and payments among nursing homes within their peer group. And I know this is actually just the beginning of the work that we're starting to do to align and better determine how rates are paid to nursing homes. So starting with the peer group is actually part of what we are looking for. And actually Nicole Godburn is on, and she'll be able to answer more questions about the peer group. Moving on to House Bill 6587, an act concerning Medicaid coverage for diapers. At this point, we are unable to support the bill because we do not have an allocation in the governor's budget. We do, however, provide diapers for children who are ages 3 or older when those diapers are medically necessary to manage incontinence or that is associated with a medical condition, and it is based on the individual needs of the member. So we anticipate that this would be a significant increase in the cost, and would also mean that we would have to go through the waiver process because it's currently not covered by the waiver, and we don't have any guarantee that would actually be approved as a waiver, and it is not in the budget at the moment. So we are not in support of this bill at this time. All right, so moving to House Bill 6612, an act concerning nonprofit health and human services providers. Essentially, this is a challenge that health and human service providers have brought to the legislature, and I've done it myself on another side of the table many times, which is the ability to retain what it is that they don't spend in the administration of their programs. So the challenge that we have here is that the way in which most health and human services providers are reimbursed or paid for their services is actually sort of an amalgamation or a mixture of Medicaid dollars and state dollars. So that means that we're not able to properly allocate or cost allocate what are Medicaid dollars and what are state dollars, because they're basically just put into one pot and given as a grant to most nonprofits. That poses a significant problem when it comes to allocating that money for Medicaid purposes, seeking Medicaid reimbursement, and particularly for audit. If we can find another way to do this, then we would be happy to have that conversation with the health and human services providers. But currently, the way in which they are paid for their services, it's a challenge. And I'll just read from my testimony so that I can just make that clear. For the DSS contracted services, retention programs can only apply to the contracts that are not otherwise funded or reimbursed by the federal government. And could likewise not apply to programs that are funded with a combination of state and federal funds unless the contract specifically and clearly separates the activities funded under each source. So that is really the challenge that we are having right now. So we're always happy to be in communication. We understand the challenges that health and human services agencies are facing, but we have to be able to have the actual documented costs that have to be converted to the final rate in order for us to properly account for those costs under Medicaid. And we're not able to do that now. And so that is the challenge that we're facing. Moving on to House Bill 6617, an act promoting equity and coverage for fertility care. We actually anticipate that adding care for fertility treatment would result in a significant increase in Medicaid spending, which is not in the governor's budget. So currently, Medicaid does provide some reimbursement for family planning, including the diagnosis, treatment, and counseling of individuals who are in childbearing age. But that is also, it includes reproductive health exams and lab exams, and it can detect the presence of conditions that might affect reproductive health, which include infertility. But the current regulations prohibit reimbursement of doctors for infertility treatments under Medicaid. And actually, this is in line with other state Medicaid programs. And in the written testimony, there is actually a link to other appendices where there are lists from other states. So at this moment, we cannot support the bill. With respect to House Bill 6618, an act concerning medical assistance for certain persons receiving abortion care related services in Connecticut. To summarize, we are broadly supportive of the intent of this bill, but we'd like to work with the committee to adjust the language so that the structure is clear as to how this would happen. So obviously, we are a department that strongly supports reproductive rights and access to abortion care, but we do have some concerns as to the way that the bill is drafted. It's really the scope that we have some challenges with. So we cannot accurately predict the number of people who may come from other states that may seek abortion care. So we also want to know whether or not, so that makes it challenging for us to know whether or not the $2 million that has been allocated is really going to be sufficient to meet those needs. And we don't have any other resources beyond the $2 million in the governor's budget to meet those needs. Second, the scope of related services and the definition of limited access to abortion is not really clearly defined. So we would really like to work with the committee to get some clearer definitions as to what it is that means, because we also know that should it pass, providers are going to also want to know what limited access to abortion means, and we want to be able to be in a position to provide them with some guidance and support. And finally, we're asking that the language that reads that that the department shall apply for a waiver under 1115 of the Social Security Act be removed. Essentially, we're not advising pursuing an application for waiver under the Social Security Act for the reimbursement of abortion, essentially because of the restrictions of the Hyde Amendment that we know prohibits federal funding for abortion except in the cases of emergency and rape and incest, or where the pregnant person's life is in danger. So we would not necessarily be able to secure federal funding under those circumstances. And if we do, it might be very limited. So while we support the bill, we're really asking if we could have more discussion with the committee in order to be able to tailor it so that we can accomplish the goals that have been outlined in the bill. House Bill 6665, an act concerning the governor's budget, recommendations for Health and Human Services, is quite extensive. And I know that we've testified to much of this in front of the Appropriations Committee, and that is a place where many of you were. So I will try to make this as short as I possibly can. Essentially, the governor's budget includes funding for several changes that we think will make significant changes and positive changes for low-income families. So that includes our temporary family assistance, our TFA. We are proposing under the governor's budget to increase the offset limits for TFA from $3,000 to $6,000, and also to increase the earned income disregard. So that would mean that families can make more money under both of those circumstances without having a significant impact to their eligibility. We'd also like to recognize the change in the 2022 session that automatically indexes the temporary family assistance. So that there can be automatic increases that are indexed to the consumer price index for what is now known as urban consumers. Section 6 of this bill also increases the assets limits for what we call SAGA, our state administered general assistance program, doubling that limit from $250 to $500. And we anticipate the cost of that to be between $140,000 up to $140,000 FY 2024 and $480,000 in 2025. We're also looking for a retroactive start date for the state supplemental program. And sections 8, 9, and 10 of our bill hold steady the rate increases for residential care homes and for rated housing facilities. At this point, we're not decreasing the rates, but the governor's budget and the governor's bill does not include any specific rate increases for residential care home and rated home facilities. It does, however, in section 10, allow us to rebase the rates for residential care homes. So as many of us know, the residential care homes have really been experiencing some significant financial issues, and that has resulted in the closure of many homes. So understanding this, actually, the governor's budget includes funding to help rebase the fees for those homes and the reimbursement rates for those homes so that they can continue to operate and make sure that those homes are viable. Section 11 of our bill also holds steady the rate increases for ICFs, intermediate care facilities, not reducing those rates, but holding them where they are. And it does the same under Section 12 for nursing home rates. Nursing homes in particular have received a significant amount of funding through ARPA and through the pandemic. But this bill actually would eliminate the increases over the biennium and instead pivot more significantly to the acuity-based payments that I referenced earlier. So altogether, that would be a net savings of $34.4 million in FY 2024 and $58.4 in FY 2025. House Bill 6701 is an act concerning funeral assistance for persons with limited income. What I will say to this bill is that it's seeking to increase the amount from $1,315 to $1,800. In recent years, we've actually already increased the rate from $1,200 to $1,350. While we appreciate the intent of the bill, there are no resources within the governor's budget at this time to account for the additional cost. And we also want to know that contributions up to $3,400 from other sources are also allowable before the department can reduce or deny any funeral benefit. Moving on to the LIHEAP program, which is covered under House Bill 6703, this bill proposes several changes to the way that our fuel vendor partners that I referenced earlier are paid. So first, this bill actually asks that the time frame be shortened to 48 hours and those payments be made electronically. The challenge that that exists here is that the payments are made by our community action agencies, and many of them really don't have the administrative infrastructure to be able to provide the payment in that quick of a time period or through any other means besides a check. So we are asking instead if the committee would consider adopting our proposal that these vendors be paid within 10 days, because that appears, we have been doing that and that appears to be working because there's a finite pool of money for SEEP. So if we have to increase the administrative costs that we pay to community action agencies in order to pay vendors, then that is less money that we have actually to provide home heating relief. And so we would ask that you just adopt the 10-day period that we had proposed in our bill. There's a second proposed change that would require us to establish a county and regional pricing standard. We are asking that this be reconsidered because we already pay vendors on a regional county pricing standard, taking into consideration the differentials per gallon, which are outlined in our written testimony for FY 2023. And also includes the margins that fuel vendors have speak of. So given that we already use a county pricing standard and we pay vendors based on that standard, we're asking that this portion of the bill actually not be considered because we're already doing that. So we are opposing the second and third proposed changes and ask that you adopt the 10-day time period. All right, so now we're reaching the end. We're coming to House Bill 6775, an act concerning mandated reporters. This one is really quite simple. It allows us to align the mandated reporters that already exist in the Department of Children and Families to our own mandated reporter statute. So we would include clergy and others that are not necessarily already in our statute, so that mandated reporting is the same with other agencies that also have an obligation to protect those that are vulnerable in our population. All right, and finally, I know that you never thought I would say that, but I am. Finally, we are at House Bill 6776, an act concerning passive Medicaid reimbursement determinations for certain aged, blind, or disabled recipients. So we really do appreciate the intent of this bill and wanting to streamline this, but the fact is that actually are already doing this, and I know that we will be providing some updates and some briefings to leadership and to your committee so that you can learn in more detail how we are already doing a number of passive renewals and reviews so that we can decrease the number of people who need to reach out for support and have their questions answered. So we respectfully oppose the bill because we actually already are engaging to the greatest extent that we can, the utilization of wage data and other kinds of income data so that we can renew as many people as possible without having them to be actively engaged in the renewal or redetermination and re-eligibility process. So I really appreciate your time and your patience as I have walked through all of the bills that are in front of you that are either ours or have been proposed by you or your colleagues. And I am going to open it up to the entire team that is on this call today as I continue to bring myself up to speed on the details of these issues so that we can answer your questions as thoroughly as possible. And I thank you again for your time and your patience.
Thank you, Commissioner, for a thorough testimony. But like you said, there were so many bills, so I really appreciate it. And my only comments are I look forward to following up and working with you all on the community health workers, the abortion care, and the LIHEAP. As well as others, if you have questions. I am going to go to Senator Lesser.
Thank you. Unfortunately, Madam Commissioner, I am not as succinct as my co-chair, so I got a few questions for you.
That's fine. I answer as best I can.
And I know we've got a lot of people after you, but you did cover a ton of ground. So first, the Covered Connecticut program. My understanding is that currently there's a lapse in the program, plus the governor has proposed to increase an appropriation to the program, plus the governor has also proposed in his budget to allocate, I think, $10 million to cover the first 2 months of premiums for the expansion population that is, currently envisioned by that bill. Is that all correct?
That is all correct. I'm also looking at Guy. Guy, did you want to weigh in at all in response to the senator's question? Okay. Yes, it is correct. Yes. Okay. I guess that is the way yes, it is correct.
Sorry,
yes.
You couldn't hear me. I was saying yes. Sorry about that.
Yes, it is correct. Yes.
Yes, Senator.
Okay, phew. So I want to say I heard you loud and clear about the uncertainty about future federal funding. They extended it for a few years, but we don't really know what the landscape is going to be. I know that other states that have attempted programs like Covered Connecticut, and by the way, congratulations to the department for securing the 1115 for that. That has been huge. Have the legislatures have offered some flexibility to allow reprogramming of funds, state funds if federal priorities change or if there are new pockets of concern. I think that's what we were trying to do with the new step down. But I'm wondering if that's a type of approach that we would be well advised, with Covered Connecticut to take, to allow you to target available, state matches to particular areas of concern for exchange support.
Yes, I think that's your Dean. Go ahead. I see you wanted to come off mute.
Yeah, no, I agree, Senator. And just to clarify, the comment in the commissioner's testimony on, I know you know this, I'm just saying this for others, the CMS approves 1115 waivers for a fixed period of time. And we were just merely reporting the fact that they've approved the initial waiver for 5 years, as they do basically all waivers. And there is legit uncertainty, right? The Biden administration is very in favor of expanding coverage, but there's legitimate policy uncertainty around the future beyond that 5-year period. And that's all we wanted to communicate there.
Great, thank you. I appreciated your testimony on community health worker bill, and I think as Representative Gilchrist said, I would appreciate the ability to continue to work with the agency to hone that language and find a way to design that in a way that works for the agency and move that forward. With regard to we've gotten a lot of questions about the acuity-based transition from nursing homes, and specifically the concern they've had is how to pay for it. And it seems that the department is looking to pay for it with a lapse of funding. And I just wanted to see if you had seen the comments we'd gotten from our nursing homes, and if you had any response to the concerns they've expressed there.
Thank you, Senator. No, I have not seen the comments. If there are any that your clerk would like to forward to us, we're more than happy to review those so that I can provide a more comprehensive response.
Okay, great. That would be great. And we can have that conversation going forward as part of the budget process. With respect to the new maternity bundle, we did get some opposition from the Hospital Association. One of the things that I know that this committee and others have been looking at is the real shakiness of labor and delivery wards, and especially in our rural areas. And just wanted to see if you had done any analysis or any concerns about, I'm not sure exactly how that's going to work rolling out, and just want to understand better what we can do and what tools we have at our disposal to ensure that that mothers have access to to high quality labor and delivery services near where they live.
Yeah, you look like yeah.
Great, thanks, Commissioner. I never want to jump in.
Yes. No, it's okay.
It's a good question. We received a letter from the Hospital Association and have spoken with them, so we're certainly aware of their concerns. I will point out the maternity bundle focuses on the OB providing kind of the baseline care. It's not actually targeting the delivering facility. So if I have an OB in my neighborhood in New Haven and then deliver at Yale New Haven Hospital, it's not impacting the payments that we're giving Yale New Haven Hospital, and that's in part because of the hospital settlement and other things, right? Those reimbursement rates are fixed. So I won't speak for the Hospital Association, but when I read their letter and think about their concerns, I don't think their concern is about the maternity bundle in particular, because it literally doesn't impact hospitals. I take their concerns to be more general, kind of theoretical concerns, but I certainly won't speak for them. And we would welcome the opportunity to answer questions that they or others may have. But I just wanted to clarify, the maternity bundle does not, it's not directly impacting hospitals.
And maybe I'm misunderstanding this, but when we're asking the hospitals, why are you discontinuing labor and delivery services at some of our smaller hospitals, they keep citing the shortage of OBs and other providers as an issue. So I would imagine that if it, I have a question, I don't actually know if this would exacerbate that issue or address it in some way. I don't want to pick on Representative Johnson, but if there's a shortage of OBs in the Windham area, how does that how does this impact that, and does that have some sort of ancillary impact on the ability of Wyndham Hospital to provide those services?
Yeah, no, it's a great question, and I would love to talk directly with the hospital association. The maternity bundle, the policy is not to squeeze money out of the maternity delivery system or anything like that. The policy is to try to give OBs incentives and tools to care holistically for their patients. So I'd have to think more carefully, and would love to hear their concerns, Representative Johnson's concerns about any indirect or knock-on effects. But the baseline effect is holding payments fixed for maternity care and changing a little bit how we pay. But this isn't a backdoor rate cut or anything like that. It's very much trying to change those incentives. But I would love to continue the conversation, hear the concerns.
Great, thank you. And then with regard to the Innovation Incentive Program, listened, Commissioner, to your testimony in opposition. I just would say that, this is current law. We did pass this, and OPM has directed agencies to administer it. Just specifically with regard to the legality concerns, can you point specifically to the CMS regs or the terms of the home and community-based waiver services that the waiver that would prohibit?
I'm not sure I understood your
So
question.
you indicated, as I understood your testimony, that that we needed to segregate Medicaid funds from state funds, and so that's why I was curious if you could, so we can understand this, because obviously this is current law. So if there are specific CMS regs or waiver terms that prohibit us from, that require that would be helpful, so we can understand what rules apply.
I will get those for you.
Okay, great.
Yes. Okay.
Can you give us a quick update, because with regard to, I understand that last year the department was looking to bring residential care homes in under Medicaid, and now seems to be backing away from that. Why is that, and where do things stand currently?
I see. I apologize for my newness. I'm going to defer to Guy. Yeah.
And Bill, Bill Halsey, who's the deputy director, has been leading this initiative. So Bill, if you wouldn't mind chiming in on the challenges as we thought through it and the whole process.
Sure. Good morning, Bill Halsey from the Department of Social Services. So that was the plan. And once we started analyzing moving from our current payment to a Medicaid fee-for-service payment, what started to occur is that it started to affect individuals' state SUP accounts. And all of a sudden, we were potentially altering, modifying, adjusting, lowering the state SUP amount that individuals were going to receive if we moved some of this funding over to Medicaid. And that could potentially also impact their Medicaid eligibility. And once we started down kind of that line and understanding how this would potentially negatively impact a resident of an RCH, we said that we were pretty sure that was not the intent of what anybody wanted to do. And we felt the cleanest way to do this was to enhance through state funding.
Thank you. On the LIHEAP bill, I have a question. So we're trying to have a sort of an iterative dialogue with action agencies about what's not working and where things are working. And one question, and I've been in touch with DSS on this, one issue that I've heard from is that currently your online intake form for LIHEAP doesn't talk to the action agency's internal software, and so it has to be manually entered in on the other end, and that's a big bottleneck. My understanding is that DSS is working to fix that, but it seems to be a continual concern for the agencies, and just didn't know if there's anybody on who could speak to that update, and if that's when we can address that, because in the year 2023, people shouldn't have to be manually, typing and retyping.
Right. No, I understood. Peter Hadler should be on,
Yes.
there he is. Okay. And I think Peter can address your question, Senator.
Thank you, Senator Lesser. Hi, I'm Peter Hadler. I'm the Director of Program Oversight and Grant Administration at DSS. It's a good question. We just launched the online application last year. It was the first time we opened up an access channel for state residents to be able to apply for energy assistance through a channel that I think many people expect that we should be able to offer to households. In that first iteration of the product that was put forward, we made sure that we would be able to collect the vital information that people needed to be able to get an eligibility determination. But the rules for the system still reside in the community action agency's systems. So we would pass the information collected through on the application to them. It does require data entry right now because it is two separate systems that need to be built to talk to each other over time. I would just note that it is not different from receiving an application in any other channel for the community action agencies, whether it is a paper application or a walk-in. You still need to put the person's information into the source systems. We are working on automating that process. We understand that there are substantial administrative efficiencies to be gained by passing that information through. We are currently undertaking a second phase of development of that online application, which also includes, and actually we've already implemented a very important component, which is matching the person's income against DSS enrollment data. So we're taking a step out of the process that is normally required for other forms of applications for energy assistance. We're able to automatically verify that a person is income eligible for the program based on their enrollment in a DSS program such as SNAP. So the next phase does include a lot of enhancements to that process. And this is a new developing application channel, and we are definitely working on streamlining the passing of information through to the community action agencies as well, understanding that that has efficiency gains for everyone. So I hope that answered the question, and happy to answer any other ones.
Thank you, Peter. That's very helpful. And thank you, Commissioner. And just lastly, on passive redeterminations, hear you loud and clear. I just want to say that it seems that you've done heroic effort to try to get that up and running. We obviously have, maybe not obvious, we have continued, interest in the Medicaid redetermination issue, and want to make sure that we're doing everything we can in collaboration with Access Health to handle it as best we can going forward. So just want to thank the department for its efforts so far. They've been noted and are really impressive. Madam Chair, that's all I got for right now, but I probably have another 40 questions up my sleeve somewhere else.
Thank you very much, Senator Lesser. Representative Dathan.
Thank you very much, Madam Chair, and thank you so much, DSS and Commissioner, for your testimony today and bringing your whole team. It's really appreciated. There was a lot to go through, and I'm still sort of processing it all. Wanted to talk first. I didn't see any testimony on 208 about the free transportation, access to low cost of free transportation for persons with disabilities. Just wanted to kind of find out, I know we're currently using VAO in our state and we've had some issues. Would love to hear from your team sort of what your thoughts are in expanding that. I do understand that, some municipalities provide transportation through other means outside of VAO, but just wanted to get your opinion on that. And I also wanted to find out exactly how much, if anything, the feds match on that sort of transportation cost.
Thank you, Representative. I will start and then ask other members of my team to join in. So with respect to VAO, which has been acquired by another company, so now it's known as MTM, that contract is currently, well, actually it's more than out to bid. We are in the tail end of the procurement process and have final interviews with the final vendors and should be able to make a decision on that really within the next several weeks. That is really our goal. We are always in support of expanding transportation options for the people that we serve. Specifically, obviously, it would depend on the resources that we have available, but I'm going to ask of our team, I think you'd ask about the cost. I'm going to see if I think I saw Nick Vendetto on and another team member that might actually be able to address the cost. So if I can ask somebody to come off mute and address the representative's question, that would be wonderful. Whoever that right person is.
Commissioner, this is Bill. I'll at least address one thing. I think Representative Dathan, I'm not sure it was 100% clear that that bill specifically spoke to transportation to medical appointments. So
I think it's both, actually. And that was, I would understand that if it was a medical appointment, that it would be covered by Medicaid.
Correct.
But my question is also outside of medical appointments, is there any matching by the federal government?
At least under non-emergency medical transportation, it has to be to a medical appointment.
So if maybe you were talking about somebody, and I know this isn't your area, but let's say you were somebody that was not, we're not talking DSS, this might be DDS, but if you had somebody who was trying to get to their job or their other thing, would that sort of be covered at all?
That would not be covered under non-emergency medical transportation.
So non-emergency medical transportation is covered at a match of 50%. Is that correct?
I know Nick is on and maybe can jump in on the match.
Hi, thank you. Nick Venditto, Department of Social Services, Chief Financial Officer. Actually, the match rate depends on the coverage group that the client is eligible or the member is eligible for under Medicaid. So for the majority of our Medicaid members, our Husky A and C groups, they would be matchable at the normal base level of 50%. For our newly eligible Medicaid expansion group of what we call Husky D, for those newly eligible individuals, the services are eligible for a 90% match.
Got it. Does the department do any analyses of the where the MTM or VEO or the prospective vendors operate so that we can ensure that no matter where folks are in our state, that we would be able to get them to their necessary appointments? Is that part of your
Yeah, so that's an essential part of the contract, and it was, as you know, part of the challenge we were having with VEO, now MTM, is that there were certain criteria and requirements within the contract that should have made them available, right? Should have made transportation available throughout the state, but we found that there were pockets of the state, and I can get you specifics, where there wasn't as much availability as had been promised under the contract, and also not as much reliability, and reliability was really continuing to be a challenge. So we heard very clearly that those two issues needed to be addressed, and so we are very hopeful that the new vendor, when they're selected, would be able to do that. So Representative, now that you're speaking, I think I'm recalling the bill that no, we did not offer any testimony on in this session, but I think we did offer it in the joint session with the Department on Aging. And I believe that was a testimony. I think it was a bill that was looking for a pilot, I think it was pilot money or a pilot grant for transportation outside of non-emergency medical transportations that would, in essence, provide for an opportunity for those who needed transportation to get out into the community, for socialization, for attending church, for, just being a whole citizen in the community. That transportation, as Bill Halsey said, is not covered under Medicaid. But I'm very familiar with that. If, for example, to use your example, you are with a DDS agency, let's say you're living in a community living arrangement, then the staff at the agency would help, or family members also would help facilitate that integration into the community. And depending on the person's level of independence and comfort, they would also be able to access public transportation to get where they go. So that all depends on the person and their individual circumstance. Now, understanding that as people age or their health and other circumstances change, their needs for socialization and activity in the community may change, but that desire to be part of the community doesn't change. But we don't really have an ability right now under the Medicaid rules to reimburse that non-medical transport into the communities. But we're happy to have more conversation about how we might be able to do that within the resources we have available. But we don't have anything right now that would be covered under Medicaid.
Okay. As part of your process, and how do you evaluate your medical transportation providers? Do people do a real-time survey after the ride, kind of like an Uber type thing where you give your driver 4 stars or 5 stars, depending on how great they were, or 1 if they canceled on you? Is there any sort of real-time feedback that members provide so that we can ensure that we're getting quality service? Because I know we've had a lot of issues with different providers, and we've already had 2 providers in my tenure. And so I'm just concerned that we just keep kind of vendor hopping, and how can we ensure that we have a long-term vendor that is going to be sustainable in our state?
Well, we share the same desire, and there are quality measures. I can get you the specific quality measures, but some of them are spontaneous, as you mentioned. You know, we get feedback about an excellent ride or a poor customer experience. Often they will call the commissioner's office if there's a poor experience, and we'll hear that directly. But I can get you more details on how we actually measure quality. In our new request for proposal that had issued in the final vendors that we have, there is a specific emphasis on reporting, accountability, and quality. But I will also be honest with you, Representative, because that is just my nature. This is a very limited field. So it does appear that we are hopping, and that is because there are very few vendors that actually work in this space. So, you know, while we are really hoping for a much better experience with our current vendor, we may experience some of the same challenges as we get them up to speed, but they do know that there is a very bright spotlight on their performance in this state, and we absolutely plan on holding them completely accountable in the ways that you had defined. So we too are very clear about what our responsibility is and how dependent people are on making sure that that service is dependable.
Thank you so much. And I appreciate that. I am looking forward to hearing more about that transportation because it is so important. Just one last question on transportation. Does the agency utilize any sort of Uber or other sort of share peer, I forgot what you call those.
Ride sharing. Yes.
Ride sharing.
Ride sharing. Yes.
Do you utilize those services for medical appointments if the medical provider isn't able to do anything?
We currently do not, and there are a number of reasons. We need to have a more formal contract. We need to be able to assure the safety of the individual and also be able to know that the person who's providing the transport has had appropriate background checks that meet our standards. So it isn't as if it's an impossibility. And I think I read anecdotally, and please don't hold me to this, that some states have actually pursued that as an option, you know, much larger states like Texas and California, or because of just the vastness of their state, they've had to find other ways to do this. So we are exploring that. And I do remember that Representative Case said, and I believe it was at the joint hearing, that the Department of Children and Families has also started some form of their own transportation because of the unreliability of other services. I've made a note of that. I have not had an opportunity to explore that with the commissioner, with Commissioner Durantes further, but we're doing that as well. So we're starting with what we know. And I think that is because we are an agency in transition, particularly with respect to senior leadership. So that would be me, you know, our 2 deputies, and who are both in TWR status, to just stabilize transportation as it currently exists, and then make a commitment to explore other options so that we can provide a wider array of services and have other alternatives, because we think that's necessary too.
Okay, thank you so much on that. Sorry for more questions, but in SB 978, I'm just going to
Would
Yeah.
I be able, would you be, so we are at the hour mark, and to be respectful of the 145 people we have signed up, I would ask committee members to ideally limit to 2 questions and then follow up with folks who are testifying after the fact. So I am going to move on to Representative Mastro Francesco, and I'm just hoping that Representative Dathan, you can follow up with the commissioner afterward. Thank you.
And
Representative
Representative, would it be-
Mastro Francesco, go right ahead.
Thank you, Madam Chair. Madam Chair, I understand that we have a lot of people that want to testify today, but there's a lot of bills on this agenda today. And this is our only opportunity to ask questions. I don't know when we will have the other opportunity to talk with the commissioners about in public about these questions. So just a point of, I just want to say, I just think it's unfair that we're only asking 2 questions. I probably have 10 questions. Ugh. I guess that, thank you so much for your, I thank you so much, Andrea, for your testimony. I appreciate it. There's a lot that you talked about. My particular questions are on House Bill 6618, the abortion services for out-of-state people.
Yes.
Can you tell me
yes.
right now, how much does the DSS spend on abortion care, right, and abortion services under Medicaid? Do you have that answer?
I don't know if I can answer that. I'm not sure if anybody else in our team can. Nick, do you know if we have that number for the representative? Or we can get it?
I can certainly get that for you, actually, probably in just a few minutes. I don't
Okay.
have it right now.
Thank you.
And when you respond, can you send that to our clerk, Chandra, so that the entire committee can have it? Thank you so much.
Sure.
And I'm just curious right now, I'm assuming that Medicaid covers 100% of, I mean, the state portion of it covers 100% of those services. Does the state also pay for abortion services for undocumented immigrants?
As far as I know, I'm not certain. Guy, would you mind answering that question? I'm still learning, Representative. I'm not trying to be evasive, but I want to make sure you get accurate information as I get up to speed.
I can, Representative, and just I'll answer your question, but just one quick note. You're right that with our abortion services, we pay the state covers all of the abortion care. We don't request federal matching on the abortion care that we provide, and we offer the same there's not a carve out. We offer the same benefit package for all of our members, including regardless of immigration status.
Okay, and so would you be able to get me numbers of how many people are citizens and undocumented? Would you have that broken down?
I can, I think we can, Peter. I think we can get that. I think it's gonna be very small, just given the age group of undocumented immigrants that we cover, right? It was 13 and grandfathering up. I suspect it's 0 right now, but we'll follow up, either saying we can't get it or we'll explain why we can't.
Thank you. And I apologize, Madam Chair. I have a few more questions. If you want to cut me off, you certainly can do that, but I just have a few more questions if that's okay. I guess there's some concerns I have about this bill, obviously. So if somebody comes, and I know in the governor's bill, he allocated $2 million for abortion services. If somebody comes into the state of Connecticut and changes, and I'm assuming the travel is paid for. That's what I understand. Part of the governor's bill is that the travel portion is paid for.
Correct.
If they
That's
come
correct,
into
Representative.
they come into the state, I guess I want to know how the travel is paid for. Are they paid for up front? Are they reimbursed? Should somebody come into the state and decide that they change their mind? Do they get reimbursed, and do they get travel money to go back home?
Right. So the bill isn't specific about the mechanics. That would be left up to us at the agency to determine that. Our preference is to do it on a reimbursable basis. But we also recognize that some of the women who may be coming to seek abortion services may not be able to afford. So we would have to determine that. But primarily, we would like to provide it on a reimbursement basis so that we know that the exact cost of the travel, and that we don't have someone coming in with travel expenses that would exceed what we would consider reasonable for those expenses.
Okay, thank you. And the state of Connecticut has a state-of-the-art healthcare facility here in Connecticut. your portion of the bill or this committee bill only covers for abortions, and there's something in there about related services. So if somebody wanted to come to Connecticut to get other services, maybe to save the life of a child, would that be covered?
Not that I know of as the bill is currently drafted, but I can certainly find out more for you. It's specifically for accessing abortion services.
So it's just for abortions. And should complications arise during that procedure, what would happen? Or is that covered?
So that is an excellent question, not specifically as defined in the statute, but if complications arise, let's say that an individual goes to a healthcare facility, I won't name them specifically, and they're undergoing the procedure, and let's say then they need hospitalization. I think that's what you're referring to, or is that what you're alluding to? What would happen? So that provider then obviously would have an obligation under their license, right, and their oath and obligation to move that person to a facility where they could get care. And then we'd have to determine how we would pay for the cost of that care. And that is why we're saying that the $2 million wouldn't necessarily, because if you have several people that need that care, we know that hospitalization can be quite expensive. So that's why the $2 million in care may not necessarily cover everything, which is why we needed some more clarification. But we wouldn't deny anybody the ability to receive care because they have to move from one facility to another.
Thank you, Representative Mr. Francesco. I am going to move on to Representative Case. I just want to say to all the members of the committee that part of our role, we can reach out to the department. That said, if members of the committee want to submit questions to the good chair and I'm happy to then send those on behalf of the chairs. We can do this in a variety of ways, but we do have so many people signed up that I'm going to move on to Representative Case. Go right ahead.
Thank you, Madam Chair. I just want to reiterate, we had a senator and a representative stand here for a good 10, 15 minutes asking questions. I think it's unacceptable that we are not allowed to do that, but I understand. Thank you.
Good afternoon. I do understand the time constraints, but I happen to agree with Representative Francesco. Our two first speakers or questioners asked multiple questions, and I plan on asking multiple questions myself. Commissioner, I want to get back to MTM and VEO, and it was a very long process in the past few years. I want to make sure that process is still in place. We worked with Kate McAvoy at the time and Representative Abercrombie. I want to make sure, because the only way we know if there's problems, we hear there's problems from people talking to us. But the way we get the problem solved was the problems come to us, they go to our aide, an email goes to the company and also to DSS. Is that still happening?
Still happening right now. So we are aware of some of the problems that we're having still with VEO, or actually MTM. They are, so, yeah, that's a recent acquisition, so I apologize for continuing to refer to them by their prior name. And then part of that challenge is, part of the challenge that we have with MTM is exactly what you defined, is that we want the vendor to have more of a direct communication with us rather than have sort of this roundabout way of letting us know what's going on. But part of that representative case is for us to figure out inside the agency how we can have a more proactive approach with that vendor. So, my philosophy in managing vendors, and the vendors that I've worked with will tell you this, is that we meet with them frequently so that we're holding them accountable, whether that's weekly or bi-weekly, so that it isn't a matter of them just, of issues just sort of popping up and we don't know about it. Because the way that I'll just put it a different way. I believe that if you're spending dollars, state dollars, federal dollars, it doesn't matter, right? It's taxpayer dollars when we're in state government, then you need to be accountable to that. Just because you are the winning bidder of a contract doesn't mean that all of a sudden you don't have any responsibility to those of us who are paying the bills, right? And that's all of us on this call, all of us who are taxpayers, and all of us who are supporting those who are receiving the benefit and the services. So my intention is to have that process work differently based on the way that I have managed vendor relationships in the past.
And I agree with you, Commissioner, and I thank you for that, because in the past, the vendor before this, we had even more problems with, and we didn't have the open communication. So I think when we sat on that 7th floor or whatever over at DSS, I'm not sure what floor it was, but
I think it was the 7th. Yes.
We had a very distinct meeting that we encouraged people to write into us or to call us so that we could reach out to the vendor, but have that email chain go to you also, so that there were no complications of the vendor, oh, we didn't hear that, or DSS, oh, we didn't hear that. So I think that's what brought a lot together. I hope we can do this. And as you said, there are very few vendors that can handle this type of transportation throughout the country. MTM right now, I believe, in doing research, is in 33 different states.
Indeed,
But
they are.
it is also what we have to look at. It is a driver shortage. And there's also differences now between what cab drivers can do as far as certification of what transportation can be done. And during COVID, there was also some drivers who backed out because they didn't want to drive if it was a COVID positive, and they didn't know what if the person was or wasn't. So there are a lot of things to work out, and I think you'll be great. We'll work with you on it. I'll leave it at that, but it's something that we worked very hard on to make sure, because if we don't have that communication level, we're never going to get a provider that's going to satisfy anybody.
You're right.
So I agree with
Yes.
you. So let's work together on that.
Yes.
I'll try to move very quickly. So you talked a little bit on 6701. So back in the day, I've been here a little while. It was 1800. We moved it down to 1200. Now it's back
Okay.
up to 1350.
Yes.
When you look at it and you go forward and you actually have a cremation, back when they moved it to 1200, that was $9.99 to do the cremation. Now that's gone up to almost $1,300. So the covering the cost of actually doing the cremation for the indigent person, this was 1,800,
I
and
see.
it got bumped down to 1,200 with the Malloy administration.
I see. Okay.
So that's where a lot of us have questions on it, and this is where it's an appropriations issue. We just want the good help from the funeral homes. They're not making money off of this. They just don't want to lose money off of this, because they
Understood.
still have to transport the body from the medical examiner or from wherever it is, bring it to the funeral home, bring it to the crematory, and then do with the ashes. So that's the reason why this is here. Just trying to make the funeral homes whole. I mean, you went from 1,800 to 1,200. So that's a little bit of what I remember being on appropriations, and I don't wear that hat anymore. So
Thank
and
you for that.
I'll
That's very
answer
helpful.
one last question, and it's on 6703. And I'm not sure if you realize, but with the low income home energy, you realize that Operation Fuel has suspended for 1 month.
Oh, yes. Yes, Representative. I'm very much
Operation
aware that
Fuel is having trouble because they have so many people, over 7,000
Yes.
households right now that are
Yes.
coming in. That's not our low income assistance. But you also have fewer suppliers. And if you do the research and you look at it, when is the last time the state of Connecticut suppliers have seen an increase? We have an increase. There is an increase of costs that go to these suppliers that is unbeknownst to us. There's going to be even a higher increased cost because of the hut tax coming forward, because the fuel has to travel so far on tractor trailer. So I think what people are looking at is, Operation Fuel is feeling the pinch right now. I think we're going to be feeling the pinch. Where are we at with dollars? Do we know right now as far as energy? We've had a mild winter, but I think people are still burning fuel.
They are. Peter, do you mind answering the representative's question?
Sure. No, I'd be happy to answer a couple of those questions. Representative Case, we are currently doing okay on funding. We have funding in the Connecticut Energy Assistance Program, and I know that while Operation Fuel has suspended their services for a month, we are not suspending our services. We are available, and we understand that Operation Fuel can assist some households that DSS can't. But I do want to emphasize that if people are in need of energy assistance, they do try coming to Energy Assistance Program, because we still do have funding to provide to households. We can certainly give you a current update on expenditures to date. We did just receive an additional round of federal funding for LIHEAP. Another $19.6 million did just arrive. I know we've been accounting for it all along, but it's in hand, and we are prepared to be able to serve clients as they come in. We do anticipate that we'll be able to serve the full volume of clients under our current projections that have come into the agency. Just with regards to the vendor payment amounts, we increased the margin over rack last year from 35 cents to 45 cents. We moved it up to 50 cents this year. So that is a quite substantial increase to account for some of those costs that deliverable fuel vendors have been incurring related to labor and other costs of their business. It doesn't necessarily leave a giant profit, but it is a significant amount of money that we have adjusted, and that's on a per gallon basis. So we're up 15 cents per gallon that we provide to the deliverable fuel vendors. We have very good participation this year. It's only slightly down from last year, but it is sufficient to cover the full geographic range of the state. And we haven't encountered problems with being able to do deliveries. And we also have made some of those changes that were alluded to early in the testimony about ensuring that payment is getting to them faster. We have asked that payments be delivered within 10 days and are supportive of making that change at a statutory level as well. So I hope that answers some of your questions, and happy to answer any others about LIHEAP.
Always does, Peter. Nice job. Thank you. And I'll leave it, but we look at Senate Bill 2008, which is access of low cost and free transportation. I just want to make alert that we're going to come into a cliff because the free busing is going away April 1st. We have packed buses right now. A lot of those are people with DSS. A lot of those used to get coupons to ride.
Yeah.
April 1st, when there's no transportation, and we barely have any transportation in the northwest corner, those transit districts, DOT, I don't know what we're going to do. So people aren't going to be able to get around as they are right now. And they're mostly the people in our catchment areas that we all work so dearly to make sure they can get where they need to get. So just something to keep on your radar. I know it's a federal thing that if we don't have busing, if we don't charge for busing for 365 days, that there's possibility of losing federal funds, and that's why it has to kick back in April 1st. I was hoping we could have a ride around on that, not on the bus, but work through the agency to see where we can try to make up some of the differences, because transportation, not only for our catchment area, but for our disabled people, is huge. So I appreciate your time, and thank you, Madam Chair. I hope that was quick enough.
Thank you, Representative Case. Representative Johnson, go right ahead.
Thank you so much, Madam Chair, and thank you so much, Commissioner, for your work and your testimony. Just quickly, there was some mention by Senator Lesser about the Wyndham Hospital and maternity and delivery issues. This is also in the northwest corner. This is also a problem at Day Kimball, perhaps, and then later on with Johnson Memorial Hospital. And the more rural areas we're in, they are the hospitals, the associations, the ones that are more monopolistic, let's say, are withdrawing from that type of service. And they have a process that they follow, which is they get rid of the critical care units or the ICUs and those hospitals first, and they watch diminishing of care from the doctors. It's happened over a 5-year period. The same thing is being proposed for Sharon Hospital in the northwest corner. And so we have a situation where we can see the handwriting on the wall. When they get rid of the ICU, then they go for maternity and delivery. And then I have a question that I've given to the Hospital Association on what their regulations are and how they plan to actually define what a hospital is. But that's beyond the scope of this, and I'm going to cut it short now. And I will write some questions to you. Maybe we can have a meeting about how to do that after we get the Hospital Association's rules, because they're the ones that make the determination as to whether or not a hospital is really a hospital. Thank you so much, Madam Chair, and I'll leave it at that and write some more questions.
Your representative.
Thank you, Representative Johnson. I don't see any other hands. Thank you so much, Commissioner and team. And again, I'll reiterate to all committee members, if you have any interest in having Senator Lesser and I submit questions over to the department, we'd be happy to do that. Thank you so much for your testimony today.
Thank you very much.
We have hit our hour mark, which means we will now start to go back and forth between the public and state officials. And so we are going to go to Mike Van Lenderen. Yay, I did it. All right. You can sit anywhere. You do have to push the button, and then the public does have 3 minutes to testify.
Oh, there you go. Can you hear me? All right. Representative Cook, Representative Gilchrist, those of you in TV land, thanks for allowing me to testify today. My name is Mike Van Valanderen. I've worked for Reliance Health for the last 31 years. We're a community-based nonprofit organization in southeastern Connecticut, but we serve all of eastern Connecticut. I'm here to speak today in favor of passage of House Bill 6612, specifically about revenue retention and indexing future funding for nonprofits. And shout out to Senator Lesser for pointing out to the commissioner regarding her testimony that this is partly already in legislation, especially in regards to the revenue retention. But we've either seen it not enacted or the agencies have had to jump through hoops to show how they're going to spend the excess dollars. Just really quick, I want to just walk through the funding for nonprofits for the since 2007, for those of you who may be new, or for those of you who just want to hear it again because we enjoy reliving it. From 2007 to 2017, we saw a zero increase in funding for the nonprofit sector. In 2017, there was a 5% clawback to help balance the state budget. Over the last 2 years, we have finally made some headway, and with the Appropriations Committee, which has been very supportive of us, and we hope that they're as supportive this year. But again, it didn't keep pace with inflation or the consumer price index. So as grateful as we are for the increases over the last 2 years, it has not kept us whole even for the balance of the last 2 years. So revenue retention is extremely important for us, and indexing is extremely important for us. The challenges that we face are that we are now dealing with anywhere from a 40 to 60% shortfall from our 2007 budgets, depending on which you use, the CPI or the inflationary budget. And I know that one of my colleagues is going to point that out later on. So thank you for allowing me to testify. Thank you for getting us in early for those of us who braved the storm. I greatly appreciate it. And please really consider supporting House Bill 6612. Thank you.
Great, thank you. We do have a question. Representative Case.
Okay.
Thank you, and thank you for coming in. Hey, so we did legislation as far as the clawback. Did that affect your nonprofit at all?
I'm sorry, say it one more time.
We worked on legislation, I believe it passed, on the clawback of leftover dollars.
Yes. And my understanding is it's passed, but it seems to have gone through some sort of Rube Goldberg machine of us trying to hold on to our dollars. And I'm not sure where the disconnect is. Did I answer your question?
Yeah, because the bill came through Human Services and we worked hard on it, and it was the clawback was to allow nonprofits to keep the dollars as long as it was used for capital and not for employee benefits, wages, or any type of salary related stuff. So we're hoping that that's where things started, and because the money has already been budgeted for the nonprofits, so why not keep them but use them in a capital way?
Agreed. And just to sort of piggyback on your thoughts, even increases that have been appropriated by the Appropriations Committee, for instance, last year, we're still waiting on 2.5% of that funding. I mean, we're already talking about what's going to go into the biennium budget for the next 2 years. We haven't even received our full allotted dollars from the last year's allotment.
Thank you for coming forward and putting that to us. And I think good Chair and myself, maybe we'll have a conversation and see if we can get some answers on that 2.5%.
Thank you very much. Thanks for everyone's time.
Thanks, Representative Case. Thank you for being here. Next, we'll hear from Sarah Egan, the child advocate. She's on Zoom.
Good afternoon to the Human Services Committee. My name is Sarah Egan. I run the state's Office of the Child Advocate. My children are all home from school today, as I'm sure many others, and they have been quiet for a long time. So I hope they continue to be quiet. I don't know. I wanted to testify on a couple of important bills before you today. I'll start with the bill that the gentleman before me just testified on, 6612, which is ostensibly about increased funding for the nonprofits. I don't want to comment specifically on the clawback provision, though. I echo what you'll hear from testimony throughout the day, but we are still facing a dramatic behavioral health crisis across the board, as I'm sure all of you know, across the country and in Connecticut, we have dramatic workforce shortages. Our kids are still struggling significantly with unmet behavioral health needs. And a huge part of the problem undergirding the behavioral health crisis is the persistent lack of adequate funding for children's behavioral health services and the nonprofits. I know the legislature has been working at this and committed to increases for the nonprofits. But as we go forward, more investment is just absolutely needed. Every single week at the Office of the Child Advocate, we hear from families, family advocates, providers about children that can't access the services they need in a timely manner. This includes children in crisis, children leaving emergency departments, children sitting in emergency departments, children waiting for intensive in-home services, children leaving inpatient hospital stays. I was recently informed by a number of providers that the waiting list for one of the go-to in-home mental health services for children, ICAPS, is, as one provider told me, infinite. And as the manager for that program at Yale told us, there are over 500 families on the waiting list for that service, with certain regions of the state and London, Wyndham County no longer to even able to provide it at all. And that's about workforce, but it's also about investment and the dollars that the nonprofits have to be able to provide services to children and families. Our testimony does include some recommendations for the committee to consider. What we really need is a way of funding services, both through contracting and Medicaid, that is based on, has a relationship to the cost of actually delivering the care. Only then, only when we close that gap, are we going to really be able to provide timely access to services that children need. A comment on the bill 6587 about Medicaid coverage for diapers, which the OCA strongly supports and echoes the testimony from several proponents today, which is that diapers are a basic hygiene and health need for all children. And we know that a significant percentage of families in Connecticut struggle with their week-to-week bills. The Connecticut Diaper Bank estimates that about 30% of families struggle to afford diapers. I will point out that just submitting testimony, I'm sorry?
Could you summarize, please?
I can, yes. Thank you, Representative. Testimony from about a dozen different healthcare organizations in strong support of this bill, and the Office of the Child Advocate is among them. Thank you for the opportunity to testify. I'm happy to answer any questions.
Thank you so much for being here. Any questions or comments? Yes, Representative Master Francesco.
Thank you, Madam Chair. Thank you for your testimony. I'm just curious, can you tell me right now what the state is spending and giving to the diaper bank? Do you know that answer?
I actually don't, Representative. I'm sure I see that they're testimony later today. I'm sure that they know. I don't know what the allocation is for that.
Okay, thank you. I just had that quick question. Thank you, Madam Chair.
Thank you, Representative. I don't see any other hands. Thank you so much, Ms. Egan, for being here and for your work.
Thank you.
Next, we're going to go to Carrie Dyer.
Good morning. Morning, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Cook, Representative Pizzuto, Representative Case, and members of the Human Services Committee. Thank you for the opportunity to provide testimony in support of House Bill 6612. I'm not as good as ripping, so I'm going to go off my script. My name is Carrie Dyer. I'm the CEO of Reliance Health, a community mental health nonprofit organization that contracts with the Connecticut Department of Developmental Services and Mental Health and Addiction Services. We've proudly served Eastern Connecticut for over 47 years and have evolved to meet the changing needs of our community. I'm speaking in support of correcting the historic underfunding of the nonprofit sector and establishing a plan to recognize and adjust for inflation in a clear and dedicated way. Specifically, that you increase funding for community nonprofits during the biennium by 9% in fiscal year 24, 7% in fiscal year 25, and to index future increases to inflation. This funding is essential to honoring your long-term plan to increase funding for community nonprofits to correct the trajectory of funding lost to inflation. Legislatively issued funding increases were greatly appreciated last year and sent a message to our employees and clientele that they are recognized and valued. The increase, however, is diminished by the years of flat and reduced funding that the nonprofit sector has suffered. This bill would allow the legislature and nonprofits to truly partner to address the tremendous gap between inflation and historic underfunding. As Mike referenced earlier, our agency received no funding increase for 10 years between 2007 and 2017, and then suffered a 5% budget cut in 2017. In 2021 and 2022, we received a 4% and a 5.41% increase, respectively. That leaves us 4% above our 2007 funding, while facing expenses that leave us 32% below the rate of inflation. A graph is included in my written testimony to demonstrate the magnitude of that discrepancy. I have copies also if you'd like them. This is our opportunity to be proactive and improve the contracting process. As it stands currently, state-established nonprofit budgets are locked in upon contract signature and do not increase unless the cost of living is issued by the governor or legislature. Barring this, funding stays flat while expenses rise, resulting in nonprofits struggling to maintain consistent staffing, offer acceptable rates of pay, and absorb astronomical increases in health insurance and overhead expenses. This dynamic must stop. We look forward to building upon the momentum of last year to create a sustainable model of indexing that stops treating the nonprofit sector like an afterthought and doesn't suggest philanthropy or one-time funds as a solution. Thank you for your time and consideration. My written submission includes copies of previous year's testimony as they continue to be relevant and demonstrate the extent of significance this topic represents.
Thank you so much, Ms. Dyer. I don't see any hands. Thank you for your testimony and your time and coming out today.
Thank you.
Now we'll go on to Senator Summers, who is joining us by Zoom.
Good morning. Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and distinguished members of the Human Services Committee. In 2021, we passed bipartisan legislation which built upon New London's innovative approach to using peer navigators or recovery coaches to combat the opiate crisis. As you know, these community healthcare workers are people with lived experience of substance abuse disorder who develop relationships with people struggling with addiction. Recovery coaches or community healthcare workers provide non-medical services in collaboration with health professionals authorized to prescribe medication for opiate use disorder. The New London Director of Human Services, Jeannie Milstein, deserves credit for putting this program together. It's a program that incorporates our Ledgelight Health District, first responders, healthcare providers, nonprofits, and city leaders, and it represents a blanket of hope wrapped around those individuals who need it the most. It connects individuals with vital supports and access to medication and basic necessity. It does so in a non-judgmental, non-punitive, supportive fashion. It's a pathway of hope and recovery that has saved lives. It makes sense to focus this best practice example like this as we push forward to do more to address the opiate crisis. SB 991 represents a solution to improving and expanding the services that navigators, recovery coaches, or community healthcare workers provide. Connecticut's Medicaid program does not reimburse community healthcare workers' services. The lack of reimbursement really is an impediment to future progress, and we can remove that obstacle by passing SB 991. Incentivizing healthcare providers to work in community healthcare workers will help the navigator model or the recovery coach model to continue to take root throughout Connecticut. The model is based around trust and expertise and success. That trust is preventing tragedies and death, and we should be looking to build upon that trust in every way that we can. The legislation that was passed in 2021 was forward-thinking. We saw great successful local idea in New London and took took it upon ourselves to roll it out statewide with a statewide idea. This year, we have identified an incredible opportunity to further improve this program and better help our most vulnerable low-income residents. As ranking member of the Public Health Committee, I want to thank all the members of this committee for your ongoing commitment and relentless and bipartisan in tackling the opioid crisis at every angle. Thank you for your consideration, and I fully support SB 991. Thank you.
Thank you so much, Senator Summers. I see Senator Lesser has his hand raised.
Thank you, Madam Chair. I just wanted to thank you for sharing what's happening on the ground in New London and for your work and the work of our colleagues on the Public Health Committee. We look forward to working with you to pass this into law.
Thank you.
Thank you, Senator. Representative Dathan.
Thank you so much. And thank you, Senator, for your testimony today. I agree with you that the community healthcare workers have been phenomenal, particularly when it comes around peer support services. I would like to know if you, in your research, have you discovered any other states that provide reimbursement for Medicaid services regarding peer support services through the community health workers?
You know, honestly, I have not looked at that. I could get back to you on that, but I do think providing Medicaid coverage under the umbrella of a community healthcare worker gives us an opportunity to almost segment them. Some people might be considered a peer support person, a recovery coach, but we're all talking about the same kind of support, maybe in just a different lane, which is so necessary because right now they're all volunteers, right? And for the most part, and asking somebody to dedicate that kind of time and commitment, which people love to do, but they also have to have a way to, put food on the table. I think that this would be a really, really positive step with the way that we allocate Medicaid funding here in the state of Connecticut. This will save lives. It impacts people on a daily basis. Mothers, fathers, children's, grandparents, grandchildren are so impacted by the good that this can do for very little dollars. And if you think of the budget of the state of Connecticut, funding this in a way that is broad enough so it's under a community healthcare worker gives the opportunity for us to save lives at very low cost and change people's lives directly or indirectly in an unimaginable way. So I fully support this. In anything that we can do. And I will be happy to do that research and get back to you.
That would be great, Senator. I just feel that, we're in a healthcare shortage in our state. We have we need to make sure that we enhance where we can. And here's an opportunity for expanding the community healthcare workers so that we can use them for peer support services, which helps the people that are in recovery, providing those services themselves, but also the recipients. And it really does do a quick turnaround. So I appreciate your advocacy on this, and I look forward to working with you to make sure that we can get peer support services covered. Thank you so much.
Great. Thank you.
Thank you, Representative. I don't see. Oh, yeah. Representative Pizzuto, go right ahead.
Thank you, Madam Chair. Thank you, Senator. Just quickly, do you notice that there's a huge demand with your workers or amongst patients for behavioral health? And if there is, and they are able to use counselors, are they limited in the scope of who they can use? Can they go to private counselors? Do they have to use state-supported ones and so forth? I'm not sure if you know that, but.
I think your question you're asking me are people that are would be using community healthcare workers. Are they also seeking counseling? And are they allowed to go to counselors that they choose? And the answer would probably be yes. They're not all the time. Are they going to counseling? This is in some cases, in lieu of. We would encourage people that are going through opiate addiction to definitely seek counseling, but this is also a different type of support. This is a support that is somebody who has actually normally been through addiction themselves, someone who is in recovery themselves, or we don't say recovered, but has experienced what this person may be going through. They're supportive in helping them find housing, helping them figure out how to go on a job interview. How do they get back into the community? They also offer support where they can enable them or show them a different community to engage with. One of the things we talk about is you don't want to go back to where you came from or the friends that you used to have before you decided to seek recovery because it just doesn't work. So it's a type of support that I would say is complementary to counseling, but it's not replacing counseling. And I do believe that if somebody is seeking counseling, they can go to whoever the counselor are that they choose.
Thank you. And lastly,
Your question.
a regional workforce investment board that, and I'm sure you do in your district as well, that would supply suits, interview skills, bus passes, laptops, whatever, to get through that. And I just wonder if there's a connection with your community health workers and your workforce investment board.
Well, I'm not sure. I can't speak to necessarily our workforce investment board, but the model in New London, the community healthcare workers they work with police, they work with local businesses, they work with our Ledge-like health district. So it's really like a full wraparound service that they can provide. They are sort of the conduit to get the person who needs the help to all the services in a way that is non-judgmental, non-threatening, but also somebody who has been where they are, if that makes any sense. So there may be these great programs that are, offered by workforce investment boards, but having the person know where they are, how to access them, that's a different story. So I can tell you the program that we have in New London that provides all of these wraparound services that we voted in 2021 to expand in a pilot program around the state of Connecticut has had phenomenal success in keeping people from going back to a life of opiate addiction. And as we said previously, that affects children. If it's a mother that is addicted, it affects grandparents, the grandparents that are taking care of the child for the mother that is addicted. It helps save lives. And these community healthcare workers, that would just be one segment of what they could do. There are other segments to what a community healthcare worker could do. But as was stated previously by the representative, with such a shortage of healthcare providers, this network where these people are trained, they have the life experience. We don't have the healthcare providers in the traditional sense to fill this void. If we can fill this void with qualified individuals who have not only sympathetic, but they can be empathetic because they have lived this, it will make a huge difference in the lives of the people of the state of Connecticut and save dollars in the long run because we're keeping people out of the emergency room going for overdoses. We are keeping people out of having to go back to recovery. So I think it's a win-win overall, and I hope I was able to answer your questions.
Oh, very, very much so. Thank you. And it's true. The testimonials from people who've been there and done that are very powerful. Thank you, Madam Chair. Thank you.
Thank you, Representative Bizzuto. All right, seeing no other hands. Thank you so much for being here, Senator Summers.
Thank you. Enjoy the rest of your day.
You too. Now we will go to Nicholas Smith.
Hello, everybody. My name is Nick Smith. Thank you, representatives, for your time. I'm here to speak on House Bill 6618. Due to our state's recent decision to add the right to an abortion into our Constitution, I do not expect us to all agree on the morality of abortion. I know there are two separate DNAs, the mother and the child's, when a woman is pregnant. Therefore, I believe that an unborn baby is a person and abortion is murder. Well, I don't know that we all agree on the issue of abortion. I do know we all agree on the tragedy of human and sex trafficking. If Bill HB 6618 passes, the state of Connecticut would be willingly taking part in the sex trafficking of minor girls and women. Abortion is a tool used by those who control these victims to keep the girls and women available for further exploitation. Pregnancy hinders traffickers' profits, and the forced abortion is their answer to that hindrance. Consider these statistics from the National Center for Missing and Exploited Children. In the US in 2022, there were 19,000 reports of possible child sex trafficking and 400 reports of runaways who are being sex trafficked by gangs. They estimate that 1 in 6 runaway children will be sex trafficked. Much like sexual abuse, it is likely these numbers are underreported due to the shame and embarrassment that comes with such horrendous abuse. The 8.7 Alliance estimates that 192,000 women and girls were sex trafficked in the Americas in 2016. Steve Wagner, the former Director of Human Trafficking Program of the U.S. Department of Health and Human Services, states, the average age of entry into commercial sex exploitation is 14. The average life expectancy of someone in commercial sexual exploitation is 7 years. Start at 14, dead by 21. The mortality rate for someone in commercial sexual exploitation is 40 times higher than for a non-exploited person of the same age. Helping a victim return to exploitation more quickly by terminating a pregnancy increases the odds of death. If we pass the House Bill 6618, we will be aiding and abetting the sexual enslavement of women and girls. Our state does not require parental notification of an abortion. This allows any abuser to travel to Connecticut, forces victim to have an unwanted abortion, and travel home, all in the state of Connecticut taxpayer dollars. I hope I've shown you the direct line between human trafficking and our state's eagerness to partake in all things abortion. I urge you to vote no to House Bill 6618. Thank you for your time.
Thank you. Representative Cook.
Thank you, Madam Chairman.
Yeah.
Thank you for that. I have been back and forth on this piece of legislation, and obviously I believe in the public process, and it's an interesting concept and view that you have
Mhm.
on this piece of legislation. So I want to thank you for coming out, weathering the storm, and then and bringing that view
Absolutely.
to our attention. Thank you so much.
Yes, thank you.
Thank you for your testimony and your time.
Thank you.
Next, we will hear from Representative Mike D'Amico.
Good afternoon, Representative Gilchrist and Senator Lesser and all the good members of the Human Services Committee. Thank you for having me here today. I am hopefully going to be joined by Jonathan Sigworth remotely. Great.
Yes, I'm here.
Oh, great. There he is. Looking good, Jonathan. So members of the committee, my name is Mike D'Amico. I'm the state representative from Farmington. And I'm joined by Jonathan Sigworth, who is a wheelchair user. And we are here to talk about one of the bills before you today, which is House Bill 6702, an act concerning a consumer's right to repair a powered wheelchair. So I appreciate that this is on your agenda today. As you may know, both Representative Smith and I introduced similar legislation to 6702. And as you're well aware, 6702 puts, well, it does a few things, but basically it tries to get at the problem of wheelchair repairs and the speed or lack of speed with which wheelchair repairs are done, the difficulty that wheelchair users have in getting their wheelchairs repaired, and 6702 in short would make available to wheelchair users documentation, parts, software, hardware, tools, in order to enable the wheelchair users to fix their own wheelchair or to get someone to fix their wheelchair. So in discussing this with Representative Smith and wheelchair users, consumers, and advocates, we think we have a better idea, a better plan. So I would respectfully offer alternative language. I believe that Representative Gilchrist is in possession of that alternative language, and it is also attached to the testimony for today's hearing that's going to be presented by Disability Rights Connecticut. So if you look at the testimony from Disability Rights, you will see attached to that, should be attached to that, the alternative plan, alternative language. The alternative, in short, puts the onus for repair on the supplier as opposed to the consumer, which we feel is a better way to go. So I hope that the committee will consider that alternative language and that alternative approach. And it requires, oh boy. I guess I should, look, basically it requires that you could ask me what it does, Representative, and then that would make my life
Thank you for
easier.
summarizing. Representative D'Amico, would you tell us what the bill does?
Okay, so it would require that the supplier come out to inspect the wheelchair within 3 business days, make an assessment of the situation, and if it cannot be repaired in a timely fashion, that starting on the 4th business day, a loaner wheelchair would be given to the wheelchair user. And it requires that the suppliers have to stock parts so that they don't have to spend time ordering parts. It requires that the supplier have a staffed 24-hour call center for receiving calls about urgent wheelchair repair needs. So again, you can read it for yourself. But I just wanted to note that this alternative language, in the opinion of myself, Representative Smith, who's going to testify later, and the advocates and the consumers, we think this is a better approach. And I would be remiss if I did not allow Mr. Sigworth, Jonathan Sigworth, who is a wheelchair user who is here via Zoom, to be able to say a few words as well, with your indulgence.
Thank you. Good afternoon, everyone. And thank you, Mike D'Amico, for helping me share my testimony. My name is Jonathan Sigworth, and I've lived with a spinal cord injury in Connecticut since 2006. I'm paralyzed below my arms and in my hands, and serve on the Connecticut State Independent Living Council as a board member and chair of the Durable Medical Equipment Repair Committee, where we are researching this problem and surveying the public. Therefore, I greatly appreciate the intent behind the proposed bill and the revised language that we have come up with. Just to provide some context, if you live in a wheelchair, a flat tire, a broken brake, a missing screw, perhaps minor repairs that can cost less than $50 in parts, these can put your entire life on hold indefinitely, meaning you may not even safely get out of bed, but it can also put your life and health at risk as you try to make do on your own. Our wheelchairs, both manual and motorized, are custom machines measured specifically for our individual size and needs that cost anywhere from $10,000 for a lightweight manual chair like mine to $30,000 or more for your motorized chair. So each is unique and precious for our independence and cannot be easily substituted or replaced. So with that precarious context in mind, I want you to consider that over the past decades, there are 2 national custom durable medical equipment, or DME, vendors in Connecticut, National Seating and Mobility and New Motion, who have consolidated the market while reducing the total number of staff across a total of only 3 physical locations. This has resulted in excessive delays and lack of communication regarding consumers like me. The proposed Disability Rights Connecticut alternative language lays out a bill that would address the right for people with disabilities to have timely communication and repairs for the DME that they use every day to care for themselves and participate in society. So from personal experience, for example, I called my DME vendor last October, to put in a repair to replace several inexpensive ball bearings, cost about $5 each, that allow my wheels to spin smoothly. And when the technician arrived several weeks later, they did not have the proper parts to conduct the repair, and they advised me that I should replace my entire wheel assembly, which costs $2,000, instead of replacing these $5 parts. And that would leave me with a more than $1,000 deductible with my private insurance. Several friends have also experienced similar things where they have perhaps a $10 flat tire. And again, instead of a technician coming out and changing a wheel tire, this is the same process that you do when you change a tire on a bicycle. The same suggestion is made: replace the entire $2,000 carbon fiber lightweight wheel set. Replace that $2,000 set instead of changing the tire. And why are these things happening? It's because these specialized technicians employed by these companies are not being provided the basic equipment or training that they need to safely do these repairs. And that leads to these extensive delays in ordering and receiving the parts, as well as not being able to conduct these repairs on the spot. So my own repair that I initiated last October for these ball bearings was finally completed last week, but only after I called 4 times during business hours, leaving 4 messages which remained unanswered for several days, despite recordings promising that all calls would be returned by the end of the business day. And when the office finally called me back with a very heartfelt apology, the manager told me that the delay was due to there being only 1 staff person working in the office, handling scheduling, customer service, insurance claims, and everything else apart from the 2 field technicians on her team. So the takeaways from this example are not simply that the time the repair has taken is extensive, but the obvious limitations of the technicians and the staff to do their work effectively. And it's not their fault, but they are not being equipped properly. And although my repairs, as I explained, are minor, such minor and major repairs can prevent life-threatening harm and need to be prioritized. And so to summarize, the revised language for bills HB 6702 would establish minimum requirements for the timeliness of initial repair evaluations and minor repairs, the availability of a 24-hour staffed emergency hotline for repairs, and the establishment, this is very important, of a stakeholder group comprised of assistive technology professionals, such as these technicians, and wheelchair users to work together to create more detailed time requirements for different categories of repairs, among other related provisions. So I urge all lawmakers to support this bill with the revised language to support all wheelchair users in Connecticut and the professional technicians who help make our independence and everyday lives possible. Thank you.
Thank you so much. We do have questions for you both. Senator Seminara.
Thank you, Madam Chair, by the way, and thank you so much, Representative D'Amico and Jonathan, for coming to testify. This is a huge issue and it's an important issue, and I agree with you wholeheartedly from personal experience. I have a child with a disability, and to get repairs on her wheelchair, I'm probably talking decades of complications all the time, and hearing people long before the birth of my own child complaining that is an issue and an ongoing issue. And I do really recognize how debilitating not having your wheelchair can be for people who are in them on a 24-hour-a-day basis. So I wholeheartedly understand your plight, and I hear it, and I am so grateful that you offered some alternative language, because many people have approached me on this bill and said the content of the bill or the spirit of the bill is great, but there are some issues with the language and the thoughts behind it. So I promise I wanted to make you aware that I am a supporter of this issue, and I will very much do my due diligence and look at your alternative language and also consult some other people so that hopefully we can come to something this term that will assist people with disabilities in the ability to get repairs to their wheelchairs in a timely manner. Thank you. And thank you again for your testimony.
Thank you for those kind words, Senator. I appreciate it. Thank you.
Great. Thank you so much. Representative Case.
Thank you, Madam Chair, and thank you, Michael, and thank you, Jonathan, and thank you, Representative D'Amico, for coming forward today. I agree. It's a difficult situation, and just a few questions to you, Jonathan. When you go out and you first purchase, because it's custom made for you, is there a warranty, and then do they tell you who is to repair it and who is not?
Yes, the supplier, the supplier through whom the order is made with insurance is the one who must repair the wheelchair, even after the warranty period. In order for me to get it repaired, it goes through the same supplier, goes through the same DME vendor.
So is that part of insurance covering it with your deductible, that you have to have it done by the manufacturer? I'm just trying to get to the bottom of this. I think.
No, yes, that's correct. So the warranty period, as we commonly talk about, perhaps it lasts only for the first 1 or 2 years. I use this chair anywhere from 5 to 10 years. You can get a new wheelchair usually every 5 years. So the warranty period doesn't really matter that much unless it's, there's a defective part and the supplier can be reimbursed completely by the manufacturer for that defective part, in that 1 or 2 year period.
So when you talk about this in the supplier having to repair and they send out technicians, I'd like to work with the supplier and see if, in my business, we have certain pieces of equipment that we have to go out and fix. But per our contract with the person who's using the equipment, we have to have those repair parts on the vehicle that's going out to repair. Is that something that we should maybe work with the suppliers of the chairs to have that ability? I mean, putting a law into effect is one thing, but actually working with the wheelchair supplier is another. Has that been talked about through you?
That is the entire purpose of this bill, is to create a stakeholder group, as I mentioned, that would bring the suppliers, who are our allies in every way, to figure out what are the needs, what are those required parts that should be in those vans for different types of repairs, to make sure we cover the basis for the most urgent repairs. I mean, because even some minor repairs like a ball bearing, wheelchair tubes, those types of things may not always be there. And there is no current requirement for these national companies. We're not talking about mom and pop vendors in Connecticut. We're talking about national companies that have a financial incentive to run skeleton crews, essentially, and minimize those costs. We need a law in order to require that they provide those necessary things. And we want to create that stakeholder group that would sit side by side and collaborate and figure out what those things are.
Well, I mean, and you don't want to cause an increased cost for getting things done, but I believe from hearing you, you want to work with the supplier of the chair, because the supplier also has to warranty those repairs, and they need to make sure that the chair is working because they're on a contract with the insurance company to supply. I just want to make sure that we exhaust everything with the manufacturer, because you're correct. Your wheelchair is your lifeline. You can't be without that. There are so many things that people take advantage of and don't understand that what you need is what you need, but this is your lifeline. And it's difficult to put a loaner with you when it's been custom built for you. So I think somehow in the workings of this bill, we work so that the manufacturer who has these technicians out there have the proper tools. It's almost like somebody comes to fix a Xerox machine at an office building. They have all the proper tools to fix a Xerox machine. So we want to make sure that happens, and the least impact to you or to others is a much better outcome, because these people are coming into your home. They're coming in to fix something that you have, but we don't want to see the issue become an insurance issue. I mean, does this need to go to the insurance committee because the wheelchairs are bought through insurance? They're not privately purchased, is that correct?
So the wheelchair is purchased by insurance, and you get authorization to do that. This bill, which I don't think we've already mentioned, would also eliminate the requirement for prior authorization for repairs, because insurance has already authorized that piece of equipment. So to repair and maintain that piece of equipment, prior authorization, which is often contributed to the delay removing that for repairs is actually one of the requests of the DME vendors themselves. And to be clear, the language that we've proposed does not specify any specific part. It doesn't specify anything of that nature. It simply requires that the initial repair evaluation take place within no more than 3 days. That there be 24-hour communication, an open line for communication, so that people who are experiencing emergencies do not have to wait several days to get in contact with a human being. And it requires that we create a stakeholder group of wheelchair users and vendors to come to consensus about what those more detailed repair deadlines and requirements would be for the vendors. So I hear you, and it's absolutely an attempt to make broad strokes that don't put undue burden on companies, but to really get to the bottom of this so that we can work together and be more effective.
Well, it's not an undue burden, it's their job, but we need to make sure that we can work with them, because you look at this in any industry, they're all hurting for employees, but this is something that is a lifeline, number one, and I respect that, and I get that from you. I just want to make sure that we exhaust all of our time in working with the manufacturers to give them the benefit of the doubt, of which maybe you already have. I don't know, I haven't spoken with you, D'Amico, but making sure that they are at the table and that they're doing everything they can to make it happen. Because when they send somebody out to do an evaluation, yeah, if it's a $4 or $5, bearing change out or a flat tire change out, but if you're looking at an axle or you're looking at something different, they need to make that decision, because that's going to evidently go to the insurance company or go to the warranty. So those are the types of things. Maybe in the bill we put a cost cap of what it was and how somebody can fix it. But I just want to make sure that we don't, how do I say this in a good way? We don't burn the bridge between the manufacturer and the people using. We want to be able to mend it and be able to work together. And I get what you're saying. You want to have more communication. I think the number of days that you're waiting is much longer than I would like to see. But I'd also like to see the manufacturer be the one to work on the piece of equipment myself. But maybe they need to beef up their people on road so that they can be able to get to you at a more timely fashion. But the manufacturer is the one who knows that chair best. And I believe they would have a database of knowing where their chairs are throughout the state, so where they need to have the most robust people to get where you are. So I think we work both with the manufacturer, and we want to get something over the finish line, but we want to make sure that we're doing the right thing. Does that sound correct, Jonathan?
That is exactly what we are proposing.
Okay. Well, I thank you, and I'm sure I'll reach out to Rep. D'Amico for more, and talk to Senator Seminara, because I think we all take an interest in this. So I thank you for your time, Jonathan, and coming forward.
Thank you.
Thank you, Representative Case. Senator Lesser.
Thank you, Madam Chair. And I'm going to join the chorus of legislators interested in this bill, and want to thank you, Representative D'Amico and Jonathan, for your testimony. My understanding is that the initial bill is really modeled on the Colorado law that's about creating a right to repair a wheelchair, and the suggested changes are to more create standards of conduct for the companies in this space. Can you just talk a little bit about why the shift to the second approach rather than the Colorado approach?
Well, Senator, thank you for the question. I'll answer it in my way, and I'm sure Jonathan will answer it in his way. Short and sweet. In discussing this with consumers and advocates and wheelchair users such as Jonathan, it became clear that to me, and to the group that was discussing this, became clear that if you really want to solve this problem and you really want to help people in wheelchairs, this is a better approach. This will get to the heart of the problem, and this puts the burden where it rightly should be focused. So that's my response to that. I don't know if Jonathan wants to add to that.
Yeah, sure. So what Senator D'Amico said is absolutely true, and in the State Independent Living Center board, we've been discussing this issue and how to solve it. Kind of trying to dig down into the source of the problem and gather people's testimonies. And we really feel that right to repair, which attracted a lot of opposition, especially from software and other industries that feel threatened by this over, intellectual property rights, et cetera, that are threatened by this idea of sharing information in order to conduct a repair. We really felt like we needed to do a broader thing that would also include manual wheelchairs, that would really get to the root of the problem, which is we don't have enough access to repair to begin with. There are not enough technicians. The technicians are not adequately trained. And furthermore, as I mentioned, I have a $15,000 manual wheelchair. You may have a $40,000 power wheelchair. How many of us on Medicaid and Medicare are going to be paying out of pocket to get those things repaired, taken apart, risking that they will be damaged in the process? And so all of those concerns are legitimate, which is why we were pushing for this alternative language that would be more broad and really get at the root of the problem.
Okay. And are we going to leave anybody behind? I guess people pay with different ways. Does the suggested language leave anybody behind that you can identify?
Not that I am aware, because I don't know if there was any personal testimony behind that kind of pushed forward the right to repair bill, or if it was simply borrowing from another state's efforts. But all of us get our wheelchairs repaired through insurance primarily. And if you have a right to repair issue with a power wheelchair, most likely you are insured and you have insurance backing that process.
Okay. And you don't have, you don't think there are any, I'm thinking of folks who are self-pay arrangements. There's nobody you think would be left behind.
I mean, and even if there are, perhaps it is a legitimate concern to take up at a future time. But the likelihood of that effort succeeding is very low. And so we feel like proposing a broader, more practical measure at the moment is better.
Thank you. Thank you, Madam Chair.
Thank you, Senator Lesser. Representative Kit.
Thank you, Madam Chair. And thank you, Representative D'Amico and Jonathan, for bringing this up to us here in the General Assembly. As a more than 20-year advocate for people with disabilities, this is an incredibly important issue. And I was hoping that Jonathan could just share with us why it is so critical that people with custom wheelchairs are able to get them repaired quickly. And it's why using a sort of a loaner chair or any other options really is not a safe option, and why this can lead to critical health issues.
Definitely. And thank you, Representative, for that question. So, for example, I am paralyzed below my arms, so I don't have trunk control. So my sense of balance is absolutely dependent on the height of the front of my chair, where my axle is placed, the size of my wheels. The smallest incremental change to those measurements, to the placement of the wheels, to a low tire, those heights can mean the difference between me being able to push up a ramp safely and me pushing up a ramp and falling backwards, or me tipping out of my wheelchair, falling on the floor, breaking my wrist. So that just, from my personal experience, every aspect of a wheelchair, the wheelchair user knows their wheelchair the best. It is designed, we go everywhere with this thing. It is customized to every inch of it for our benefit if we can. I mean, if it's very unfortunate when that is not possible for someone because it prevents you from taking a shower independently. It prevents you from getting out the door, from getting a wheelchair into your car. So custom wheelchairs are very, very, very different from what you see in a hospital setting, in your local pharmacy, perhaps. It's an entirely different product. It's probably more similar to eyeglass prescription or an organ transplant. You know, you really need to have something that is fit for you, and it needs to be repaired quickly because otherwise an essential part of your body is missing. And we should not be expected to wait more than 3 days, as it's a generous amount of time to ask for those things to be evaluated for a repair.
And you may not have experience with this, but I also know from a lot of people I work with, they experience pressure sores if they are not in a specific chair. And those types of sores can lead to long-term infections and hospitalizations. I'm sure, have you encountered that in your work with your advocacy groups?
Yes, absolutely. And pressure sores can start with a very minor cut. And because many of us have reduced sensation, you know, that can unseen develop into a pressure sore that goes down to the bone, and that is incredibly life-threatening and can debilitate us for years and years to come and really reduce our level of independence and threaten our lives. Absolutely.
Well, thank you for sharing your story, and thank you, Madam Chair.
Yes, thank you. I don't see any other hands. Representative D'Amico?
Yes, thank you, Madam Chair. Just in conclusion, I just wanted to reiterate that I hope you will take a careful look at the testimony from Disability Rights Connecticut, which includes the suggested alternative language. And also, I should point out, there's also good testimony in your packet, so to speak, from the ARC of Connecticut, from the State Independent Living Council, of which Jonathan is a member, and also the Connecticut Legal Rights Project. So all good testimony. But I would further suggest that perhaps the best resource for the committee is the ranking member, Senator Seminara. So I hope that you will get her involved in this discussion as well. How's that?
Thank you so much, Rep. D'Amico, for that glowing support for me. But I assure you that I will work closely with both chairs and the members of this committee so that we can do our best to get a piece of legislation that really addresses this issue. And I very much appreciate you bringing it to the forefront.
Thank you.
Thank you so much, Representative, and thank you so much, Mr. Sigworth, for being here today.
Thank you.
All right, we are going to number 8, Megan Gorman.
Hello, everyone. My name is Megan Gorman. I am, right now I can see myself. I'm not sure if I started already. Good morning, Senators Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and all members of the Human Services Committee. Thank you for your attendance and attentiveness to all of the matters being brought before you today. My name is Megan Gorman. I work at Community Mental Health Affiliate, CMHA, which is a behavioral health provider that serves over 7,400 individuals a year across central Connecticut, from New Britain, Waterbury, Sellington, you name it, we probably have a presence there. I thank you for the opportunity to speak today and provide testimony in support of HB 6612, an act concerning nonprofit health and human service providers, which would prohibit the practice of state agencies clawing back surplus funds from nonprofits at the end of the fiscal year, allowing us nonprofits to retain these savings and directly reinvest them into the services that we are already providing. It would also allow for the indexation of the rates that states pay to nonprofits based on inflation. Now, and it's been mentioned earlier on that legislative action has been made in ways to support this sort of initiative. But despite that intent and the support for it. The policy has still not been implemented in a way that is as best helpful to nonprofits as it could be. This proposal has always been simplistic in that nonprofits should be able to utilize the funding that's already been provided to them. I'm uniquely in a position to speak to the process of securing these fundings as I'm a grant writer for my organization, and the hoops that we have to jump through, the strictures that we already follow to prove that we are qualified to even receive this funding and offer these programs is already testimony to the quality of the services and our capabilities. Earlier, it was noted, and I would like to rebut this sort of, it was noted that a possible issue with HB 6612 that was raised earlier is in regards to how state agencies can or would need to differentiate federal dollars possibly from the pool of funding made available to nonprofits who are then wanting to keep these funds. The nonprofits and human service providers across the state already juggle with aplomb the variety of funding strictures and requirements that come with receiving funding from varied sources, whether they be state agencies, federal, private, or local philanthropic entities. We maintain this standard of fiduciary responsibility in all programs because it is only through multiple funding resources that nonprofits can survive.
Ms. Gorman, can you please summarize?
Yes, I will. I'll summarize and state that, it's the heart of nonprofits, the people that make our services possible. And in support of HB 6612, I think that the legislature has a simple response to this, to show nonprofit human services providers that they take seriously what we do for the state. We directly serve the needs of citizens across this state. And, HB 6612 will just go a long way in demonstrating that what we do is not only needed, but it's prioritized by the state and appropriately funded. Additionally, there is an aspect of HB 6612 that stipulates state agencies are required to pay for services rendered within 30 days. I'm a major proponent of that. As a case in mind, at our agency, we at one point waited over 12 months for the funding to come for a program that we were awarded. And during that time, the requests for data, the requests for other documentations from the state don't stop, but the funding never even came until we made a concerted effort and issue over it. So again, thank you all for this opportunity to provide testimony. I thank you for your time, and I encourage you all to listen to the people who know the realities of nonprofit human service provision the best, the individuals who are testifying here before you today on a variety of issues, which are unfortunately all lumped together and not given the due consideration and attention they need. These people are here and they're making a priority to be here and provide testimony. So I encourage you to listen to them and their experience with these matters. Thank you all.
Thank you, Ms. Gorman. Representative Case.
Thank you, Madam Chair. And real quickly, Megan, thank you for coming on. You're the second person who's spoken on this. And since then, I've been getting some texts and stuff that it hasn't fully been implemented on what we did in a previous year. And we need to work on that because that was to stop the clawback and allow those funds that were allocated to the nonprofits to be used for capital line items and other things, not programmatically, but and not for raises and wages, but to allow you to keep the money that has already been budgeted for you. So I think that's a question that we have as a committee to go to OPM to see when we are going to fully implement this, because I would have thought it would have been done by now. So I thank you for coming forward, and the more we have on this, the better, because more numbers is better for us, and let's go after and see what the issue is on not implementing the bill that was passed. So thank you. Thank you, Madam Chair.
Thank you, Representative. I don't see any other hands. Thank you so much for your testimony and your time, Ms. Gorman.
Thank you.
Next, we'll go to Representative Frank Smith on Zoom.
Thank you very much, Madam Chairman, and good morning, Madam Chairman Gilchrist, Senator Lesser, Vice Chair Senator Gaston, and Representative Dathan, and also ranking members, Senator Seminara and Representative Case. I'm here to speak about the House Services Bill, Human Services Bill 6702, which was just covered in fairly close detail by my colleague Mike D'Amico and by Mr. Sigwarth, who more thoroughly and eloquently made the case for this bill. I just want to add very briefly, both Representative D'Amico and I had introduced bills regarding powered wheelchair repairs, coincidentally, but on separate channels, and we're kind of joined by it as we began to discuss it. It was originally before general law, and I presume the fact that it's in human services has to do with the fact that it has a Medicare insurance component. The important thing here is it started out as a right to repair. A constituent of mine approached me with an article regarding the Colorado right to repair bill, where as Representative D'Amico said, the onus was put on the wheelchair user themselves, but themselves the service provider or the supplier of the wheelchair to provide parts, software, schematics, all sorts of information and parts that are necessary to make these wheelchairs whole. As I think Mr. Sigwarth said very eloquently, this is not just something that you would have with an appliance. This is something that is very much a part of your personal independence and sometimes your personal safety. It's something you need to get around your house. And it's not just a segment of our population that's not active. And these are people with great responsibilities, with great input into the community, and represents every small business owner up through governors and President of the United States, a wheelchair user. This 6702 is being presented here and discussed as part of the right to repair, but has been changed with the new language that was submitted. And I encourage the committee and encourage the assembly to take it, view it favorably and recommend it for inclusion on the JF. It's something that I think you will hear more testimony in the time ahead here this morning. And I think it's something that is necessary. And I think it's something that will go a great way to probably appeasing any doubts that the industry had. This is going to put the responsibility back on the industry. And I think, as Representative Case mentioned, that might be the best place for it to reside. It's something that they will now have no issues with pre-authorizations. They will not have any concerns about intellectual property. They will be in charge, and this user stakeholder council will help to define those things like what is expedited, what's the time period, and so forth. I think it's a good bill, and the changes to it, I think, are something that are more acceptable than perhaps it was originally presented. And I want to thank too Senators Seminara and Representative Case for their sensitive understanding and familiarity with this issue, and I appreciate their input. Thank you very much, Madam Chairman.
Thank you so much, Representative Smith, for being here and for your testimony. I don't see any hands. Thank you for your testimony and your time. Next, we'll hear from Jennifer Van Gorder, who is joining us on Zoom.
Can you hear me?
Yes, we can. Go right ahead.
Okay. Thank you, Madam Chairman and committee members. I am speaking in opposition to HB 6618. I think it is a misappropriation of Connecticut taxpayer dollars. No matter how you stand on the abortion issue, we should not be spending our tax dollars on services for out-of-state people. If there's a need for that, I think there could be options to start up nonprofits, 501c3s. Some, people can do their own private funding for that, raise some money, but I don't think it's a spot where we should be spending our tax dollars. I also thought it was interesting. We do not have the funds for family planning and fertility issues, but we do have the funds for out-of-state abortions. And I also would like to second Nick Smith's testimony. I thought it was actually really interesting and a good thing to bring up regarding this bill. And I think that's it. Thank you.
Thank you very much. I don't see any hands. Thank you for your testimony and your time.
Thank you.
Now we'll hear from Representative Delnicki. Come right up.
After last week's calamity, it's great to be here today with an internet that's working, though we had a bit of snow out there, which caused a deal of trepidation. Good afternoon, chairs Gilchrist and Lesser, ranking members Case and Seminara. I'm State Representative Tom Delnicki. I represent the 14th District, South Windsor. And I'm in support of HB 6703, an act concerning the low-income heating energy assistance program. You know, it's interesting. This industry that provides a home heating oil is substantially a mom and pop operation, small family businesses. In my community, there's 3 companies, and each one is a family-owned business. So you could only imagine what they go through when it comes to getting the funding to provide folks with the home heating oil that they need. They go to the depot, typically in Wethersfield, and they have to pay by an electronic funds transfer when they're leaving with their truck full of oil to bring to people so that they can heat their homes. The LIHEAP program currently gives the non-governmental entity up to 30 days to pay this provider of home heating oil. Think about it. You're a small business. You're making ends meet. You want to do the right thing. You want to provide people in the LIHEAP program with the oil they need to heat their homes. You have to pay for it up front, and then you can wait up to 30 days to get paid. I mean, that's unbelievable. In my community, I know we've had one dealer that's actually dropped out of the program. Regrettably, the dealer didn't want to drop out of the program, but it was a function of you got to pay your bills. There's a couple of others that are talking about leaving the program. That's why 6703 is so important. To actually, A, get the bills paid in a short period of time. 6703 calls for 2 days, 2 business days to get paid. It's done electronically, so the funds go into the bank account so that they can pay their bills. And the other piece of the puzzle there is the actual profit, if any, that they get on the oil. Because typically the profit, the remuneration from the non-governmental entities comes based off of New Haven oil cost versus Wethersfield. And let's face it, with the cost of diesel fuel and the cost of folks that deliver the fuel, you can't drive down to New Haven to get the oil and come back and hope to make a profit at all, and to pay the bills and to pay the employees. I heard the signal there. In closing, something has to be done to make this program sustainable, to keep the small operators, the small businesses, the folks that are helping people in their communities in business. You know, it was and I could see the regret on the owner's face when I was talking to him about him dropping out of the program, because these are people that he's dealt with forever. And, you know, it was one of those deals where you either have to do what you have to do to stay in business, or you go out of business. And they want to go back into the program. Please do something there to solve the problem, to get these folks paid, and to keep the program working tremendously well. You know, this is one of those crown jewels of good things that we do in Connecticut, providing people with the heating that they need in the winter. I don't know if anyone has any questions, but I'm here to answer anything.
Yep, yep. Thank you, Representative Delnicki. And I've heard from the very same people and agree with you that, you know, they want to be in this program, but it's taking a sacrifice. And so I'm hoping we can do something. We do have 2 questions at this point. Representative Case, go right ahead.
Thank you, Madam Chair, and thank you, Rep. Delnicki, for coming forward. And I think that you hit the nail on the head, because the way Connecticut prices it is they price it off in New Haven Harbor, but as you speak, your providers over there pick up at a depot, correct?
That's right. Just think about it, Representative Case. To drive a truck down to New Haven, pay the cost of diesel, pay the cost of the person driving the truck, and bring it back up. And that in itself is a hit that's unsustainable when it comes to actually trying to run a business and trying to make a meager profit.
Yeah, and you talk about it because sometimes that oil can come up a day or 5 days ahead of time to that depot, but you are paid on energy assistance in the state of Connecticut on the day that you deliver it. So the price could have dropped in those 3 or 4 days to where it was delivered to the depot. Is that your understanding?
You know, I'm glad you bring that issue up, because in the spring, back in May, when there was that tremendous cost of oil spike, they were picking up oil at a huge price. I mean, I can remember I got a delivery thinking I was going to actually save money by getting a delivery in May, and I paid just under $6 a gallon. Now, bear in mind, they bought oil at that high price, and now they're stuck with it. And they had some LIHEAP customers thereafter. And if the oil sat in the truck or sat in the truck, and now you're delivering it at less than what you bought it for, you can't do that very long and stay in business. And you can't do that very long when you've got an electric bill to pay. You got to keep the heat on in there. You've got to pay your drivers, and you've got taxes. So they took a tremendous hit on that. And that was probably the reason why one of these folks actually got out of the LIHEAP program.
And I think, there's a lot of things that we need to look at, because, when a hauler picks it up in New Haven, it's EFT 3 days, most people. So they have to pay for it within 3 days and then bring it to the depot that it's going to. But it's interesting, in the state of Connecticut, you can get LIHEAP for propane, and it's paid at the company's retail price.
Yeah, it's interesting you mentioned that, Representative, because it's almost an instantaneous payment on propane versus home heating oil. And I think most of the big operators get the 3 to 5 days, but the small family operators, I'm not so sure. I think they have to pay right away.
Yeah. All right. Well, thank you for coming forward. And that's something we've been talking about for years. So thank you very much for taking the time.
Well, Representative, I hope it's not just we're talking about it again next year. Let's get something done this year.
Representative.
Thank you, Madam Chair.
You're welcome.
Thank you, Madam Chair. Great to see you, Representative Delnicki. We have constituents in Waterbury that buy huge amounts of oil, and they literally have become banks. They have people that owe them from 2 years ago, and they still deliver oil to them. But one of the issues that comes up, and I don't think it's in the LIHEAP thing, is that sometimes the oil is delivered, but the furnace may need a nozzle change or something very minor. He sends his repair guys, and it saves them from burning the oil that they do get so inefficiently. And it's a minor little part. It takes 5 minutes, but does that address that at all?
Yeah, that's a very good issue you brought up, because many a time somebody who's on the LIHEAP program will run the burner dry. And now a technician has to come out. They've actually got to prime the pump. Conceivably, you could have that nozzle issue, but at the very least, they have to prime the pump on the burner to actually get it going again. They've got oil in the tank, and you want to talk about frustration for the individual. They've got the oil delivery. The oil company is waiting to get paid. The phone rings. Hey, I can't light my burner here. They send a technician out. And now not only do they have the cost of the oil luckily covered by LIHEAP, but they have an additional charge of having to have a technician come out. And if there's any opportunity to actually expand the program to address an issue like that, I think that would be great. Because if it's a direct cause and effect of a burner that won't light after an oil delivery because it was run dry, it's the kind of thing that should be covered. But at least let's get the payment up and get the folks paid in a very reasonable period of time.
Excellent. Thank you. Thank you, Madam Chair.
Thank you. Thank you, Representative Delnicki. Have a great rest of your day.
And thank you for the opportunity, and you made it in the snow. That's great.
I only live 8 minutes. Thank you. Next, we'll hear from Jeannie Milstein.
Thank you so much. My testimony says, good morning. You'd think after all these years, I would learn. Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the Human Services Committee. My name is Jeannie Milstein. I am the Director of Human Services for the City of New London. I am testifying in support of Senate Bill 991 and Act concerning Medicaid reimbursement for community health workers. I would also like to thank Representative Datum for her leadership, and a personal thanks to Senator Heather Summers for not only her leadership on this particular issue, but her extraordinary leadership and support for the work on our opioid crisis. She's a true partner, and we're so grateful. As all communities, New London has been hard hit by the overdose crisis. In 2016, under the leadership of our mayor, Michael Passero, and Jen Maggio from Ledgelight Health District, Kelly Thompson from the Alliance for Living, we implemented an initiative, New London Cares, to help address the overdose crisis. We hired navigators who are community health workers, individuals who have experience and expertise in substance use disorder, to connect with our neighbors who are living with substance use disorder. The engagement, the trust, the consistency of a relationship with someone who cares has been so successful that you, the Connecticut legislature, thank you, have passed legislation to replicate and expand the model throughout the state. The initiative has also been so successful that in our own city, we are expanding the model to a public safety mental health navigator initiative. So mental health navigators will be working with our police on calls that have to deal with mental health issues. In addition, our community health workers assist individuals in our community who are unhoused, experiencing mental health issues, need assistance navigating the medical system, and connect people with food, internet, vaccinations, and jobs. It was raised earlier about the job piece. Having an individual connect our neighbors with workforce development not only helps individuals re-enter the labor force, but it helps address the workforce issues that we are dealing with in the state of Connecticut. During COVID, the work of the community health workers was invaluable. Getting people PPE, making sure they were tested, making sure that people had food. I can't emphasize enough the work that took place. The fact that the community health workers are embedded in the local health department and in community-based organizations makes a profound difference. So I encourage you not just reimburse community health workers who work in clinical organizations, but include health departments and community-based organizations as well. However, Connecticut's current Medicaid program does not reimburse community health worker services to incentivize healthcare providers to work with community health workers. And again, community health workers are an effective way to address inequities and promote health, particularly for low-income households served by Medicaid. May I also suggest, and we would be happy to sit down with you, Health Equity Solutions, the commissioner, I know conversations are already taking place, to discuss specifics, but could I suggest that the legislation also be expanded to include reimbursement to local health departments and community-based organizations, cover a comprehensive list of community services, reimburse at rates high enough to employ community health workers at a livable wage and cover the cost of supervision, billing, and routine training, and ensure that community and community health worker voices are involved in all stages of design and implementation. And I thank you again for the opportunity to testify, for all of your work, and happy to answer any questions.
Thank you so much, Ms. Milstein. It's so good to see you. We do have a question. Representative Dathan, go right ahead.
Thank you so much. Thank you, Jean, for your testimony today. I really appreciate you coming forward. I am looking at our state that we actually have a healthcare worker crisis. In your evaluation, do you believe that enabling reimbursement for community health workers would be a workforce development issue that could really facilitate this crisis we have in our state?
There's no question in my mind. Absolutely. And by the way, someone asked a question earlier about other states who have already done this. I believe that 25 states have done this, and you're absolutely right. It will help address a desperately needed workforce issue.
Thank you so much. I'm actually going to have a look into those states. I really appreciate that. In terms of setting rates for community health workers, are you familiar about how rates are set?
I am not, but I would defer to Health Equity Solutions and other experts on that, and happy to get back to you, of course.
Okay, great. Thank you so much for your testimony. Thank you, Madam Chair.
Thank you, Representative. I don't see any other hands. Thank you so much, Ms. Milstein, for being here today. Next, we'll go to Chris Edge.
Thank you very much. Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, Senator Gaston, Representative Nate Dathan, and esteemed members of the Human Services Committee. I'm a lifelong resident of Connecticut, and I'm speaking today as a proud foster parent of 18 years. The hardest job anyone can hold in our state is taking care of those who are in most need of not just help, but are in need of a friend, advocate, and a family. The nonprofit organizations, including Klingberg Family Centers, who we've called our partner for over 2 decades, become friends and advocates to children in the foster care system, and foster families like ours become their family, even if just for a short time. These nonprofits throughout our state provide vital services to our most vulnerable citizens who need your help today, and is in the form of Bill 6612. In the last session, a revenue retention bill was passed, but restrictions were put in place so that nonprofits who badly needed the funding had to give it back. If a nonprofit is able to do the work more efficiently than expected and have some funding left over, where do you think it will go? Back to those in our state in the greatest need. The unused funding is not going to go to trips, stockholders, or wasteful spending. This sector has been pinching pennies for over 2 decades, and you and I both know that unused funds will be used creatively to create new programs, hire new staff, and even come up with new ways to help the state save money. Give these firms who do some of the most challenging work in our state the discretion to use the funds as organizations to survive and thrive. The legislature, though well-intended, put an amazing amount of pressure on these same nonprofits as minimum wage increases in our state each year. An employee who made $18 an hour when others made $12 will be asking for $23 an hour now that others are making $15. This is not reflected in the increases the state of Connecticut provides currently, but the level of services expected by the state is the same, if not higher. 6612 will provide a reasonable amount of cost of living adjustment to these organizations that will be tied to inflation. If Bill 6612 is not passed, the nonprofit sector will continue every session to come to Hartford, send emails, letters, and bring lots of supporters to push this committee and the entire legislature for additional funding. This can help them to be competitive, in some cases, stay in business and provide services to others. I can say with no exaggeration whatsoever that without Klingberg Family Centers, we would have given up being foster parents after a month or less. With them and me and my wife's side, we've been foster parents for 18 years, adopting our first in 2019, and being able to say we are foster grandparents to another 6 wonderful children in the greater Hartford area. If you are not in the field of helping others in the nonprofit world, you cannot fully grasp the incredible inner strength it takes or the labor of love that goes in every day to do that work. I would ask you, have you ever met a rich social worker? Neither have I. Please do the right thing and move 6612 to the floor for a vote so that Klingberg and the other amazing nonprofits who work in the state of Connecticut can get not only what they deserve, but what they need to survive. A COLA which is not there, but but to inflate, tied to inflation, and continue to do this hard work for all of us. Thank you very much for your time and consideration, and it is wonderful to have all of you up at the Capitol, even in this crappy weather. Thank you.
Thank you, Mr. Edge. I don't see any hands. Thank you for your testimony and your time.
Thank you so much. Have a wonderful day, children.
You too. Next, we'll go to Mika Flashman.
Hi, everyone. Thank you for the opportunity to testify. I'm going to join others in the opposition to HB 6618, abortion funding for out-of-state low-income women. So last week, I had the pleasure of meeting with the Connecticut State Representative. Our conversation focused on the priorities of the Human Services Committee. Of all the wonderful work being done to improve the lives of Connecticut citizens, I was the most excited and grateful to hear about the efforts of this committee and of the legislature in general to fight to end human trafficking. Public Act 1326, 15210, 17131, 19108, and 2147, to name just a few, all representing countless hours of time and thought and energy and attention. Truly, thank God for all of you and this amazing work that you've done. Political affiliations aside, I know we can all agree that human trafficking is an unspeakable tragedy and one of the great moral evils of our time. I cannot fathom the untold trauma experienced by countless families who have fallen victim to this despicable behavior. The conversation then turned to HB 6618. I asked if this bill would risk counteracting the impressive strides Connecticut has made in its fight against human trafficking. I argued that given Connecticut's permissive abortion laws, which require neither parental consent nor notification, it seems clear that this bill would welcome those who traffic underage sex workers and victims. Protected against coerced abortions in their own state, young women will be brought to Connecticut and pressured to receive free abortions by the people who control them. Why would we risk inviting some of the most nefarious characters on the planet to our state? Why would we risk becoming a destination for the victimization of low-income women? Which Connecticut citizens will benefit from this allocation of resources? I can think of only one group: abortion providers. Considering the 32% reduction of on-site abortions in Connecticut over the past 10 years, it's understandable why Connecticut's abortion providers would pressure this body to backfill that revenue by paying for the abortions of out-of-state residents. Does the interest of this tiny fraction of the population override the public safety interest for the remainder of Connecticut's 3.6 million citizens? If one person is kidnapped by human traffickers while they are here on an abortion tour of Connecticut, all expenses paid courtesy of Connecticut citizens, then this bill is an utter disaster. For Connecticut to grow and remain competitive, we need to increase our human capital. Perhaps a better use of this money would be to fund life-saving healthcare for low-income pregnant women who want their babies to live. Maybe these children will grow up to become productive members of society, innovators, entrepreneurs, or legislators right here in Connecticut. I'm sure there is pressure from various special interest groups to vote for this bill. I hope you can see that this is unacceptable. For the sake of the victims, please vote against this bill. The lives of many innocent people depend on it. Thank you.
Thank you, Mr. Flashman. I don't see any hands. Thank you for your testimony and your time. Next, we'll go to Heather Latora. Go right ahead.
Good afternoon, Madam Chair and members of this committee. My name is Heather Latora, President and CEO of Marrakesh Incorporated. Marrakesh partners with DDS, DEMAS, DCF, DSS, and others to provide services to adults and youth with disabilities and with similar service needs in Connecticut 24/7, 365 days. Thank you for the opportunity to provide testimony in support of House Bill 6612. The clawing back of surplus funds from nonprofit discussion seems like deja vu all over again. It gets approved, yet the implementation is interpreted and carried out differently by each state agency. We submitted 2 requests to funders for revenue retention this year. Thankfully, one request was granted from DCF, about $70,000, and one is still being considered by DEMAS, even though the fiscal year ended 6 months ago. That's $120,000. Imagine trying to run a company on a retrospective review on how to pay for an HVAC system, building repairs, and a 401k contribution for your employees who have not received one since 2016. One huge expense that we are experiencing but isn't funded is with private landlords. Many of the people we support need safe and affordable housing, and landlords need security deposits, full rent, even if the apartment has a vacancy, and other incidentals. The people we support cannot afford this, and neither can we. We've experienced landlords ending their leases with people with disabilities, especially since COVID. It would be beneficial to be able to save some of our surplus funds for this purpose. This is actually holding up 5 people from moving as we speak today. House Bill 6612, if passed, will hopefully lead to better outcomes for providers, their staff, and the people they serve. I am also testifying in huge, huge support. I've been working at Marrakesh for 37 years, so huge support for Section 4 of this bill, which would index the rates the state pays for contracted nonprofit health and human service providers to inflation, providing increases automatically with inflation. The failure of ensuring future indexes to our rates and budgets is exactly what got us into this mess in the first place. Human service providers had 0 budget COLAs from 2008 to 2021 for both DMIS and DDS budgets. To make matters worse, our expenses are going up. Our preventative maintenance has suffered. Our 650 employees have suffered and for the past fiscal year, and people and families have suffered waiting for services, a long waiting list, which we never had before. Yes, the people we support with disabilities and our staff are considered discretionary when looking at the Connecticut state budget. People are not discretionary, and indexing rates would support that theory. COVID just proved how mandatory we all are. By accident, Connecticut has been weakening the nonprofit providers that the state needs to provide quality and cost-effective services to most service recipients in the entire state. That needs to be reversed. Thank you for the opportunity to testify in support of this important bill, and please support House Bill 6612.
Thank you, Ms. LaTorra. We do have a question. Representative Dathan, go right ahead.
Thank you very much, Madam Chair. Nice to see you today, Heather. Sorry I'm not there in person, but the weather prevented me from getting to Hartford this morning. Just wanted to ask a question in regards to the bill. DSS said that if this was implemented, it would remove the state's ability to craft contracts to maximize quality and value for recipients and taxpayers. Can you please give me some examples how in your experience that this would be the case?
I'm not sure about the contract process and the legal aspects to that, but being able to finally review this year with funding sources about how to best use this money and what we are spending it on, and also reviewing what we're spending it on. It's not that we are going to go buy new, I don't know, cars and stuff for our staff. It is definitely related to service and quality of service. And I gave an example of being able to pay to reserve money for landlords so people can have safe, affordable housing. And that's a huge problem all over the state of Connecticut.
Yeah, I was thinking, I mean, just in my financial experience, I was thinking that enabling local agencies, local nonprofits to retain funds would actually help them reduce their cost in a longer term basis that maybe could actually even help the state save money for longer term contracts versus a shorter term contract. Do you have any opinion on that?
Absolutely. Unfortunately, our preventative maintenance has suffered. And so when we are repairing things, and sometimes it's emergency repair, and being able to have that surplus for a problem instead of waiting and waiting and waiting till it's a real major catastrophe is definitely important. And we are audited. Every single penny that we spend has a receipt, has a process. We had, besides our regular audits, we've had major audits on an annual basis for the past 3 years. I mean, there's not one penny that is under the carpet, not being managed by our state and by our auditors and outside auditors. So I know it's for good. And we have, Marrakesh alone has 52 years of doing good work in Connecticut and helping people. And so do our counterparts.
Great. You actually answered my third question, which I wasn't allowed to ask anyway. So thank you so much for your testimony. Thank you, Madam Chair.
Thank you, Representative. And thank you so much, Ms. LaTorra, for being here.
Thank you so much.
Have a great day.
You too.
Next, we'll go to Matthew Blinn-Strubus.
Thank you.
You're welcome.
Hi, hello, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Matt Blinn-Strubus, and I'm the Executive Director of Equality Connecticut, a grassroots organization that works to advance the rights, health, and history and culture of LGBTQIA+ people in the state. And I'm testifying today in support of House Bill 6617, an act promoting equity and coverage for fertility care. This bill allows equitable access to fertility care for Connecticut residents, enabling them to expand their families. The existing fertility coverage statute, while a positive development to expand access to health care, is discriminatory toward the LGBTQIA+ community and single individuals seeking reproductive care, as it covers infertility for couples who are defined as suffering from infertility based on a definition tied to heterosexual relationships. This outdated definition needs to be updated, and 6617 aims to do just that by providing equal access to fertility services for all individuals, regardless of their sexual orientation or relationship status. Connecticut has already made updates to other laws regarding modern family formation, and it's time for the state's fertility insurance regulations to follow suit. HB 6617 aligns with the actions of private companies that acknowledge the significance of ensuring equal and inclusive access to fertility care, particularly for the LGBTQIA+ community. Many Connecticut employers have already taken the initiative to provide comprehensive fertility care coverage for their employees voluntarily. HB 6617 is a concrete step toward providing equitable access to fertility and reproductive health care for all, including those in the LGBTQIA+ community. This legislation would guarantee that everyone has the medical care they need to build their families, regardless of their sexual orientation and gender identity. By removing barriers and promoting inclusivity, 6617 ensures that every individual has a chance to start a family if they choose to do so. And thank you very much for hearing me.
Thank you so much for being here. I don't see any hands, so thank you so much, Mr. Blinn-Strubus, for being here. I'm going to turn it over to Senator Lesser.
Thank you, Madam Chair. If you might bear with me for 1 second.
We already did number 12, so you're going to number 13.
Okay, so next up we have C.M. Kurowski.
Hi there, can you hear me?
Yes, we can.
All right, members of the committee, I'm Marcella Kurowski. Thank you so much for the opportunity to speak today. I oppose HB 6618 because this is a misuse of tax money. It is possible that tax relief could benefit Connecticut's economy because disposable income often results in more dollars circulating through a local economy. I also oppose the promotion of abortion because I believe that to promote the termination of a pregnancy is to promote the use and abuse of women. The fertilizing partner is allotted no responsibility for the conception because the female can, quote unquote, just have an abortion. Also, abortion has many physical, emotional, and psychological risks associated with it. Some risks may include the following: infection, heavy bleeding, incomplete abortion, damage to the cervix, scarring of the uterine lining, perforation of the uterus, damage to internal organs, sterility, allergic reaction to medication, death, and post-abortive syndrome, which can include symptoms of depression, guilt, denial, suicidal thoughts, flashbacks of the abortion, avoidance, substance abuse, unhealthy relationships, sexual dysfunction, sadness, and eating disorders. Thank you so much for your time and consideration today.
Thank you for your testimony. Are there questions or comments from members of the committee? And I'm not sure if there's anyone in the room. Maybe the clerk could let me know if there's anyone in the room who's looking to it.
No, Matt, there's nobody here.
Okay. All right. Well, thank you very much for your testimony.
Thank you, Senator Lesser. Bye.
Next up, we have Noah Fleischhacker, followed by Ollie Gray.
Thank you. Good afternoon, Senator Lasser, Representative Gilchrist, and distinguished members of the Human Services Committee, and thank you for your time. My name is Noah Fleischacker, and I'm testifying in support of Raised House Bill 6617. I'm the executive director of Tight Lift, which is a grassroots organization by and for people who have vulvovaginal and pelvic pain conditions. This bill would make it possible for people like me living with vulvovaginal pain to access fertility care. I have something called pelvic floor dysfunction, which is a condition that causes a number of different symptoms, including vaginal pain. That can mean that any kind of vaginal insertion, like penetrative sex, is extremely painful and almost completely impossible. For example, the only time I was ever able to tolerate a pelvic exam was under general anesthesia. This is a chronic condition. It's something that I will likely be dealing with in some form for the rest of my life. I also likely have undiagnosed endometriosis, which often overlaps with pelvic floor dysfunction. Vulvovaginal and pelvic pain are extremely common. Up to 1 in 4 women in the United States will develop chronic vulvovaginal pain at some point in their lifetime. But since these conditions are so stigmatized and really hard to talk about, many people struggle in pain and in silence. Every single day in my work, I receive messages from patients who want to have children, but can't afford the medical treatment that they would need because they have vulvovaginal pain. I've spoken to many women who have struggled through excruciatingly painful sex in attempts to become pregnant, and many people see that as their only option and force themselves to endure excruciating pain, burning pain, searing pain, which can often last for days at a time in the hopes of starting or growing a family. This issue is about essential care to enable people like me to have safe and healthy pregnancies. Since starting treatment in my mid-20s, I've known that I will need medical care in order to conceive and carry a healthy pregnancy. However, it's extremely expensive and very hard to access this kind of care. I'm currently in something called pelvic floor physical therapy. I take medications, and these are treatments that are necessary in order for me to be able to become pregnant. I've already spent $8,000 out of pocket for these kind of treatments, and at every step of the way, I've struggled to receive insurance coverage. I've known forever that I want to have children, but knowing how difficult it has been up until this point to access care, I can't imagine how difficult it will be when I'm actively trying to conceive. I recently moved to Connecticut, and I'm incredibly excited and moved that this bill is being discussed. It's an enormous incentive for me and for people like me to build my life and start my family here in Connecticut. I strongly support Raised House Bill 6617. And as someone who has chronic vulvovaginal and pelvic pain and works with people with these conditions, I strongly support coverage of these conditions as a form of fertility treatment. Thank you for your time.
Thank you, Noah, for your testimony. We made a number of changes a few years ago, I think in 2017, to try to get iatrogenic, that's coverage of fertility treatment, but that you're saying that that's not available for folks right now with your condition?
No, not for people who have endometriosis, chronic pelvic pain, or chronic vulvovaginal pain conditions.
And is that, when you say that, does that come from the insurance commissioner, or is that, I believe you, but I'm just trying to understand where you're looking to for that information.
That's a good question. I don't feel like I can best speak to that. I mean, there's a lot of difficulty accessing insurance coverage for these conditions, even if you're not trying to get pregnant. And so often people who have these conditions struggle to get any form of treatment. And we're not just talking about IVF, but also things like pelvic floor physical therapy and other kind of pelvic pain treatment covered is very difficult, even if you're not attempting to get pregnant. So I'm not sure specifically, but I know that it's very hard to get any insurance coverage for these conditions.
And are those last 2 treatments that you mentioned, are they covered by this bill?
Like one interpretation of this bill would be covering expansive fertility care. So that would include pelvic floor physical therapy. That would include other forms of treatment for vulvovaginal and pelvic pain.
Got it. Thank you very much. Any questions from members of the committee? If not, thank you for being here this afternoon.
Thank you.
Okay, next up we have Ollie Gray, followed by Reverend Robin Anderson.
Ali isn't present.
Is Reverend Anderson present?
Yes, I am.
Hello,
Good. Hello there. How are you, Senator Lesser, and again, Representative Gilchrist, and all committee members? Again, my name is Reverend Robin Anderson. I'm the Executive Director for the Ministerial Health Fellowship, and I am here in support of Bills SB 991. It is to me so essential that we pass this bill for to continue to retain and have community health workers here in Connecticut. We know that there are several other states that have already saw the need to have that, and to have it as cost reimbursement through Medicaid. This is so important because as I think about the pandemic and the times that we were in, and there were so many people of color that were dying at rapid rates, and that we had essentially had a real great problem in terms of getting people of color to the vaccine clinics. And it was through the community health workers that went door to door in neighborhoods, speaking to family, transporting persons, educating them about COVID, where they can get tested, and also where the vaccine clinics were. And not only that, but also getting them there, that we were able to get many people of color vaccinated. As we talk about health equity, and as we talk about health disparities that have existed for over 400 years, really, especially amongst people of color, not feeling like they have understand the system that's before them, the healthcare system, not feeling that they have been treated right in the healthcare system, not really feeling like they understand the healthcare system or even have access to the healthcare system. And even as it relates to signing people up for insurances, the community health workers have been essential in helping people to understand what insurances are available, how do they sign up for insurances, helping them get through the process of signing up for insurances. And then we also have our community health workers that also are very essential of making sure people go to their appointments, accompanying their appointments. And to me, this is essential as we think about really addressing health disparities and really helping people to live and not die. The way our healthcare system is, it is very complicated. It's not always, so friendly to kind of navigate through and to get through. And to have a community health worker in your community that's able to help you navigate the system, also to be able to advocate for health care and to get you where you need to go, it is important. So I am in full support of SB 991. Thank you so much for allowing me to share.
Thank you, Reverend Anderson. Are there questions or comments from members of the committee? Yes, Representative Dathan.
Apologies, rookie error. Thank you for your testimony today. In your description of how the community healthcare workers facilitate people getting the vaccine within the community, do you believe that they also helped folks identify when they should go get medical care in a little bit more speedier fashion than maybe they would have done?
Yes, we had the community health workers have helped many people to reconnect with the healthcare system. There have been many people that we have worked with that have not been to the doctor for years, that also use the emergency room because they don't have primary care doctors. And so the community health workers are able to not only help them get connected to a primary care doctor, but also to get them to go to the doctor, in many ways accompanying them to the doctor because of their, fear of doctors, and also the way in which they feel like they have been treated, especially Black males.
That's really helpful because I feel like sometimes those early interventions really do help overall lower the cost of healthcare because people are getting ahead of the treatment and getting ahead of the chronic emergency. So thank you so much for your testimony today.
Thank you. Thank you. You're absolutely right. Especially when you think about people going to the emergency room because they don't have primary care doctors right there. Just being able to connect them to a primary care doctor saves a lot of money.
Fully agree. Thank you so much. Thank you, Mr. Chair.
Thank you, Representative, and thank you, Reverend Anderson. At this point, I'm going to pass the baton back to Representative Gilchrist.
Thank you.
We will now go to Rashad Gibson.
Good afternoon. My name is Rashad Gibson. I'm the founder of United America, and I am testifying in regards to HB 6618 in opposition to it. There are several reasons why I'm opposing this bill. And the very first thing I want to state clearly is I have some rhetorical questions that will state to kind of frame my argument. Have anybody seen an actual abortion being done? Have we seen the dismemberment of these babies, or as some of you may say, fetuses? Have we observed this? And the reason why I bring that up, because when I was thinking about my argument this morning, I could not get the images out of my mind. When I thought about this, I said, if anyone can observe the actual event and walk away from that and still believe this is a humane event that's using taxpayer dollars to fund, that at best, that is a lack of humanity, and at worst, is borderline psychopathic. So when I think about what's going on, and especially as this being a civil law issue, the one thing I would consider is this: when it comes to civil law, it's based off of moral law. Without moral law, you have no civil law. So when we consider these ideas of funding this bill with $2 million worth of taxpayer dollars, in my opinion, it is absolutely absurd, because it is not in sync with the moral law as you all being civil lawmakers. So with that being said, thank you for giving me the time to testify, and I appreciate it.
Thank you, Mr. Gibson. Representative Mastro Francesco, go right ahead.
Thank you, Madam Chair. Thank you, Rashad, so much for your testimony. When you were telling your story about people seeing how an abortion is performed, it reminded me back many, many years ago when I took a public speaking class and I had to speak in front of everyone. I had to pick a couple of topics. So I felt that the best topic for me to do would be something that I'm uncomfortable with, would be abortion. And I actually did that. And I did a lot of research and I watched a lot of videos back there. And it was at that moment that that procedure stuck in my mind. And it was absolutely horrible. I'll never forget it. And from that day forward, and I was probably 20 years old at the time, wow, I had a whole different perspective on it. So I truly understand. And I certainly agree with you 100%. I think it's just horrible that we're actually even paying for this with taxpayer dollars. Well, regardless of how people feel about abortion, I mean, it's just not right. But I appreciate your testimony. And I just wanted to mention that it reminded me, and that, you know what, when you see something like that, it sticks with you forever.
Absolutely.
And hopefully that message will transcend to other people. Thank you so much, Rashad. I appreciate it.
Thank you.
Thank you, Representative. I don't see any other hands. Thank you so much, Mr. Gibson. Have a great day. Next, we'll go to Manya Saunders.
Good afternoon, everyone. Are you able to hear me well?
Yes, we are. Go right ahead.
Good afternoon, Senator Lesser and the representative, everyone who's on the call for Human Services. My name is Manya Saunders, and I live in New Haven, Connecticut, and I'm here to testify in support of the SB 991 Act concerning Medicaid reimbursement for community health workers. As I am testifying on behalf of Transitions Clinic, which provides primary care to Connecticut residents returning home from incarcerations. We have clinics in Bridgeport and New Haven and Hartford. I am a community health worker. I am proud, and I'm a proud community health worker doing what I do. I support men and women as they transition from incarceration back into our communities, and I connect them to healthcare. My work saves lives. I was just hearing another woman as she spoke, the Reverend, I believe, how you know, during the COVID time, what we had a project in our transition clinic where we had you know, went out to the communities to help and support and give people knowledge of the COVID vaccination, the social distancing, the safe social distancing, and just was out there in the community and persuading people to get vaccinated, give them the facts and the myths of this vaccination, trying to make people feel comfortable and also find out what are the barriers or why you don't want to get vaccinated. Having lost my mother to COVID in the first round of COVID, I was very adamant and persuading people to please get vaccinated. So that's another thing I did. I just want to kind of piggyback off the other one who spoke earlier. So I'm a proud community health worker supporting these folks. And I feel like just in my work, the support that we give them and the services that we can supply for them is something that I feel like people just don't have time for. The doctors, social workers, we're out there, we're in the street. I'm in the streets, trying to reach these people, getting them health care, giving them knowledge for diabetes, diabetics, different things that, that can help them and also prevent, ER visits. We're out there on the pavement, trying to save lives. I go into the prisons and speak to women who are about to come home. I introduce myself to them. And I also share my own personal story, where I had struggles in the past and as a formerly incarcerated woman, some 20 years ago. But, I just feel real adamant that we are on the front line to, work with the doctors and other people in the communities to help, save this population of people. And also having the experience of, transitioning from incarceration, knowing what it's like to be inside away from our family and our children, then to come back into this community feeling with no support. It's been 20 plus years for me, but I wish there was a community worker when I came home, or even come to the prisons when I was in prison, to give me hope, saying, when you are released, call me, we're going to be able to do this and do that, and to help me transition, a smooth transition. If it's just nothing but support.
Time has expired. Could you just please summarize?
Okay. So I just wanted to get up here to let people know I'm a peer. I'm not above them, but Transitions has created a plan for people coming home. And what we do, I feel, is very vital and important, and it is essential. Thank you for letting me share.
Thank you so much for your work and your testimony and your time. I don't see any hands, so thank you again. Next, we're going to go to McKay Lee.
Hi, good afternoon, co-chairs and other members of the committee. My name is McKay Lee, and I am the Associate Director with the National Coalition for Assistive and Rehab Technology, or NCART. NCART is a national nonprofit organization that seeks to ensure individuals with disabilities have access to complex rehab technology products and supporting services, such as individually configured manual and power wheelchairs and related repairs. In pursuit of that goal, NCART operates by collaborating with suppliers, end users, manufacturers, and clinicians, along with federal, state, and private policymakers to establish and protect appropriate coverage, funding, and supplier standard policies. I'm testifying today in opposition of House Bill 6702 that initially proposed consumer right to repair for power wheelchairs. That bill now has some pending amended language that we're looking forward to reviewing and discussing with the advocates who brought it forward. Thank you for the opportunity to provide the following comments to you all today. First and foremost, we acknowledge the very real challenges that individuals are experiencing in accessing repairs and services for their equipment. We also agree that when wheelchair repairs are required, it's essential that those repairs be completed as quickly as possible in order to protect the health, safety, and independence of the individuals who are utilizing them. However, we have some concerns with the way that the legislation is currently written and respectfully request that HB 6702 not advance until committee members, advocates, providers, manufacturers, and other stakeholders have been able to meet and discuss solutions that address the root causes of this issue and create a safe, reliable, and affordable process for individuals to act on when their wheelchair is in need of repair. NCART and others have already begun identifying policy action that can be taken to significantly improve access to repair services for wheelchair users within the existing structure. These options include some of the ideas that have already been mentioned by others today, including relieving and reducing administrative requirements related to insurance coverage, and addressing insufficiently supported provider networks. Improving in these areas and others in existing policy would streamline access to reliable, safe, and affordable repairs that ensure individuals are able to get back to their daily lives as quickly as possible. NCART and our members remain fully committed to collaborating with all other stakeholders on identifying advancements that promote access to these critical services. I thank you again for your time today, and I'm happy to answer any questions.
Thank you so much, Ms. Lee. I don't see any hands. Thank you for your testimony and your time.
Thank you.
Next, we'll go to Deirdre Ducharme.
Thank you so much. Good afternoon, Senator Lesser, Representative Gilchrist, and other distinguished members of the Human Services Committee. My name is Deirdre Ducharme, and I greatly appreciate raising the bill HB 06702, which addresses a serious problem for consumers whose lives and safety is dependent on safe, functioning wheelchair. Wheelchair users and their advocates have been carefully considering the right to repair bill and are in support of a different approach to this bill, which holds the dealers accountable for services they provide. This level of responsibility will more effectively benefit the people with mobility disabilities requiring the use and repair of wheelchairs that they rely on. For example, my sister was diagnosed with muscular dystrophy in her mid-20s. She is now 45 and lives alone in a handicap-accessible apartment. She was fitted with a customized power wheelchair by New Motion nearly 3 years ago that was intended to keep her safe and allow her to live as independently as possible. However, I am seriously concerned about her safety, and given the frequent malfunctions, including broken seatbelts, broken shocks and casters, malfunctioning joysticks, which is the operating system of the wheelchair, and inoperable batteries. My concern is more than just the repairs to the wheelchair, but New Motion has not been responsive to her request, nor have they made an attempt to repair the malfunction in a reasonable, timely manner. She has been stranded outside her home in the winter for more than an hour when the steering mechanism broke. She was trapped inside her kitchen pantry when the wheel spun and wouldn't move. And in some cases, she relied on strangers to help. But each of these scenarios placed her at a substantial safety risk of injury. She waits for days for customer service to return phone calls and months for technicians to make repairs. If there isn't a loaner wheelchair, she has no choice but to live her life in a bed without access to her kitchen and bathroom, and is at a greater risk for falling if attempting these spaces without her wheelchair. The longest repair issue spans from November 2020, when my sister was first fitted for a wheelchair, to current day, February 27th, 2023. Initially, the foot plates were not conducive to the positioning of her legs and feet, which caused them to drag on the ground and has caused disfigurement. From November through 2021, she couldn't use the foot plates because they hurt too much. Even with repeated requests to New Motion to adjust the foot plates, they have not responded, nor have they conducted a re-evaluation. After 18 months, this issue has not been resolved. In light of their negligence, she experienced substantial leg and foot pain, strain on her legs and ligaments, and difficulty transferring from her wheelchair. The lack of proper foot plates has caused physical deformities to her feet, which will only worsen without the—
Can you please summarize?
Yes, thank you. Without the revision to Bill HB 06702, the current bill will further compound an already failed process. Thank you for taking the time to let me speak with you today about this bill.
Thank you so much. And I think so it's Ms. Ducharme. Got it.
Yes.
I don't see any questions. Thank you for your testimony and your time. Next, we'll hear from Ruth Grobe, followed by Ralph Carlo.
Thank you very much. Representative Gilchrist, Senator Lesser, and members of the Human Services Committee. My name is Ruth Grobe. I live in Farmington, and I am the secretary of the Citizens Coalition for Equal Access, which is a small grassroots disability advocacy group. And I'm testifying in favor of the substitute language for HB 6702 about wheelchair repair. But mostly as an able-bodied person, I'm testifying in favor of the videos that are going to be submitted later in this public hearing by people with disabilities who are part of the Citizens Coalition for Equal Access and live at New Horizons Village in Unionville, because it is their experiences that have gotten me so concerned about this issue. Although there are only 3 videos, there are actually 9 people who are going to testify on those videos. And the videos were made before the substitute language was introduced. And there was neither the time nor the manpower to change the videos. But I know 5 of the 9 people testifying are members of the Citizens Coalition for Equal Access. And I know that they will support whatever language seems to be the best solution to this very pressing problem. And my final thing to say is that as an able-bodied person, I managed to spend a great deal of my life unaware of the many barriers in this society that still exist for people with disabilities, and especially how often they are dismissed or disregarded even by the companies that are supposed to be serving them, like the wheelchair repair companies. So anything that can be done to hear their voices and address this issue, I very much appreciate. And I thank you for taking my testimony today.
Thank you, Ms. Grobe. I don't see any questions. Thank you for your testimony and your time. Ralph Carlo, followed by Liz Gustafson. Ralph, are you with us?
Good afternoon. Can you hear me now?
Yes, go right ahead.
I am very sorry. Good afternoon. My name is Ralph Carlo. My wife, Jennifer Tracy Carlo, and I are 3rd-generation owners of Tracy Energy. Tracy Energy is a 92-year-old heating oil and service company based in New Haven. Jen and I have been operating our company since 1987, after we started working with her father, who was the 2nd generation. Tracy has been a vendor of Connecticut Energy Assistance Program since the early 1970s. I have testified several times in the past years about this program. I am here today in support of HB 6073, an act concerning the low-income home energy program. But I would specifically want to focus on the margin over rack pricing mechanism. Since this pricing plan has been put in place over 20 years ago, more and more risk and price exposure has been put on heating oil dealers. However, other energy providers are paid their full retail price, like natural gas, electricity, propane, and kerosene. Only heating oil vendors are mandated to a fixed discounted margin. Why does DSS make small family oil dealers subsidize this program? It is an unfair policy that needs to be remedied. Oil companies are put on a pricing mechanism that puts a financial strain on us to participate in.
Mr. Carlo, you got muted. You're
Okay,
back.
I'm not sure how that happened.
You can continue.
Tracy Energy only participates in order to take care of our customers that are eligible for this heating energy help. We would just like to be treated fairly and not to be asked to shoulder the burden of the pricing risk. While the increase from 35 cents to 45 cents last year over rack and now 50 cents this year is appreciated, it is still asking us to make deliveries at a significant discount. And on some days, depending on timing and volatility of the market, we can be delivering at cost or a loss, actually negative. Utility companies do not have to worry about this. Propane and kerosene companies do not have to deal with this. Why do heating oil companies get punished for participating in this energy program? Thank you for your time today. I just wanted to make a statement just with regards to today's price. Today's price came out yesterday at $3.42. During the course of the day today, it's gone up 5 or 6 cents. Now it's back to being flat. But depending on when we pick up the oil from our vendors, the price was put out yesterday for deliveries today, but my delivery cost is in today's time, not yesterday's. I think this is something that really needs to be remedied. I'd really rather see us be at our retail price, not this margin over rack. It's not fair. Nobody else has to do it. I don't see why heating oil companies are faced with this. I would love to have any questions.
Thank you, Mr. Carlo.
Thank
Senator
you.
Lesser, go right ahead. He does have a question.
Yes, hi, Mr. Carlo. Thank you for your testimony and for your advocacy here. Were you here earlier when the Commissioner of Social Services testified with her response to some of this stuff?
I was for parts of it. I was also here when the gentleman from DSS was talking about the margin over rack program and the increases that had been put in place.
So when they say that when he argued that the changes are unnecessary, you disagree?
I totally disagree. I mean, there's other people who have mentioned this, but there's a list of things. It's diesel fuel, insurance costs, new taxes on the highway, for over road use. There's multiple reasons why we shouldn't be even on a margin over rack. But if it is, it should be more like 75 or 80 cents like the other states in New England. There's 3 states that get full margin. There's some that are or 2 that are at 75 cents over. And I believe Rhode Island can set the price based on a cash basis. Connecticut's the only one that I know of that's this low and still doing this margin over rack.
Thank you very much. Very appreciate it. Thank you, Madam Chair.
Thank you.
Thank you, Senator. Thank you, Mr. Carlo. Thank you for your testimony and your time.
Appreciate it. Thank you.
Next, we'll hear from Liz Gustafson, followed by Matthew Butler.
Good afternoon, Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Liz Gustafson, and I am the State Director of Pro-Choice Connecticut, and I am here to testify in support of HB 6618 and HB 6617. The decision regarding if, when, or how to start or grow a family is one of the most important life decisions we make, and everyone should be able to make that decision without stigma, barriers, or political interference. We are grateful to the Lamont administration's commitment to protecting and expanding access to comprehensive reproductive health care and exploring the opportunity to act in response to President Biden's executive order on securing access to reproductive and other healthcare services, which includes the provision of federal Medicaid funding for cross-state travel for people with low incomes seeking sexual and reproductive health care. Abortion access in the U.S. has long been inequitable, due in large part to systemic racism and insufficient protections for low-income individuals, which has led to insurmountable barriers for young people, Black, Latino, and Indigenous people, the LGBTQ+ community, and people living with disabilities. Since the Supreme Court's decision to overturn Roe, the landscape of abortion access continues to rapidly and drastically change, as a total of 18 states have either banned or severely restricted abortion access. We are already witnessing the harmful impact of abortion bans, including difficulties faced by individuals seeking life-saving medical care for miscarriages, ectopic pregnancies, and other pregnancy complications. Additionally, research has shown that being denied an abortion can have devastating economic consequences and drive people deeper into poverty, as well as significantly impact an individual's mental health and physical well-being. Financial and geographic barriers should not prohibit people from accessing the essential health care that they need. While we navigate a reality without Roe, Connecticut providers continue to show up for patients regardless of who they are where they are from, or how much money they make. And it's our responsibility to show up for them. It's paramount that we pursue solutions that increase access to abortion and pregnancy-related care and invest in the infrastructure and long-term sustainability of abortion care providers. As mentioned, all people making pregnancy-related decisions should be provided with all of the resources they need for each and every option, which also includes access to fertility care. HB 6617 would clarify and codify coverage for the procedures and storage necessary for state residents who receive a medical diagnosis or treatment that can impair fertility, would expand eligibility for single individuals and LGBTQ+ families, and would ensure people who are insured through Husky will have equitable access to coverage. People deserve safe, thriving communities where they can seek the full range of pregnancy-related care and raise their families with safety and abundance. Pro-Choice Connecticut urges the committee to support HB 6618 and HB 6617. Thank you so much for your time and consideration.
Thank you, Ms. Gustafson. Representative Master Francesco.
Thank you, Madam Chair. Thank you so much for your testimony. I just had a quick question for you, and just really one comment. So this bill that we're talking about today, 6618, is not about providing abortion in Connecticut. Connecticut already has abortion, right? You're in Connecticut, you can have an abortion. So there's no question about that. The Connecticut laws are there, and they don't differ. The question here is providing abortion services for out-of-state residents. That's what this bill deals with. So I'm just curious. So you are from Connecticut, pro-choice?
Pro-Choice Connecticut, yes,
Pro-Choice
that is
Connecticut,
correct.
and you're the state director on that, correct?
That is correct.
So does your organization help people looking for those services? Do you guys pay for that? Do you fund that?
We do not. We are not an abortion fund, no.
You do not. So the question here is people coming from out of state. So if your organization had funds for that, would you supply abortion services for people coming from out of state?
Well, we are an education and advocacy organization, so we do not provide direct service, but we advocate to expand access to care for both in-state and out-of-state residents.
Okay, I just wanted to clarify, this bill is not about questioning whether or not you can legally have an abortion in Connecticut.
Right,
This bill is about funding abortions for people that are not residents of this state, for out-of-state people. So I just wanted to clarify that. Thanks so much for your testimony, for hanging in there. Appreciate it.
Thank you for your question.
Thank you both. I don't see any hands. Thank you so much, Ms. Gustafson, for being here today. Next, we will hear from Matthew Butler.
Hello, my name is Matthew Butler. I am one of the owners of Ives Brothers. We are located over in Willimantic and have served the surrounding Windham region since 1917. I am here in regards to HB 6703. As a vendor that had been doing the program since it was originally known as, I believe, WACAP, I had to make the heart-wrenching decision this year to not do the program after so many decades because I just couldn't afford it. The daily price volatility, I don't even want to think about how many times I was delivering for free last spring. On June 30th this year, when the program was fortunately not running, the difference between New Haven's average and the Wethersfield terminal was 72 cents. July 1st, the day the tax on diesel went up by 9 cents, the difference to the average was 58 cents. On even November 1st, when the program started, the difference between the average and my terminal was 34 cents. I'd have been giving that back to the program. And on December 6th, it was 43 cents. I then still have to get the oil to Willimantic to deliver to the customers. The midday increases have been killing us. Last April, there were 15 days, half the month, that had a midday price increase. Even yesterday had a small one, and Friday had a small one. I happen to be in an area that's at the intersection of 3 counties. So within a mile of my office, I get paid 3 different prices to deliver to the customers. If we cannot at least do retail for the oil, we at least need to do a discount off of the retail instead of over a average price, because it just doesn't work anymore. It was the most difficult business decision I've had to make to not do the program this year, but I just couldn't afford it for the sake of all of my customers. Electricity is getting full price. How come we can't do something? Between February 28th and March 9th, the terminals went up $1.84 last year. The margin over rack did not keep up. And we ate that difference. Between the 28th and 29th, the midday price on the 29th, that was a 68-cent difference from the morning of one day to noon on the next. And what we were going to be paid was based on an average. We then got to wait 20 to 30 days to actually receive that money.
Mr. Butler, your time has expired. Can you please summarize?
The program needs help. I mean, I want to help my customers, but at the moment, I just can't afford to.
Thank you so much for being here and sharing your testimony. I'm going to call on Senator Marr.
Thank you so much, Representative Gilchrist. Mr. Butler, I want to thank you for the work that you've done, because I used to run a nonprofit, and in that nonprofit, we would we would contract with services such as yours to deliver fuel to families. And I know the desperation of the families, and I know the strain on the service providers of the fuel. So I want to thank you. I also want to recognize what a difficult decision it was for you not to do this, not to serve the clients this year, when you had to choose between your company and doing really good work. So really no question, just a huge thank you for all the years you've done this, and an understanding that there is a huge price to pay for providers, and we hear you.
We are still doing Operation Fuel, Catholic Charities, Soldiers and Sailors. We're doing what we can, but with the LEHEAP program, we just can't until it gets fixed.
Totally understood. Thank you so much for everything you've done.
Thank you for hearing me.
Thank you, Senator, and thank you, Mr. Butler, for your testimony and your time. Next, we will hear from Pam Fields, followed by Ivelisse Correa.
Is that on?
Yes, go right ahead.
Good morning, Representative Gilchrist and Representative Cook and members of the Human Service Committee. I'm Pam Fields, the CEO at Midstate ARC. Thank you for the opportunity to provide testimony in support of House Bill 6612. One of the sections of this bill would allow for nonprofits such as Midstate to retain any savings and reinvest them into improving the quality of our valuable services. When cost settlement was established, all providers were under contracts and had slots. The state would pay the agency for a set number of slots, whether or not the person attended. At that time, cost settlement made sense because we were paid for services we did not provide. However, that's not the case anymore. We are paid on an individual per person basis on fee for service. If they do not come into our programs, we are not paid. Now the cost settlement does not make sense, and it is really clawing back money for services that we've already provided, and it destabilizes the entire system. I do not think this happens with other contracts such as paving roads. They are for-profit companies paid an agreed upon amount, and the state does not take back the money at the end of the job if they have any left over. But it does take back money from the nonprofits every year. I feel it is unfair treatment, and I do not understand the legality of this. I am also not understanding why we cannot reinvest any savings when we are not paid for the real cost of services, which is covered in Section 4 of this bill. If the state is not going to pay for the actual cost of service, why would the state not allow us to reinvest when we have a rare savings? This ask to the legislature has always been simple. Nonprofits should be able to reinvest savings they have while meeting their contractual obligations, thereby improving their quality of valuable service. If the state is not going to pay for the true cost of service, and the state will not let us reinvest any savings, how do you expect quality programs with quality services? It just doesn't make sense to me. The state wants us to perform as a legitimate business, but pay us as a begging charity. Our ask is just good business. Our state needs to pay for the services it contracts for so that agencies can provide highly effective programs that support the health and safety of the people we service, the staff supporting them, and the fiscal stability of the agency oversight. Thank you for the opportunity to testify, and please support this important bill.
Thank you so much, Ms. Fields.
You're welcome.
Representative Cook.
Thanks, Pam, for coming out today. And I couldn't agree more with the, I guess, dysfunction of the payment system. So if we allowed you to reinvest your savings on an average year, do you know what that would look like if the payments were better allocated and you were able to take those savings as opposed to give them back?
Right. We would reinvest them into our houses and buildings because we don't have the money now to repair some of the places. We provide services for people with very high behavioral needs, high behavioral interventions, and that causes sometimes a lot of damage to the property. And we really have to now pick and choose what we can fix and what we can't fix. So we would be able to upkeep our properties. We would be able to invest in technology systems, electronic systems for our staff data, better able to give data to the state and to CMS.
And so currently, if you needed to upgrade your system, or if you needed to fix a hole in the wall or paint, what is the process?
Well, we try to see if we have money available, or if it's a health and safety issue, we do it anyway and run in deficit.
And then at the end of the year, the fiscal year, what happens with that deficit?
It just stays on our books.
Thank you. Thank you for that. I hope we can figure out a way to fix this. And thank you guys for everything that you do.
Thank
It's
you.
very
I
important.
appreciate
Be
it.
careful, please.
Thank you, Representative. Thank you, Ms. Fields. Thanks for coming out today.
Oh, Representative Pitt has a question.
I don't know. No, that's. Oh, I don't know what that is. You're all set. Thank you so much. No, okay. Next we'll hear from Maureen Emerald, followed by Tina Yeats.
Thank you, Madam Chair and members of the committee. My name is Maureen Amiro, and I am speaking on House Bill 6702. I have been a wheelchair customer with New Motion for 2.5 years. Within the span of a year, I've had over a dozen repairs, 3 of which were major repairs, in which the suspension system failed, rendering the chair immovable. Each of these repairs took 6 to 8 weeks to complete, meaning I was without a working wheelchair for 5.5 months out of the year. Twice I received a loaner chair, once I did not. My wheelchair enables me to live independently. I can complete my daily activities, run errands in town, and use transportation services for my appointments. But when my wheelchair is not operable, I can do none of this. In fact, I'm relegated to my bed and suddenly require a level of service that I don't have access to. Taking care of my personal needs goes from being something that is routine to being dangerous and puts me at risk of falling. I'm left feeling anxious, stressed, isolated, frustrated, and this is only exacerbated by the lack of timely service that I'm receiving. This past Friday, I did have 3 repairs completed that had been outstanding from January, December, and August of last year, and I still have 3 outstanding repairs related to an issue reported back in June of 21. This is a pattern with New Motion. They don't exhibit any type of urgency when processing a repair. Their calls go unanswered and unreturned. Technicians miss appointments and repairs sit unattended for weeks or months. Unless I make countless calls to the company, no action is taken to move my repairs forward. I have written a formal letter to the CEO, and so these repairs I'm talking about have been reflect the intervention of upper management and are considered to be expedited, and yet their output is still beyond dismal. So while I appreciate the efforts being made today with regards to the right to repair bill, I do not feel this is the best route for us to go. I worry about taking on the responsibility with an outside vendor who may or may not be equipped to handle these repairs, much less doing it myself. And I worry about expensive out-of-pocket costs. Furthermore, this bill does nothing to hold the companies accountable. They would just continue to operate as they've been doing. New Motion and National Seating have taken on the responsibility of providing us with a wheelchair that is in proper working order, and I would like to see them held to account. I understand there is alternate language that would require a time frame for repairs and work towards other regulations that would be acceptable to both the dealer and the customer, as well as prohibit the prior authorization requirements. So I think this is more aligned with our needs, and I hope you take this into consideration. Thank you.
Thank you so much, Ms. Amaro, and perfect 3 minutes. I don't see any hands. Thank you for your testimony and your time.
Thank you.
All right, next we'll go to Tina Yeats, followed by Jenny Cole.
Good afternoon. Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the Human Services Committee. My name is Tina Yeats, and I am the president of the Connecticut Association of Residential Care Homes. Thank you for the opportunity to offer testimony on several bills. Before I do get started, I wanted to express our appreciation to the committee for the attention to residential care homes and also to the governor for the proposed investments in residential care homes. Regarding House Bill 6665, CARCH has concerns with the language included in House Bill 6665. It is important to note that we support the governor's budget proposal and investments that are being made. However, we would like to work with the administration and the committee on the language included in this bill to rebase residential care home rates. Our rate system is highly complex, and due to years of flat funding, rebasing has not occurred in almost 10 years. Since that time, statutory changes have been made. Therefore, we want to ensure that all homes see a rate increase under this proposal. A rebasing could possibly see some home rates stagnant with no increase due to the cost-based reimbursement system. In particular, the language on lines 1019 through 1020 prohibits any inflationary increases for residential care homes in the 2024 fiscal year. This is problematic as the state is utilizing 2022 cost reports to set the rates for 2024. This puts the cost-based system almost 2 years behind as the cost reports concluded on September 30th, 2022. The continued escalation of costs are not captured without an inflationary increase. When we had looked at 2019 cost reports, it was clear that due to years of flat funding, homes were cutting costs. As a result, a rebasing without guardrails is likely to result in many homes receiving a lower cost-based rate that is inadequate to keep up with increasing cost pressures. At the very least, a stop loss should be implemented to ensure rates cannot go down. A stop loss provision is not included in the current language. We also think it is crucial for the health of the industry that all homes see an increase so that they can invest it in home and staff. We would like to encourage the committee to look at caps on our costs due to recent inflationary pressures. This includes caps on administrator salaries and caps on various other cost drivers that have not kept up with the real world costs. As you have heard, several homes have closed in the last year, and we are concerned that others could face the similar fate. Finally, we would like to thank the governor and DSS for Section 7. Often, many individuals do not have the opportunity to apply for the state supplement program prior to an unexpected admission or the time of admission due to an emergency. The date of the application is signed is the earliest possible date assistance can be provided. This section would allow coverage of benefits for up to 90 days prior to the date of application.
This procedure will allow homes to accept residents and very likely be paid. It may also further earlier discharges from institutions such as hospital. We welcome further discussion of all aspects of this bill as the session moves forward. Regarding Senate Bill 1109, we have significant concerns with the.
Ms. Yeats, your time has expired. Can you please summarize?
I certainly will. We have submitted written testimony regarding the concerns on the other two bills, but we look forward to working with the committee and the department to hopefully change some of the language in the first bill. Thank you so much.
Thank you so much. And I look forward to connecting with you offline. Thank you.
Thank you.
See any hands. Have a great day. Jenny Cole, followed by Nathan Briggs.
Thank you so much. Good afternoon, Senator Lesser, Representative Gilchrist, and honorable members of the Human Service Committee. My name is Jenny Cole, and I'm the Community Outreach Coordinator at the Diaper Bank of Connecticut. Thank you for the opportunity to testify in favor of House Bill number 6587, an act concerning Medicaid coverage for diapers. I started at the Diaper Bank as a graduate level intern, having very little experience with babies. And while it's embarrassing to admit, the truth is I had absolutely no concept of the importance of diapers. Within a short few days of getting to know the organization, however, it became so very obvious that a diaper is not simply just a diaper. Families who struggle to afford an adequate supply of diapers experience negative health outcomes, negative economic and educational outcomes. Diaper is not just a diaper, it's a basic essential need. But unlike other basic essential needs, such as food and housing, there are no continuous safety net programs for diapers. Now, as the Community Outreach Coordinator at the Diaper Bank, a large piece of my job is to raise community awareness around the importance of these products. With this responsibility, I've talked with a wide range of business, philanthropic, and student groups. And without fail, one of the first questions I always get is, are diapers covered under WIC or SNAP? While we're certainly not advocating for diapers to be covered under these programs, as it would take away from the essential nutrients they provide, it raises a really interesting point. The general public, it seems, very surprised that there's really little to no support for diapers. 1 in 3 families in our state are struggling to afford these basic essential items. Research shows that when families are forced to stretch the lifespan of diapers, babies are much more likely to experience urinary tract infections, diaper rash, and other diseases associated with infrequent diaper changing. Lack of access directly affects the health and safety of babies. We understand that covering infant and toddler diapers under Medicaid is a big ask. However, we're confident that this has the potential to significantly improve the lives of families across the state. Connecticut has always been a leader in this space. In 2007, we became the first state to allocate funding through a line item in the state budget for diapers. And in 2016, we joined the few states to pass removing the sales tax from diapers. None of this would have been possible without the hard work of our legislators. And once again, we are asking for your support because we know that families throughout the state need your support. I urge you to prioritize the health, safety, and well-being of families and expand Medicaid coverage to include infant and toddler diapers. Again, thank you so much for your time, and I welcome any questions you might have.
Thank you, Ms. Cole. Representative Mastro Francesco.
Thank you. Thank you, Jenny, so much for your testimony. I appreciate it. I'm curious, from the Diaper Bank, how many diapers, can you give me a dollar amount or a quantity of how many diapers that they have distributed?
From on our behalf, last year it was about 3.3 million diapers, but we know that's going to be much larger this year.
And funding part of it. So this, I remember, I think it was back in maybe 2020 or 2019. There was a large amount of funding that went to the Diaper Bank. Do you know how much funding you've received so far?
So during the 2020 budgeting cycle, I believe it is 700,000 each year. And in the governor's proposed budget, it's for the same. But we know that the need is much larger than what we're actually covering throughout the state. And I can certainly follow up with more information on our funding if you'd like.
Thank you. And I'm just curious, are you looking for more than what the governor is recommending? Are you looking for a larger increase in funding?
We are, yes, as an organization, but again, we see these as two separate issues. We know these are basic essential items, and there's certainly a much larger need than what we're able to cover through the Diaper Bank.
Right. But the governor is proposing a certain amount for the
Right.
diaper bank, right?
Yeah.
How much more is your organization looking for?
We're looking for an increase somewhere in the ballpark of 5 million over the course of 2 years. This would be used to both maintain what we're already doing and then expand, obviously, to reach more of the need. We did receive some money through some emergency COVID funding. So this is going to be used hopefully to sustain those program areas, because we know that was a one-time funding opportunity.
Yeah, right. So you're looking for whatever the governor proposed. So you're looking for a total of 5 million from the state over 2 years. So an additional 2.5 million.
Not additional. It would be in lieu. It would be like the total increase.
Okay, so I've got you. And then just one more quick question, if I may. How
Sure.
much money did you receive from the COVID relief for the diaper bank?
I don't know that off the top of my head, but our executive director will be testifying later today. So I'm sure she'd either be able to answer that, or I'd be happy to follow up with you.
Okay. Jenny, thank you so much for your testimony. I appreciate it.
Thank you for your
Madam
questions.
Chair.
Thank you, Representative. I just want to make clear that the bill before us today in no way funds the diaper bank. It is a proposal to have Medicaid covered diapers. Thank you so much, Ms. Cole, for your testimony and your time.
Thank you.
All right, next we will hear from Nathan Briggs, followed by Sheldon Tubman.
Thank you, Representative Gilchrist, for the opportunity to testify in support of House Bill 6612. I'm Nathan Briggs, Executive Director of March Incorporated in Manchester. For more than 40 years, March has generated positive impacts on the qualities of life for hundreds of people in Eastern Connecticut by delivering day and 24-hour, 7-day-a-week residential services to adults with intellectual and developmental disabilities, meeting our mission to enrich their lives by making a respectful, caring home for them within our community. Despite the legislature's clear intent to end the practice of clawing back unspent funds or cost settlement, the policy has still not been implemented in a way that would be helpful to nonprofits. One of the most impactful aspects of the clawback provision is reflected in March's fastest growing expense, which is temporary direct care staffing resources. The overwhelming majority of the people supported by March receive 24-hour, 7-day-a-week staffing support. Therefore, we must have staff all day, every day. And through the first half of the fiscal year 2023, our temporary staffing costs represent almost 40% of March's direct care staff salary expense. The ability to retain savings would allow us to invest in the people of March. It would allow for us to be able to help support true career paths and be able to take what is, I can speak from personal experience, a really good job being a direct support professional and helping adults with intellectual and developmental disabilities and be able to transform it into a career. And in doing so, we would be able to move closer to offering a living wage to our direct care staff, offering them stability as well as a future to them and to the people that they support by reducing our workforce attrition. I'm also testifying in support of Section 4 of the bill, which would index rates that the state pays for contracted nonprofit health and human services to inflation. March and our sister agencies in the IDD system have not received a COLA increase since 2007. As such, we're paying 2023 expenses with $2,007. Indexing the rates to inflation would allow March to no longer have to guess how much buying power we will or will not lose this year. We will no longer have to scramble to fill an unexpected hole in our balance sheet if we guess low. We will no longer have to scramble to dispose of an excess to avoid a clawback if we guess high. Instead of expending time, energy, and resources on guessing, March would instead be able to focus solely on generating the social profit that we are here to generate for our stakeholders and your constituents, the residents of Connecticut, through the effective and efficient execution of our mission, supported by your generous allocations to us as an agency. Thank you for the opportunity to testify in support of this important bill. Please support House Bill 6612 for us and for our fellow nonprofits. Thank you.
Thank you so much, Mr. Briggs. I don't see any hands. Thank you for your testimony and your time today.
Thank you.
Next, we'll go to Sheldon Tubman.
Good afternoon, Representative Gilchrist. I'm sorry there's no video there, but I'll do the best I can. I'm here to testify primarily on HB 6702. As you've all heard, the consumers and advocates have gotten together in response to this important bill and come up with a proposed substitute that would really, we hope, address a lot of the issues you've been hearing about today. And the actual proposal is attached to my testimony. but just to highlight, because some questions have arisen, the highlights are that it has to be, the equipment has to be assessed within 3 days in most cases. And on the 4th day, a loaner has to be provided if it's within warranty, not otherwise. What is a timely repair then has to be made. A timely repair must be made, but in deciding what that is, the idea is a stakeholder process. And that idea actually comes from a bill that was put forward by the industry in Massachusetts. The stakeholder group would help decide the tiering on how long it takes for each kind of repair. The stakeholder group would also exist for 2 years thereafter and meet quarterly to work out any remaining issues. The Department of ADS would then be required to do regulations by March 1st, 24, based upon what the stakeholder group came up with, or if there's no consensus, do it on their own. There'd be enforcement by the consumer and the Attorney General. There'd be prominent written notice about all the rights here. Suppliers would have to stock parts or at least have a contract with an entity that could get parts overnight as needed. There'd be a 24-hour call center. And prior authorization would be prohibited. This is what the industry seems to be also be asking for. Our language does allow for prior authorization where a supplier wanted to get it because they were concerned about the high cost, wanted to make sure to be paid for. But those are the basics of what we've laid out. We obviously recognize we may need some tweaking. Happy to meet with you, happy to meet with the industry, whoever. But really listening to consumers seems to be the answer to move this whole issue forward. The other thing I'd like to briefly talk about is SB 991. I hadn't planned to talk about this, but obviously community health workers are an extremely important innovation. And we think people with disabilities will really be benefited by having that. The bill as written is provides for a state plan amendment so these providers can be paid for on a fee-for-service basis. We really support that. The issue, though, is that the Department of Social Services has come in and said they're opposed to it, but they'd be willing to consider it as part of value-based payment or alternate payment models. That's where it really gets problematic for people with disabilities, in that putting financial risk on providers. That's what we mean when people at Office of Health Strategy talk about value-based payment. What they mean is putting financial risk on providers, including capitation. It means that the provider now has a financial incentive to deny care. So you could put CHWs within that kind of model. But if it comes out of the pocket when the CHW is provided, then you may not get CHW service and you may get other services denied. So it seems to be a good bill as written, and this should significantly move the ball forward in terms of getting this critical service out to the community. But the concerns of the advocates, not just myself, when we talk about value-based payment, should be red flags in terms of what was talked about today by the commissioner. Thank you very much. I'm happy to answer any questions you might have.
Thank you, Mr. Tubman. I don't see any hands. Thank you for your testimony and your time. Oh, wait. Senator Lesser has a question. Go right ahead.
Yes, thank you, Madam Chair, and thank you, Sheldon, for your testimony. On the first bill, the wheelchair bill, I had some questions earlier about the two models. I understood there are going to be a couple of reasons for favoring the consumer protections over the right to repair, but it does seem to have additional complexity, and I didn't know. Do you know if, when researching this, do other states have similar approaches and the 24-hour call center and whatnot? Is this based on another model? I know that the right to repair is based on Colorado, but I didn't know if you were looking to.
It's sort of based on three things. One, it's not based on the Colorado model. That's right to repair. That says you can fix the thing yourself, or you can spend your own money to get it fixed yourself when you can't get the supplier to fix it. I mean, basically, in all honesty, that's really what it is. So this bill does not have that at all. It is modeled in part on two bills that are currently pending in Massachusetts, one of which deals with, I mentioned the industry bill, and the industry bill does two things, which we sort of do in this bill. One is to create the stakeholder process to help determine what is timely, repair. And also their bill prohibits prior authorization, which is also here. But it's also modeled on a consumer bill that's being put forward by disability advocates in Massachusetts, which has things like the 3-day turnaround time for the assessment and other basic protections that for consumers. That has not yet passed, but it is something that seems my understanding is last year their bill passed one house but not the other. But the third thing that it's based upon is the actual experience by consumers that we listened to in Connecticut with when we had the smaller, locally owned companies, small businesses that used to provide responsive service. These things were all things they had. So for example, you could always call for emergencies. They stocked the parts. It wasn't an issue that basic parts were not stocked. So what we heard from consumers was that they're kind of like to, go back to what we used to have. And it's unfortunate to have to mandate it, but if that has to be, that has to be. So I think that was the sort of the other place where we got it from, is just that actual experience. But to answer your question, I am not aware of other states specifically where most of the provisions in our bill occur. I should say there's one exception, and that is the current Connecticut law, the Lemon Law, because there's a general lemon law for adaptive equipment, but it doesn't really work for this kind of equipment. It includes this kind of equipment officially, but it really doesn't work. For example, you don't get assessed for and get a loaner chair until 10 days, which is, as based upon what you heard in the testimony today, is really not going to work. But that's sort of in the background. We also were aware of that bill. I hope that answers your question.
And so would you oppose the right to repair language, or it's just your judgment that that's not the most useful way of attacking the issue?
Yeah, I don't think we'd oppose it. I think that we are responding to what consumers said. So we had, focus groups and met with a lot of folks and got a lot of input on what their actual experience is. And in general, people felt it wouldn't really move the ball forward. That would not really fix their problem, because if the responsibility is just on them to try to get it fixed, that's exactly what they're trying to get past. They want the thing to be fixed by whoever provided the device in the first place. And the other thing that is a concern, this is not a reason to oppose it, but as I think Jonathan said at the beginning, there's a lot of concern from the industry about proprietary issues. And because one of the things in right to repair is the company has to sort of make its stuff available to you so you can fix it or have somebody else fix it for you. And so that raises a lot of concerns. Our proposal doesn't have any of those issues.
But with regard to the other bill that you testified on, I believe that the testimony we got from Health Equity Solutions suggests more of the value-based payment model. You oppose that?
So one of the priorities of my organization, Disability Rights, and other organizations is to increase access to health care for people with disabilities. And right on our website, you'll see that one of our priorities is resisting financial payment models which create incentives to deny care. And although value-based payment, that term sounds great. Who disagrees with value-based payment? Everybody wants to get value for their money. But in Connecticut, in health policy circles, particularly the Office of Health Strategy, they mean putting financial risk on providers. That's what value-based payment means to them. And it hasn't been a secret that the new director of OHS has been strongly supportive of those models, including capitation. So that's where, a provider is paid just a fixed amount of money per member per month. So if CHWs are folded into that, what we have is a situation where, technically CHWs are provided, but they all go into the financial risk model and it comes out of the pocket of the provider group. So they don't particularly want to pay for it, or maybe they will pay for that, but then they won't pay for something else. If the services are paid for on a fee-for-service basis, which this bill provides, I think that's what it says. If it's paid for on a fee-for-service basis, and other states do this, it's a straight fee-for-service state option, just like a physical therapy visit or whatever, then you avoid all those issues. So I think that advocates like myself, particularly who represent people with complex medical conditions, where they have a lot of services that have to be addressed. If their providers have a financial incentive to restrict access to care, it's highly problematic, and we're already seeing it to some degree in the PCMH Plus program.
I'm sorry, and you're seeing this with regard to community health workers or with regard to?
So the Department of Social Services already has a risk-based program to some degree. And it is called PCMH Plus, not to be confused with PCMH. PCMH Plus is the model where, yeah, providers are paid fee for service, but there's also shared savings. So if they save money on their own patients by restricting their access to care from other providers, they get paid fee for service. But if they save money on their patients by restricting their access to care, they get to keep half of that money. So that is a model that's already problematic. And what I'm trying to say is that those kinds of models are what OHS has been talking about and has been pursuing. And I think that the bill that you have before you avoids that by saying we support CHWs. They are an extremely valuable new service that should be developed. We want to see it happen. We should pay for it. If we believe in it, we should pay for it directly, and we should not pay for it in a way which will potentially restrict access to care either for those services or other services.
But just understanding the parade of horribles, if we were to take the health equity solutions approach to the issue or the DSS approach, is the lack of care that you see, is it limited to community health workers, or does it spread into other areas of care in the bill?
It spreads into other areas because how's that? Because in general, value-based payment, just looking at the testimony, is, and just knowing everything, all the other models have been proposed by OHS, they look at putting financial risk on a provider group for a range of services, perhaps all of the services. So value-based payment means, in this context, it doesn't have to, but in this context, what it means is that paying for CHWs would be the responsibility somehow of the provider group, which pays for other things too. So now you're roping in CHW services and these kinds of services, those kinds of services, as all part of a sort of a package of payment. And that means that the providers have a financial incentive to restrict access to all kinds of services, as they already do in PCMH Plus.
Mm-hmm. Okay. Madam Chair, I think that does it for me.
Thank you, Senator Lesser.
Thank you.
Thank you, Mr. Tevin, for being here today.
Yeah, thank you.
Next, we'll hear from Thomas Smith, followed by Adriana Rojas.
Good afternoon. I want to thank the members of the Human Services Committee for the opportunity to provide testimony today in support of House Bill 6612. Excuse me. My name is Tom Smith. I reside in Avon with my wife, Valerie, and I'm a lifelong resident of Connecticut. My wife and I have been involved with the Arc of the Farmington Valley, more commonly known as FAVAR, in various volunteer roles for over 25 years. We are both currently on FAVAR's board of directors, and I'm also the treasurer. Additionally, we have a son, Glenn, who has Down syndrome. Glenn resides in a FAVAR group home and attends a FAVAR day program. In particular, today I'm testifying in support of Section 4 of House Bill 6612, which would provide an annual cost of living adjustment to the rates the state pays for contracted nonprofit health and human services. Nonprofits are not immune from the effects of inflation. They have been severely impacted by the cost of fuel to heat buildings in which they provide services to their participants, by the cost of gasoline for the vehicles used to transport participants, as well as the cost of food, technology, insurance, and of course, employee costs. As a member of the board of FAVAR, and as a parent of a son receiving services, I've seen firsthand the hardships and challenges that increasing costs without a corresponding increase in funding can have on a nonprofit. Mandatory cost of living adjustments can help to ensure that we do not go back to the days of chronic underfunding for nonprofits. If we do not do this, the people who suffer the most will be the recipients of these services and the hardworking, underpaid nonprofit direct service providers. Not addressing chronic underfunding will not make the problems go away, as people will still need these critical services. Thank you for the opportunity to testify in support of this important bill, and I urge you to please support House Bill 6612. Thank you.
Thank you, Mr. Smith. I don't see any hands. Thank you for your testimony and your time. Next, we'll hear from Adriana Rojas, followed by Susan Brosio.
Good afternoon, co-chairs and esteemed members of the Human Services Committee. I'm Adriana Rojas, and I'm a project manager at the Moses Whiteman Health System, which is an umbrella for Community Health Center Inc. I stand in support of SB 991, an act concerning Medicaid reimbursement for community health workers. At the health center, we believe that healthcare is a right, not a privilege. I also believe that being able to spend time and energy on one's personal health in order to live one's healthiest life should also be a right and not a privilege. And right now, for many of our patients, it is just not possible to do that without the support of someone like a community health worker. Our patients are worried about how they are going to feed their families. They are worried about paying utilities and making rent. Many do not have the privilege of spending time on figuring out how to navigate the health system, how to access healthier food, or how to lose weight to improve their cholesterol, their diabetes, their uncontrolled hypertension. And sometimes it's all three of those chronic conditions for one person. CHC hired our first community health worker, Leonora Ortiz, as part of the Community and Clinical Integration Project through a STEM grant. And that CHW has positively impacted the lives of many in the Meriden community. Leonora was already familiar with the city and quickly established a relationship with the YMCA there so that she could help patients access memberships and support them in getting comfortable with going to the gym. Leonora also played a pivotal role in helping a patient get screened for colorectal cancer. Healthcare providers are often limited to 20 minutes with the patient, and even with sophisticated dashboards, 20 minutes isn't enough time to listen to a patient talk about the challenges they face in their everyday life that are preventing them from being healthy. And 20 minutes definitely is not enough time to support the patient in overcoming those barriers. But community health workers fill this gap in the care team. It was our CHW who was able to speak with that patient who was overdue for colonoscopy and learn about their fear and lack of support. The patient wanted to get the colonoscopy, but did not have someone to stay in the waiting room during the procedure, which is a requirement. VEO cannot be helpful in getting a patient a colonoscopy, but a community health worker can be. Like many organizations, CHC continues to apply for grants to support the work that CHWs do. However, building out our community health worker program and taking it to the next level for patient outcomes is stunted because we have to focus on finding the next 2-year grant. Research already shows us the return on investment that CHWs can create. Connecticut has created a CHW certification to ensure that CHWs have demonstrated core competencies. The missing piece here is sustainable funding so that we can provide consistent impact on ER utilization, ensure patients are receiving the preventative care that will lower long-term insurance costs, and so that we can create healthier people and healthier communities in Connecticut. There are specific services that CHWs provide that no other member of the care team can. If CHW services are available, we can more easily provide them with a livable wage, we can lighten the weight that the current understaffed healthcare teams have to carry, and we can create jobs for those in underserved communities since CHW roles typically do not require a college degree, and CHW services or CHW should come from the communities in which they serve. When CHW services are available, it benefits more than just the patient. We can create a system of care that shows the living one's healthiest life is a right and not a privilege. Thank you for your time this afternoon.
Thank you, Adriana, and it is good to see you. Are there questions or comments from members of the committee? If not, thank you very much for your testimony.
Thank you again.
Susan Brousseau, followed by Mag Morelli.
Good afternoon, members of the Human Services Committee. My name is Susan Brousseau. I am the Chief Financial Officer of Edelbrook. Edelbrook provides schools and residences for individuals with autism spectrum disorder. We serve individuals with the highest level of need in the state, and we employ over 600 people. I'm a CPA with over 35 years of experience working with both for-profit and nonprofit businesses. And I'm here today to support HB 6612, which we've heard described many times today. When I testify, there's a reason why I mentioned that I'm a CPA with experience with both nonprofits and for-profit businesses. From a financial perspective, the nonprofit vendors that serve the state operate as businesses with an important difference from the for-profit vendors. As nonprofits, we reinvest all of our surplus into our programs. We do that by definition. We can't pay dividends. We have no shareholders. We're a great deal for the state. We give a lot of bang for the buck. But like for-profit businesses, we have to meet payroll. That's our biggest expense. We purchase supplies. We repair our facilities. You've heard this all day today, the different things that have to happen. However, nonprofit vendors like Edelbrook are denied the ability to retain surplus funds for future needs. Instead, we must either give the surplus back or request permission from state agencies on exactly how we may spend the surplus. And typically what we're told is to spend it on capital improvements. Capital improvements are great. That's not necessarily what we need or what we're thinking about as we're planning on how to better serve our students and residents. This forces us to be constantly on the brink of a cash shortfall, especially during payroll week. And no business can operate effectively in the long run in this manner. It just doesn't work. In addition, while for-profit vendors would not be expected to provide the same level of service year after year without a cost of living adjustment, for many years, the state has assumed that nonprofits somehow don't experience cost increases in the same way as for-profit businesses. Again, as I can tell you as a nonprofit CFO, we feel the full impact of inflation, and it's unfair to believe that somehow the laws of economics don't apply to us. I'm also testifying in support of Section 4 of the bill that would index the rates the state pays for contracted nonprofit health and human services to inflation. And this would provide increases automatically when inflation increases. This would allow us to plan for future needs, again, in the same manner as other businesses, and to provide wage increases to hardworking direct care staff who have the opportunity to do less demanding work at other jobs. This would cut the turnover rate in our agencies as staff can anticipate that they will
Please
receive
summarize your
a
testimony.
COLA.
Thank you.
And thank you very much for your time today.
Thank you, Susan. Are there questions or comments from members of the committee? If not, thank you very much and really appreciate it. Next up, we have Mag Morelli, followed by Carrie Dyer.
Thank you, Senator Lesser. Good afternoon. My name is Mag Morelli, and I am the president of Leading Age Connecticut, which is a membership association of not-for-profit and mission-driven organizations representing the entire field of aging services and senior housing. On behalf of Leading Age Connecticut, I'm pleased to testify before you today, and we have provided testimony on several of today's bills, which I will just summarize and highlight right now. In particular, I'd like to begin with our strong opposition to the request by the Department of Social Services to be granted broad and unchecked authority to change, modify, or implement Medicaid payment models as is proposed in Section 6 of Senate Bill 1110. We are particularly concerned with this request because DSS has just informed the nursing home sector that they intend to modify the new acuity-based rate system by implementing a 5% rate withhold on all nursing home rates in order to fund a value-based payment system. The proposed rate withhold, which is essentially a 5% cut to every nursing home's per diem rate, was something determined solely by the department. We are adamantly opposed to this move by DSS and would propose increasing the legislative oversight of such payment methodology changes rather than abdicating the authority to DSS as is proposed in this bill. We've also requested that another bill on today's agenda, Senate Bill 1109, be amended with language to prohibit this intended rate withhold. Senate Bill 1109 is proposing changes to the nursing home rate setting statute, which we believe are an attempt to clarify the rate setting process. However, we would request the opportunity for further review to be sure that all of the necessary changes are included. With regard to Senate Bill 1111, we would support the apparent effort to incentivize the delicensure of nursing home beds that are no longer in demand by reducing the per diem rate of nursing homes that experience a resident census of under 90% for a full 12-month period. But we have asked for an exemption for nursing homes that can demonstrate a demand for their vacant beds, but that have purposely not filled the beds due to the inability to staff them at the level that they believe is necessary to provide quality nursing home care. We're currently in a workforce crisis that is necessitating quality nursing home providers to self-impose restrictions on admissions so they can adequately staff for the resident population in their care. This bill also proposes the establishment of a new payment system for the administrator and general cost component of the current rate calculation formula through the establishment of peer groups that will be regionally based. We've asked for time to study and understand its potential impact on our membership and those they serve. And finally, we'd like to thank the governor for his support of the residential care home model as demonstrated in his recommendations contained in House Bill 6665, and voice our support for the proposal to establish a passive redetermination process for Husky C members as proposed in House Bill 6776. Again, we've submitted written testimony on several of these bills, and I would be happy to answer any questions.
Thank you, Mag. Did you hear my questions earlier of the commissioner about the acuity-based payment?
Yes. Yes, and this is a piece of the acuity-based system, which is the quality incentive payment program that goes into effect this July. The governor's proposed fully funding the rest of the acuity-based system that has a 3-year phase-in, but this quality piece, we had been hoping for new money to provide incentive payments. To take a withhold is really like cutting somebody's rate by 5%. It's very difficult for them to maintain the quality they're currently providing, let alone trying to strive for higher rates of quality. So we feel it's contrary to the program to implement this withhold.
And you don't object to the new payment methods, but you don't want the broad delegation of authority to DSS. Did I understand your testimony correctly?
Well, we're saying we don't like the idea that they would in the future be able to make any changes they wanted to any payment methodology. And I think that's what that section in the bill asks you to do, to grant them that authority. And this is just an example of one of their use of what they believe is already their authority to come in and take 5% of our rate away without any legislative oversight or granting of authority.
Okay. Are there questions or comments for Ms. Morelli? Seeing none, thank you for your testimony this afternoon.
Thank you.
I'm going to hand over the baton now back to Representative Gilchrist.
Great. Thank you, Senator. Next, we'll hear from Valerie Rayher, followed by Robert Hale.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the Human Services Committee. I'm Valerie Ryer from the Kennedy Collective, a nonprofit organization providing services across the state to persons with disabilities in employment, public transit training, independent living, transportation, adult day support services, and other community residential and rehabilitative services. Thank you for the opportunity to provide testimony in support of HB 6612, which would prohibit the practice of state agencies clawing back surplus funds, as well as index the rates that the state pays for nonprofit services to inflation. This bill is vital to the sustainability and growth of our services. Every year, our costs increase exponentially. Through the rising cost of healthcare alone, we continuously see a year-over-year increase of at least 45% and an increased burden of sharing those expenses upon our employees. Additionally, we are unable to retain employees when we are unable to provide them with cost of living adjustments. Rather than stay somewhere they enjoy working, finances often dictate that they pursue other positions, often which is as a state worker, in order to get the remuneration that will allow them to work one job. This week alone, we have had 2 individuals be hired by the state, and it's only Tuesday. Although we appreciate the recent wage increase, we are now facing the compression factor of employees who have worked in the same position for 5 years, who are making the same as those who are entering the workforce with no training. We need to be invested in if we are partnering to provide these vital services that your constituents need. Having the availability of surplus funds that we can use without restriction will allow us to develop reinvestment plans that would enhance both employee development and services and support. It would include professional development opportunities, employee retention engagement activities, newer expanded benefits, employee incentive programs, new position development, and career growth. Additionally, it will allow us to look how we further invest in improving services and supports with the replenishment of vital tools and resources and the incorporation of other innovative materials and practices. Despite the support from this committee, the legislature, and nonprofit community since 2017, the innovative incentive program has not been implemented in the way the legislator intended. HB 6612 provides much clearer direction to contracting state agencies that, if passed, will hopefully lead to better outcomes for providers, their employees, and the people they serve. Medicaid waiver reimbursement is based on a rate reimbursement structure for services rendered. If we provided those services, we should be able to receive the full rate without the requirement to cost settle. I'm also testifying in support of Section 4 of the bill, which would index the rates the state pays for contracted nonprofit health and human services to inflation, providing increases automatically when inflation increases. This will provide immediate benefits to our employees through wage increases, reducing the turnover and compression that occurs from year to year. It'll also address the continuous rise in insurance. Over the past year, our healthcare increased by 51% and ultimately warranted a full changeover and increased employee investment to get it down to a workable 35% increase.
Ms. Ryer, your time has expired. Can you please summarize?
Yes, the increases alone continue to impact our ability to provide quality services. Just because we're a nonprofit doesn't mean that our business costs do not rise from year to year. We are suffering. We ask you to see our employees, your constituents, as well as the people we serve. HB 6612 will have a great impact for services to this state. Thank you for the opportunity for this to testify for this.
Thank you so much. And you do have a question. Representative Dathan, go right ahead.
Yes.
Thank you very much, Madam Chair, and thank you, Valerie, for your testimony, and thank you for all the work that you do. It is so important to help all these people in our community with getting services. In terms of, I know you spoke a little bit about the clawback, and you also talked a little bit about the sort of rates. The question I have really is, beyond rates, how do we also ensure that we have good workforce development for people that get employed in this space?
Well, you have to have a continuous reinvestment. So the ability to add in not just the rates to provide the direct services, but also the allocation of resources to continuously train. If you look at school systems, they allocate professional development days that allow teachers to continue to enhance their skill sets. Social workers have CEU requirements. We have to do the same with our direct support professionals, our vocational specialists, anyone that's providing this service. Without that, you're not enhancing their ability to provide better quality services. And ultimately, that will reduce the cost to the state, to the taxpayers. If you're able to create progress in rehabilitation and vocation, you're going to see people not just being, service takers, but also service givers. And that's what we're trying to do.
So really talking about professionalizing the field. I talk a lot about that with workforce development, getting folks from being CNAs to supervisors to managers, and really getting to see that career progression, and training is an excellent example of that. And I do feel that in some of the situations, that sort of, if you have cost savings, it would be great for nonprofits like yourselves to be able to retain those and utilize those for future trainings or for other sort of professional enhancement, really to secure the workforce and ensure that we are investing in our workers that support our safety net. Thank you so much for your testimony today, and I hope you have a good, safe day in the snow.
Thank you.
Thank you, Representative. Thank you so much, Ms. Ryer. We don't have any other questions. Thanks for your testimony and your time.
Thank you.
Next, we'll hear from Robert Hale.
Hello?
Hello, go right ahead.
Hi, I'm trying to open the video. There, thank you. Hi, I'm attorney Robert Hale, and I'm testifying from my office in Glastonbury. I'm just going to read from my prepared remarks, which I have submitted. Dear members of the Human Services Committee, I am writing to voice my opposition to HB 6618 and to ask you not to pass this bill out of committee. Abortion is a crime against humanity, and the abortion industry is committing genocide on a scale far surpassing Adolf Hitler's Final Solution or Cambodian dictator Pol Pot's Killing Fields. Abortion is the intentional premeditated killing of a defenseless, innocent human being. It is not healthcare. It is murder. I say this to you out of all humility, and I need to confess to you that I once believed that abortion was a woman's right, but I realized that I was wrong, and I have repented, as I hope that many of those listening to me may repent. And by the way, repent means change, turn around and go in the other direction. As such, abortion cannot be justified by a personal belief, ideology, or economic status. Abortion is murder, and those who aid and abet a murderer or pay a murderer for hire are equally culpable. The idea that Connecticut would use my tax dollars to fund the murder of an innocent child is unconscionable and highly offensive. I would strongly support an exemption from state income tax for people of conscience who object to having their tax dollars used for this purpose. If the proponents of this bill strongly believe that a woman should have a right, quote unquote, to kill her own child, let them pay for the woman to have her abortion in Connecticut out of their own pockets, and let their complicity rest on their individual consciences. That is, so long as abortion remains legal in Connecticut, which I hope will end shortly. By the way, it is illegal after viability presently. I would be remiss if I did not mention that this bill has implications that do not bode well for the survival of our constitutional republic. I do not know whether it directly violates the full faith and credit clause of the United States Constitution, but it certainly appears to present at least an indirect challenge to, if not a direct confrontation, with the laws of our sister states who have seen fit to outlaw abortion. At the very least, it invites litigation in federal court. By inviting women to cross state lines for the purpose of obtaining an abortion, which would be illegal in their home states, this bill encourages disrespect for law, for the rule of law generally. This is something that ought to be avoided if we are to live in a civilized society. Moreover, this bill contains no safeguards against—
Well, your time has expired. Can you please summarize? Your time has expired. Can you please summarize?
I have two more maybe three more sentences in this paragraph. Many underage women are victims of rape by older men or family members who then coerce their victims to abort their babies as a means of destroying the evidence and perpetuating their crimes. Proposed HB 6618 would induce or entice the transportation of such vulnerable women across state lines, thereby contributing to sex trafficking in violation of federal criminal law. For the above reasons, I urge you to vote no on HB 6618. Thank you.
Thank you for your testimony and your time, Mr. Hale. Next, we'll hear from Wendy Breyer. Wendy, you need to unmute. There you go.
Good afternoon, Madam Chair and members of the committee. I am Wendy Breer, Chief Financial Officer for Chrysler Center, which is a leading social service agency located in Hartford. We offer services throughout Connecticut, and we have many contracts with the state of Connecticut for these services. Chrysler Center provides services to individuals and families living in poverty with a mental health diagnosis and/or substance abuse, HIV/AIDS, homelessness, veterans, and those returning from incarceration to live independently in the community. I appreciate the opportunity to provide testimony in support of House Bill 6612, which has been discussed at great length from my colleagues today. As you are aware, staffing vacancies for the nonprofit arena have reached an all-time high.
We have been challenged with this at Chrysalis significantly, seeing vacancy rates higher than I've seen in the 12 years that I've been with Chrysalis. Helping to index the rates for inflations for the services that the state pays nonprofits would really impact our ability to hire individuals at a wage that they can live with. With the high rising costs of inflation, they are challenged with having to work 1 and 2 jobs. And we as an organization are challenged with the ever increasing health insurance premiums. I urge you to support House Bill 6612 so that it will hopefully lead for better outcomes for all providers and their staff and the people they serve. Thank you.
Thank you, Ms. Breyer. I think I'm pronouncing that wrong. Thank you for your testimony and your time. Next, we'll go on to Catherine Krashel.
Hello, Representative Gilchrist, Senator Lesser, and distinguished members of the Human Services Committee. My name is Catherine Krashel, and I teach the Reproductive Rights and Justice Clinic at Yale Law School and have served as the Executive Director of Yale Law School's Health Law Center for the past 5 years. I've published journal articles and book chapters on assisted reproduction and access to care for LGBTQ people. I'm also the Vice Chair of the Board of Directors of Planned Parenthood of Southern New England, and I live in Mystic with my wife and our 2-year-old son, who was created with a lot of love and a little bit of science through IVF. I'm testifying in support of Raise House Bill 6617, an act promoting equity and coverage for fertility care. This bill is critical to modernize the state's law requiring insurance providers to cover reproductive health care. The bill eliminates discriminatory barriers to care and clarifies the law in 3 ways. First, it expands access to the state's Medicaid program. Second, it requires insurers to provide care to LGBTQ and single individuals, as well as people with medical conditions that impair their fertility, such as endometriosis. And third, it explicitly requires coverage for fertility preservation for people who undergo medical care that compromises their fertility, including people accessing gender-affirming care and oncology patients. Current law does not provide fertility care coverage for Connecticut residents who receive their health care through the state's Medicaid program, Husky. Like many other types of healthcare, paying out of pocket for fertility care is cost prohibitive. Black and Latinx residents disproportionately rely on Husky for healthcare, so they are currently disproportionately excluded from the state's law ensuring access to the medical care necessary to start a family. This is particularly startling given what we know about who needs access to fertility care most. Black and Latinx women are more likely to experience infertility than white women. In addition, they are less likely to access fertility care once diagnosed. It is imperative for Connecticut to work to address these disparities, and HB 6617 will help address the inequity in care by providing fertility care through its Medicaid program. A recent study I co-authored in the American Journal of Obstetrics and Gynecology tells us that while state insurance mandates like the one we have in place today have increased access for some, they have not been effective reproductive justice tools because they've failed to address the stark racial disparities in utilization of fertility care services. The current law excludes members of the LGBTQ community because it only requires coverage for those diagnosed infertile with reference to coital reproduction. Connecticut was a leader and abandoned such limited notions of ways to build a family when it passed other legislation, including the Connecticut Parentage Act. And it's time for our fertility insurance laws to catch up and align with the state's proud track record of championing the dignity of LGBTQ residents by requiring equal access to the medical care we need in order to form our families and exercise our reproductive autonomy. Finally, the bill clarifies the current law by providing for fertility preservation and fertility care for people with medical conditions other than typical infertility diagnoses, including patients with endometriosis and pelvic pain, and codifies the access to care for patients undergoing medical treatments that may compromise their fertility, including cancer treatment and gender-affirming care. Thank you for the opportunity to testify in support of this bill, and I'm happy to answer any questions.
Thank you, Ms. Krashel. We do have a question. Senator Lesser, go right ahead.
Yes, thank you, Madam Chair. And thank you for your testimony. One question sort of occurred to me, while I was listening to it. Connecticut obviously has had, or not obviously, but has had a fertility coverage requirement in our insurance laws for some time, and it was expanded a few years ago to cover fertility preservation in certain circumstances. But Connecticut does not require the state's Medicaid program to meet essential health benefits. And I was wondering if any state does, to your knowledge.
Covers fertility care, to my knowledge.
Not fertility care, just this. So we on the insurance in our insurance statutes, we declare what an essential health benefit is, but that requirement does not convey over to the Medicaid rules. And I was wondering if anybody's ever thought about doing that, if any state has done that.
I'm not certain with that particular fact, but I'd be happy to get back to you, Senator Lesser, with an answer. I don't want to answer off the cuff.
Okay. That's all I got, Madam Chair.
Yep, sorry about that. Thank you, Senator, and thank you so much, Ms. Crashall. Have a great afternoon.
Thanks, you as well.
All right, next we'll hear from Marlene Burke, followed by Luis Rivera.
Hello, I'm Marlene. I'm a lifelong resident of Connecticut. I grew up in New Milford, and now I live in New Haven while I pursue a PhD at Yale. I'm testifying to give my strongest support for the raised House Bill 6617, an act promoting equity and coverage for fertility healthcare. This bill is deeply personal to me because of the barriers that I've encountered seeking care for a medical condition that impacts my reproductive ability and my quality of life. Specifically, it's something called neuroproliferative vulvodynia. In lay terms, this is a condition where there are extra pain receptors in the vulva. By some estimates, there are 10 times the normal density of nerve fibers, resulting in excruciating pain while trying to have penetrative sex, while undergoing a routine pelvic exam, when inserting a tampon, and sometimes even just when going from standing to sitting. In my case, it has made penetrative sex impossible without medical intervention. And without medical intervention, it would be difficult or impossible for me to conceive. The gold standard treatment for neuroproliferative vulvodynia is a surgery called vestibulectomy, which removes a small area of tissue containing these hypersensitive nerves. But most health insurances do not cover this surgery, and it costs tens of thousands of dollars out of pocket. So this surgery has not been an option for me. Because of years of untreated nerve pain, I developed pelvic floor dysfunction, requiring pelvic floor physical therapy. Months of PT reduced my pain and enabled me to have penetrative sex with manageable pain for the first time. But an insurance snafu nearly came in the way. Despite having 2 health insurances at the time, PT resulted in charges totaling $16,000, and my stipend was a little over $30K. With dozens of phone calls and some very good luck, I was eventually able to convince my primary insurance to cover some of it and the hospital to drop the rest of the charges. While this particular battle ended well, I worry that for many people, PT for chronic vulvovaginal pain is out of reach. And the surgery to address the root cause of my condition is still out of reach for me because my insurance won't cover it. Again, without medical treatment, this condition makes it difficult or impossible for me to conceive. I want the decision of if, when, and how to start a family to be up to me, not up to my insurance's coverage of the healthcare that is essential to my quality of life and to my ability to have children. In particular, I want the language of the bill around the presence of a condition causing loss or impairment of fertility amended to specifically and unambiguously include vulvovaginal pain conditions. I support the raised House Bill 6617. This was my first time speaking publicly about this condition, and so I'm really grateful to you for listening.
Thank you so much, Ms. Burke, for being willing to share your experience in the hopes of helping others. I don't see any hands. Thank you for your testimony and your time.
Thank you for listening.
Next, we'll go to Luis Rivera, followed by Stephen Girelli.
Senator Lesser, Representative Gilchrist, and members of the Human Services Committee, thank you for the opportunity to share my testimony in strong support of HB 6587, an act concerning coverage, concerning Medicaid for coverage for diapers. My name is Luis Rivera, and I am the Community Relations Manager at Connecticut Children's Medical Center. In addition to my testimony here today, I have also submitted written testimony for your consideration. At Connecticut Children's, we know that high-quality healthcare is important. In addition to that, Connecticut Children's Office for Community Child Health works on addressing social factors that influence a child's health. Those are called social determinants of health. Some examples are housing, transportation, nutrition, and diaper need is one of them. At Connecticut Children's, we are proud to participate in the Diaper Connections program, a partnership between Connecticut Diaper Bank and Connecticut Hospital Association. Connecticut Children's has partnered with 2 Salvation Army sites in Hartford to provide diapers to families in need. At Connecticut Children's, we have seen families use plastic bags because they cannot afford diapers. Luckily, Diaper Connections have been able to help families to address such needs. Connecticut Children's also see countless families not be able to afford diapers due to their very limited income. That's why I am in full support of HB 6587, an act concerning Medicaid coverage for diapers. Thank you.
Thank you so much, Mr. Rivera. I don't see any hands. Thank you for your testimony and your time today. All right, next we'll go to Stephen Girelli, followed by Peter Wolfgang.
Good afternoon, Madam Chair and members of the committee. My name is Stephen Girelli, and I am proud to be President and CEO of Klingberg Family Centers. Klingberg provides a wide variety of behavioral health services to children and families throughout Central Connecticut. Our programs number over 20 and include therapeutic foster care, outpatient and school-based psychotherapy, extended day treatment, and a special education school, to name just a few. Thank you for the opportunity to provide testimony in support of House Bill 6612, specifically the provisions on revenue retention and indexing an annual COLA to inflation. Despite the legislature's clear intent to end the state's practice of taking back unspent funds, the innovative incentive program has not been implemented in the way the legislature intended. House Bill 6612 provides much clearer direction to state agencies that would lead to better outcomes for providers, their staff, and most importantly, the people they serve. At Klingberg, we would seek to use savings realized from surplus funds to meet myriad financial needs. Among these are investment in new programs to better address community needs, training required to implement evidence-based practices and to ensure that our staff maintain their skills at the highest level possible, maintenance and upkeep of our 100-year-old campus, and financial incentives to employees and job candidates that would partially mitigate the workforce crisis we're facing. I also support Section 4 of the bill, which would index to inflation the rates the state pays for contracted nonprofit health and human services. For years, nonprofits have been woefully underfunded, and we have therefore been unable to meet adequately the challenges posed by inflation. The impact of this is felt throughout the organization, but nowhere more acutely than in employee compensation, where we lag far behind other sectors. As a result, we've been unable to maintain staffing adequate to meet the growing needs of our service communities, resulting in long wait lists for some programs and denial of admissions for others. Our communities are markedly underserved, and that will continue unless funding improves. Moreover, in the current system, nonprofit providers face annual uncertainty regarding revenue as we prepare our budgets for each new year. As a result, we are left to rely on guesswork in planning and are faced with either overestimating our revenue and risking drastic year-end shortfalls, or erring on the side of caution, both of which further undermine our ability to fully meet the needs of our communities. Thank you for the opportunity to testify in support of this important bill.
Thank you, Mr. Girelli. I don't see any hands. Thanks for your testimony and your time.
Thank you.
Next up is Peter Wolfgang.
Thank you, Madam Chairperson, Representative Cook, and members of the committee. My name is Peter Wolfgang. I am the president of Family Institute of Connecticut Action, and I am here to oppose HB 6618, the abortion bill. HB 6618 is a $2 million consolation prize for Connecticut abortionists after the defeat of Roe versus Wade. Connecticut cannot afford it, and Planned Parenthood doesn't need it. Planned Parenthood of Southern New England has a robust base of donors and revenue of $39,729,249 in their 2020 report. This despite a 10% decline of reported abortions over the past 10 years. Connecticut's first woman governor, Democrat Ella Grasso, once stated, "I do not wish to be a party to the killing of the children of the poor." Unhappy with killing the children of the poor from our own state, this expansion would lure poor, out-of-state women here to kill their children also. HB 6618 would fund the killing of the children of the poor, out-of-state women through abortion. Anyone who knows Planned Parenthood's racist history should be concerned with this bill. The bill subsidizes and encourages interstate sex trafficking by targeting low-income women. Connecticut has an F ranking from the Institute for Justice and Advocacy in the protection of youth and children against sex trafficking. According to a 2018 report, the Connecticut Human Anti-Trafficking Response Team, HART, documented more than 1,000 children as possible victims of domestic minor sex trafficking. Forced abortions are part of that equation. Providing free abortions for out-of-state victims of sexual abuse invites more abuse, shields traffickers, and subsidizes their business. If Planned Parenthood must receive this money, they should be forced to scratch the surface and ask out-of-state women if they are being coerced to engage in sex or to have an abortion. If so, there are other resources to help, including Connecticut's net of pregnancy resource centers. HB 6618 not only offends the 66% of Connecticut residents who think abortion should be restricted, it adds insult by forcing taxpayers to fund abortions for out-of-state visitors and their travel expenses. At least 1% of Connecticut's abortionists are happening after the 21st week, in late term after a baby is able to survive outside the womb. If Connecticut insists on paying for the abortions of out-of-state women and related expenses, we must include covering the expense of medical care for infants accidentally born alive during a late-term abortion. It is only fair that if we promise to cover the expenses of women traveling to Connecticut, we pay for their child's medical care in case of the unexpected. Thank you.
Thank you, Mr. Wolfgang. We do have a question. Representative Mastro Francesco.
Thank you, Madam Chair, and where are you on the screen here? Thank you so much for being here today, Peter. I appreciate it. I see you're at the LOB. You weathered the storm. I apologize, I'm not there today. But thank you so much for your testimony and your advocacy. I know that your organization works really hard to preserve life, and I truly appreciate that. It's interesting today that we had like 463 pieces of testimony that came in today, and every single piece of testimony except for 11 opposed this legislation, which I was really happy to see. My question to you is that you mentioned something about Connecticut having an F ranking on the sex trafficking. Can you elaborate a little bit more on that?
Well, you know, it's hard to say just based on the records that are available because they're spotty. In my written testimony, I have the links to all the stats that I cited, but I will say this, we have our theories. And one of them is this: Connecticut is one of only a small handful of states in the entire country that do not have even a parental notification law. Our neighboring states of Rhode Island and Massachusetts have parental consent laws. We can't, this building won't even allow us to have a public hearing on a parental notification law. And so that does invite questions about, you know, if we're bordered by states that have parental consent, and you have situations, for instance, of statutory rape of older men abusing girls, and it opens up the possibility that they're bringing them into Connecticut to cover up the evidence of their crime and that no one's the wiser. That's one of our biggest concerns. And, you know, you don't want to put the state into a position of helping to fund that. I mean, bad enough that our permissive abortion laws may be facilitating it. Now we're going to have the taxpayers fund it. So that's our concern there.
Yeah, thank you. And I agree. I think the big concern too is the parental notification, and you are correct. Connecticut doesn't even have that to just even notify a parent. And there are a lot of sex trafficking out there, people from other states just coming into Connecticut to have abortions on children that were, molested and abused and so forth. It's truly a concern. I did have one other question, and I know your organization does a lot with expectant mothers and so forth. Have you seen within your organization, since you've been there, a lot of parents, a lot of women changing their mind on abortion? Or
Yes,
maybe
we do
perhaps
see
they
that.
wanted to have an abortion and then you were able to talk with them and they've changed their mind. And today they're very happy that they had their child.
Yes, we've seen a whole range. I mean, there are people who were abortion minded, women who were abortion minded, who changed their mind, brought their child to term. If you ever go to, one of these banquets for these pregnancy centers, they've been around in Connecticut for 30 years. And there are people who stand up and tell the stories, not just the mothers, but the human beings who might have been killed in those abortion clinics. My friend and colleague, Christina Bennett, has told her own story many times, but there are names less familiar that if you go to one of these pregnancy centers, they stand up, they say, thank you. Thank goodness for this pregnancy center, because if not for you, I might not be here today. So that's a reality we've seen. We've seen women who went forward with the abortion and regretted it afterwards. And there's different programs for them for healing. There's Project Rachel, Rachel's Vineyard. So we've seen everything across a whole range. The issue has been with us now for 50 years. And so we've compiled a lot of knowledge about this, about how it affects all of us on all sides, whether you're male or female, black or white or Hispanic, Democrat or Republican, pro-life or pro-choice. It's really it's a wound on our society. So we've seen that. Yes.
Thank you so much, Peter, for your testimony and again for your advocacy and trying to preserve life here. And I was encouraged to see so many people sending in testimony today, 452 actually opposing this bill and only 11 people supporting it. So it's encouraging to see that. Thank you so much. I appreciate it. I have no further questions, Madam Chair.
Thank you, Representative. Senator Lesser.
Yes, thank you, Madam Chair. And thank you, sir, for your interest in combating human trafficking, which I assume is something that is shared by all the members of the General Assembly. Just out of curiosity, does your organization weigh in on bills intending to combat human trafficking? I'm thinking particularly there was a bill that was heard yesterday in the Judiciary Committee. I was wondering if you testified on it.
No, I was here on the assisted suicide bill. You can only do so much. You guys are hitting us with so much stuff here. I wish I could have been up here on that. I can tell you that we did work with the legislature with a famous local advocate against same sex trafficking by the name of Raymond Bouchard, who wrote a book on the sex trafficking that takes place on the Berlin Turnpike. And I was here in press conferences with Raymond, with former prostitutes. So I mean, we've done work on that area, but it's sort of like, I compare it to being like you're a teacher in a one-room schoolhouse somewhere where you're trying to maybe teach the class, try to elevate the society, but there's some element out there that's always trying to burn down the schoolhouse. So, I mean, if it were up to me, I would have been here yesterday testifying on that instead of assisted suicide, but we're constantly fending off bills to make society even worse. So I wish I could be up here more on those sorts of things.
So it would be, I would just say your organization would, be well served to, if you want to embrace a real attack on human trafficking, you could weigh in on a lot of bills, like a lot of legislative efforts that, including the one yesterday, that attempt to address that issue. With respect, though, to the allegation, and I heard Representative Mr. Francesco make it a second ago, that a lot of girls and women are trafficked into Connecticut as part of a human trafficking operations for the purpose of providing them abortions. Are you aware of a single documented incident of that happening?
Well, I qualified my comments by saying that there isn't a lot of records because we're not really sure what to make of the record keeping apparatus that we have here in the state of Connecticut on that. I know that our friends at the Connecticut Catholic Conference have run up against a lot of roadblocks when they've tried to do FOI requests of that kind. So I was careful to qualify my remarks when I said that. I said it's a theory, but it's one that makes sense. If we don't have parental notification and they've got parental consent in our neighboring states, then it does seem to me that this could be a place where those things can happen. And there was that famous case of, I think his name was Adam Galt in West Hartford several years ago, who was keeping a woman prisoner in his house, a young woman whom, he brought her to Planned Parenthood to cover up the abortion, to cover up the abuse. That's the sort of thing we think of when we think of statutory rape. It was on and our lack of parental notification laws covering it up. That might have been caught. And that was something that was on the cover of national magazines at the time, several years ago. But that was unusual because it hit the light of day. And we don't know how many things may be happening out there that are not hitting the light of day. And we need better recording requirements.
Yeah, but someone, I think, once said that evidence of absence is not absence of evidence, or it was either other way around. But it doesn't sound like you have a documented incident of this happening. Thank you for your testimony. I appreciate you being here this afternoon, Madam Chair. I'll turn it back over to you.
Thank you, Senator Lesser. And I was not going to engage in this dialogue because I don't believe there's any truth to what is being said, because I actually chair Connecticut's Trafficking in Persons Council, but felt I needed to respond when you mentioned that there's no data. So the Trafficking in Persons Council has been around since 2004. The Department of Children and Families participates on that council, and they have a human anti-trafficking response team called a HEART team, where they do bring in data, report back every year. And in my time as being chair, which has been, I think, since about 2016, there has been no instance where they have reported that abortion has been linked to human trafficking. And so I just want to put on the record that we do have data, and we have an entity that meets monthly.
Just to clarify, if you listen to my testimony just now, I actually quoted HEART. I mean, it's right there in my written testimony. So I'm aware of HEART. I'm aware of its data. I'm aware of what it says about sex trafficking. My point was very specific, that I don't know how good the record reporting is with Planned Parenthood, with that our friends at the Catholic Conference have been doing FOI requests with the Department of Public Health, that they've been trying to get more information about the ages of the people having abortions, the women having abortions, and what the background is. That's where I think we have a blind spot. But yes, I'm aware of the existence of HEART. It's actually mentioned in my testimony.
I don't see any other hands. Thank you for your testimony and your time.
Thank you.
Next, we will hear from Chris McNabo. I'm sorry. Oh, sorry. Harmony Jones. Sorry about that. Harmony Jones, followed by Chris McNabo.
Hello, my name is Harmony Jones. I'm a community health worker for the Middletown area with the Ministerial Health Fellowship. I'm here to talk about the Community Health Worker Bill. Community health workers are so important. They do so much for the community that most people don't even see. As a community health worker myself, I have seen so many people who are afraid to go to anyone else for help. They feel like government doesn't help them. They feel like their people don't help them because A, they don't look like them. B, they feel less than whenever they talk to people of higher up. They feel like they're unheard. And we are that middle ground. We help people who people can't help, the people that people can't reach easily, because we will go out into those communities that you guys might be afraid of. We will meet you where you're at, no matter what your situation, no matter what's going on. And that is essential to keeping the community safe and happy and working beautifully together. That is why this bill is so important. I personally helped some more people than I can think of at this point. And most of them actually come to me saying, I wouldn't have gone to anyone. I would have just dealt with it until I had to figure it out. And it's scary to know how many people actually have that issue. A whole lot of people have that issue because most people won't say they need help when they need help. However, we are that guide that will help those people who don't want to talk about it. We will help them do what's right and keep everyone safe keep them in a good spot, help them get housing where others will just say, oh, you don't have the money, figure it out. When it comes to getting rehabilitation, a lot of people push it to the side sometimes. It gets pushed under the cracks. And we are that group that will push it forward. We will not let it fall under the cracks. That is why the community health worker bill is very important. And I do very much support it. Thank you.
Thank you so much, Ms. Jones. I don't see any hands. Thank you for your testimony and your time. Next is Chris McNabb, my apologies, followed by A. Harris. McNabb?
Good afternoon, Senator Lesser, Representative Gilchrist, Representative Johnson, and Representative Case, and members of the Human Services Committee. I'm Chris McNabb, founder and CEO of Horizons, celebrating our 44th year supporting people with developmental disabilities statewide. I'm here today in support of HB 6612, which would accomplish two things: prohibit the practice of state agencies clawing back surplus funds from nonprofits at the end of the fiscal year, allowing us to retain savings and reinvest them into the provision of services, and indexing our rates to inflation. Despite the legislature already having passed 3 laws since 2017 to eliminate the practice of clawbacks, state contracting policies continue to mandate that nonprofit savings must be returned to the state. We have had to return thousands of dollars over the years, and in most years, we have run a deficit. Holding on to those dollars could have really helped us in the lean times. Even more important is Section 4 of the bill, which would index the rates the state pays us to inflation, providing increases automatically when inflation increases. We are experiencing a staffing catastrophe. Retention and recoupment costs, vehicle expenses, energy costs are unprecedented, and nursing costs are breaking the bank and not adequately funded in our rates, causing us to eliminate providing those services and thereby not supporting some of our folks. Being able to retain unspent funds would mean we'd reinvest in our most precious commodity, our staff. We'd invest in our future by providing training and mentored experiences to our future leaders, purchase buildings, equipment, and other large capital items like solar that lower our operating costs, and have the ability to think and plan beyond 1 year. What a concept. Banks laugh at us when we ask for lines of credit because we operate so close to the bone, often with lags in receiving payments for our services. Connecticut is an outlier in not allowing us to retain unspent money. Our colleagues in nearly every other state are able to invest in quality improvements and sustainability. CMS recognizes this and allows retention. Allowing revenue retention and indexing rates to inflation will be 2 very important steps of many to begin remediating the chronic underfunding of more than a decade. Thank you very much.
Thank you, Ms. McNabb. Representative Johnson.
Thank you, Madam Chair, and thank you so much, Chris, for your testimony and the amazing work that you do for the developmentally disabled and the commitment you have to the community here in Eastern Connecticut. So I just wanted to thank you for that and look forward to working with you as we move through the session and all the rest of the things that we do. Thank you, Madam Chair.
Thank you, Representative Johnson.
Thank you, Ms. McNabb. Have a great rest of your day.
Thank you, you as well.
Next is A. Harris. Oh, no. Where are they? They're with us. A. Harris is coming. In the meantime, a guest has joined Senator Lesser and is adorable as always. They're on. A. Harris. There you are. Go right ahead.
Good afternoon. Protocol has already been established, and I'd like to address the honorable members of the Connecticut General Assembly gathered today for the Human Services Committee. My name is Ms. Harris. I serve as the chair of the Phillips Metropolitan CME Church's health ministry here in Hartford, Connecticut. And we're actually in the shadows of the state capitol, as we're not that far away in the north end of town. And I wanted to speak to you today as to why it is critically important to support Raise Senate Bill 991, an act concerning the reimbursement of community health workers. It's critically important as we transition from a pandemic to an endemic, knowing that vulnerable communities that have already experienced a high level of chronic diseases like asthma, diabetes, hypertension, will need to stay connected to services. In Hartford, we experience disparities. Though we are host to the state's capital where you sit today, we have populations in our community, particularly in the North Hartford Promise Zone, who experience a life expectancy gap that is 15 to 20 years shorter than our neighbors in connected towns like West Hartford, that's simply 3 miles away. And so the Connecticut General Assembly supporting this bill, again, Senate Bill 991, in support of the reimbursement of community health workers would actually help not only continue to connect our residents to insurance, but to help them understand their benefits, help them to utilize the systems that are world renowned here in the state. It would help to reduce emergency room visits, connect our residents to primary care physicians, to dentists, to mental and behavioral support therapists and specialists, and other service providers that connect them to recovery supports as well. In addition, by engaging residents one-on-one, they can also assist them with connecting to preventative screenings to reduce the impact of chronic conditions and identify areas that can be impacted by the promotion of healthy lifestyles, including food as prescriptions. And as we review the community health needs assessments and help to implement the community health improvement plans, we see this as a critical area for improvement. And furthermore, supporting community health workers helps to diversify the workforce, and it also helps to regain and rebuild the trust that is needed in our health care systems, our hospitals. As we found during the pandemic, there's a lot of trust building that needs
Ms.
to happen.
Harris, your time has expired. Can you please summarize?
And I would just end by saying, in order to improve the quality of life, and again, increase the years of life and decrease the life expectancy gap, this support of community health workers would yield sustainability and consistency so that engagement with our healthcare systems become more consistent and the residents will experience a higher quality of life. Thank you for your time and attention, and I'd be happy to answer any questions.
Thank you so much for your testimony and for being here today. I don't see any hands. Thank you.
Thank you. Have a great afternoon.
You too. Next, we'll hear from Tony DiPaolo.
Good afternoon. Good afternoon. Am I on?
Yep, you are. Good afternoon. Go right ahead.
Thank you. Good afternoon. Thanks for your time and this opportunity to speak today. My name is Tony DiPaolo. I'm in opposition to the current language of the House Bill 6702. I'm an ATP at Agua Medical Supply. We're a complex rehab provider serving Connecticut. We are not a national organization, but an independent supplier. So-called mom and pop as we're referred to a lot. Although we're a small independent, we're every bit as qualified as the two big box national companies everybody has been speaking about. as a local supplier, we agree that there is an issue with being able to provide timely repairs. We know that we cannot get paid until any repair is completed. So as a supplier, we want the repairs to be done as soon as possible. We are open to discussions on the best way to change the process with all parties involved, and I encourage it. And with that said, it is currently difficult to get the documentation required to get an authorization from a user's insurance company and getting parts from the manufacturer in a timely manner. As for stocking parts, there are several manufacturers and each have several models and configurations, making it near impossible to keep parts for every make and model, for several reasons. But as a supplier, we need to be attentive to repair issues, for sure. I agree that there needs to be an in-depth discussion that can ultimately help with the consumer and in a better fashion, making it feasible to get equipment repaired in a timely fashion. I look forward to being able to talk about this issue further, and getting this resolved in any way possible. Thank you for your time, and I look forward to speaking to you again.
Thank you, Mr. DiPaolo. We do have some hands raised. Senator Lesser.
Yes, thank you, Madam Chair, and thank you for your testimony. I noted that you're in opposition to the current language of the bill. Have you had a chance to review the proposed changes?
I have a little bit, and there are some good wording in there. I think we're definitely on a better direction, with that language than the current language that's proposed. And we certainly would be willing to discuss that and go down that road for sure.
Okay, thank you very much.
You're welcome.
Representative Mastro Francesco.
Thank you, Madam Chair. Thank you, Tony, for your testimony. Appreciate it. Just a couple questions for clarification. So you are a supplier to the equipment. What are you doing right now for repair?
We do a full line of repair. There's a difference between a manufacturer and a supplier, and there's been some talk about that today. Manufacturer makes the equipment in a factory and is delivered to a supplier. A supplier delivers it to a person's home, gets them in the chair, fits them from the chair, makes adjustments, shows them how to properly use that and maintain the chair for what they need to do. When they have a problem, they can call us and we can come out and do an evaluation, figure out what the issue is with the chair, whether it's a wheel issue or a wheel bearing issue, or if it's a brake issue or a brake handle issue, whatever that may be. And then, we proceed with repair there, getting documentation from the doctor, getting authorization from the insurance. Seems sort of silly to make somebody pay for a repair out of pocket when they're already paying for insurance that covers these repairs. Although it is a lengthy process, and that process, I agree, needs to be changed to get these people to do those repairs. And if a person gets a chair from company A and they're unhappy with their service, they absolutely can call company B or company C to have them work on their chair, as long as they're an authorized dealer of the manufacturer of their chair.
So the question, thank you. So the question is that if you needed to get a part for that chair, you have to buy it directly from the manufacturer as an OEM product, as the original from the manufacturer. Is that correct?
That is correct. 9 times out of 10, that's the only place you can get those parts from.
Okay.
And they're specific to each manufacturer.
Okay. And if they didn't have the part and they were taking a long time, obviously people need to get their chair fixed. What do you do?
We try and push to get that as soon as possible. And as soon as they make it available to us, we can get the repair done.
Is that the same with every manufacturer? They all have their own individual, it's a certain brand and you must buy the part directly from that manufacturer?
Right. Manufacturer A makes a power chair, manufacturer B makes a power chair, but their parts are not interchangeable, or there are very few parts that are interchangeable.
Gotcha. Okay.
Which is unfortunate.
Yeah. Thank you for the clarification. I appreciate it. That's it, Madam Chair.
Thank you, Representative. Thank you, Mr. DiPaolo. Have a great day.
You're welcome. Thank you.
All right. Next, we will hear from Lacey Giro, followed by Terry Ford.
Good afternoon, Chair Gilchrist and Chair Lesser. My name is Lacey Giroux, and I'm the manager of state policy for the National Diaper Bank Network. And I'm here today to testify in support of HB 6587, an act concerning Medicaid coverage for diapers. The National Diaper Bank Network, founded and still headquartered in New Haven, Connecticut, is committed to ensuring that all families have the basic necessities they need to thrive, including clean, dry diapers, period supplies, and other basic necessities. We work with a network of more than 225 diaper banks across the country, including 6 in Connecticut, that collect, store, and distribute free diapers to struggling families. In 2021, Connecticut diaper banks distributed more than 4 million diapers and served more than 6,000 families every month. Programs like SNAP and WIC do not cover diapers, forcing diaper banks to fill the gap. But diaper banks are currently facing unprecedented demand. During the COVID-19 pandemic, diaper banks saw anywhere from 200 to 600% increases in demand for services. And while things for a lot of us, including going back to in-person committee hearings, have gone back to normal, the demand has not changed and families are still struggling. In fact, 1 in 3 US families experience diaper insecurity. The National Diaper Bank Network strongly supports House Bill 6587, because we support creating opportunities for families in Connecticut. Diapers are not just diapers. Diapers create opportunities. Most child care centers require parents to provide a full day's or week's supply of disposable diapers when caring for a baby or toddler. And having diapers allows for infants to go to childcare, which means that parents can go to work. A clean, dry supply of diapers can reduce health costs, as families will no longer have to wait long periods of time before changing a child's diaper, reducing rates of diaper dermatitis, diaper rash, and urinary tract infections. Having diapers will also create economic opportunities for families, as an adequate monthly supply of diapers costs between $72 and $100 a month, depending on where a family lives and where they're getting their diapers from. The Center for Economic Policy Research estimates that the poorest fifth of US families spend nearly 14% of their post-tax income on diapers. This legislation allows for Connecticut families to have more than just diapers. This allows for the families to have opportunities. Thank you, Chair Gilchrist and Chair Lesser, who looks like you might be familiar with diapers, for the opportunity to speak on this bill. And thank you to the committee for your continued service and dedication to the state of Connecticut. I ask for your support for this legislation.
Thank you, Lacey. Good to see you. Senator Lesser does have his hand raised.
Yes, thank you, Madam Chair. And yes, I am familiar with the diaper. Wanted though to ask, because one of the, in conversations with the Department of Social Services, the pushback that we've had against this proposal is not a policy-based one. It's just whether or not CMS is likely to approve funding for diapers. I didn't know in your conversations in other states. I know that no state has actually done this yet, but do we have any indication that this is likely? And what do you think our chances are?
Yeah, I really can't speak to it because, like you said, we haven't seen it in other states. I will say that it's not the only state. Connecticut is not the only state that wants to do this year. So there might be some pressure. The governor of Tennessee has voiced that he would also like to get this done in Tennessee. So having 2 states that are trying to do this might push a little bit further. But because this is a new piece of legislation and something that has not passed before, we are not sure as to what that might look like in getting that a waiver.
Okay. All right. Thank you very much.
Thank you, Senator. Representative Mastro Francesco.
Thank you, Madam Chair. Thank you for coming in or for testifying today with your comments. I appreciate it. I'm curious, the funding that you get, do you ever get any outside funding from private organizations to help the diaper bank? Or is your funding solely relied on the state of Connecticut?
So diaper banks get funding from a variety of resources, but primarily they get funding from individual donors. And so they rely solely on philanthropy, and in some unique situations like Connecticut, where there is some funding for diaper banks. But in most places, the diaper banks rely solely on philanthropy.
So is my question was the majority of the diaper bank here in Connecticut, is it mostly funded through the state or from private organizations of philanthropy.
I can't speak to the Diaper Bank of Connecticut. I know there are a few people on the call. There are 6 diaper banks in Connecticut, so I know that a lot of them are getting majority of their funds from philanthropy, but we represent more than 220 diaper banks, more than 300 basic needs banks across the country. So they all run a little differently.
They do. Okay. Thank you so much. I appreciate it. Thank you, Madam Chair.
Thank you, Representative. And thank you so much for being here, Lacey. Good to see you again.
Thank you.
Next is Terry Ford.
Thank you, Madam Chair, and thank you to the members of the Human Services Committee. I am Terry Ford, Horizons COO. Horizons provides services to those with intellectual and developmental disabilities where they live, work, play, and learn. And some of those crucial services we provide are through the Department of Developmental Services, and they include residential, employment, day, retirement, respite, transportation, and nursing. And thank you for the opportunity to provide testimony in support of HB 6612. Year after year, we encounter an unnecessary obstacle, and Representative Dathan, and likely you, many of you as well, have identified what this issue is. How do we provide quality and reduce future costs when we cannot invest current savings into the next fiscal year? It just doesn't make sense. That old way that you heard about today, that for cost settlement, that's a legacy thing, and Connecticut is certainly an anomaly compared to other states. We face historic staff shortages, resulting in significant reduction in services rendered. Our staff burnout and low recruitment rates from qualified applicants are 2 significant causes of this staff shortage. We know there's no silver bullet to our current staff shortage, so allowing providers to invest at their discretion previous year's savings in staff recruitment, staff retention, and professional development is a useful tool. Capital investments will also improve our quality and reduce future costs. Yet our inability to retain savings did cause Horizons to miss such an opportunity just this very year. We were unable to accept a generous property gift from a local benefactor due to the lack of resources for renovation. An opportunity was missed there to save money. I'm also testifying in support of Section 4 of the bill. As we are a service provider, staff retention is key to our stability. Staff retention is also critical for our ability to reduce the DDS waiting list. Currently, our industry has a significant turnover rate. You heard that already. Staff wages keeping pace with inflation will undoubtedly improve our retention, and indexing rates to inflation can help emerging leaders to see a career path in this field. The dearth of future leaders is a significant cause for concern. As we know you're aware, DDS providers haven't received an agency COLA since 2007, and everything we purchase costs significantly more than what we were reimbursed for at the 2007 rate. As an example, vehicle costs are unsustainable in this current reimbursement rate, so we are currently reducing our fleet of vehicles, which obviously has a negative impact on the individuals we support, and equally important, it's had a negative impact on the families of the individuals. This impact includes reduced services, and for some families, it requires family members to provide transportation to and from our services, and sometimes this reduces their ability to do the work, and that makes the work crisis worse for everybody. I do want to thank you for the opportunity to testify in support of this important bill, and I also deeply want to thank you for your support in previous years. Once again, I ask you to please support HB 6612. Thank you.
Thank you, Mr. Ford, for your testimony and your time today. Next, we're going to David Parker, which is a pre-recorded video, so please just bear with us momentarily.
I can just scream to you.
We're going to keep working on being able to see the videos. So we're going to move forward as we work on our technical issue. So next up is Beverly Kidder.
Good afternoon. My name is Beverly Kidder. I work at the Agency on Aging of South Central Connecticut, and I'm testifying today on behalf of State Bill 1052, supporting the expansion of the Service Navigator program. I have been working in the field of information and assistance for more than 50 years. Connecticut has a broad array of benefits and services available to help seniors live as independently as possible in settings of their choice. But accessing these services and benefits is very difficult. Multiple benefits are provided by many departments in state government. Each department has its own definition of terms and qualifying standards and requirements. Within the varying departments, there are multiple programs that have requirements unique to each program. Federal benefit programs also impose multiple varying requirements in order to access benefits. This phenomenon creates a complicated system for people to navigate. During my career, I have assisted hundreds of individuals who are board members of agencies, executives of corporations, and community leaders who have reached out to me, sheepishly embarrassed, seeking assistance navigating the maze of state and federal benefits that they know exist, but they don't know how to access. Imagine the degree of difficulty and frustration that frail older adults experience in similar situations when they're attempting to qualify for benefits to which they're entitled. So for this reason, last year, the Agencies on Aging and the State Unit on Aging collaborated to create a position called Service Navigator to assist older adults who have tried unsuccessfully to access available benefits, even when they had the assistance of a benefit counselor. Some situations are so complex, a benefits counselor cannot, despite their knowledge, cannot allocate the amount of time necessary to resolve really complex cases. The Service Navigator position allots the time needed to manage truly complex cases. The first year success of the Navigator program has demonstrated the need for additional navigators. State Bill 1052 seeks to increase the number of navigators statewide by 2 additional navigators per region to help older adults and their families receive the benefits for which they qualify, but are unable to decipher the complex benefit system on their own. Please support State Bill 1052 and help our older adults get the benefits that many of you have worked so hard to make available to them in the first place. Thank you.
Thank you, Ms. Kidder. Perfect 3 minutes. I don't
Timing
see.
is everything.
Yeah, wonderful. Thank you so much. We're going to go back and try the video again.
$12 years ago, I was
We'll continue to work on it. Next up is 52, Richard Famiglietti, followed by Kevin Callahan.
Good evening, Human Services Committee and everybody else.
Hello, my name is Richard Famiglietti, and I'm here to support a version of the House Bill 6702 concerning the right to repair powered wheelchairs. First of all, let me thank the Human Services Committee and everyone involved for at least raising this bill in this important matter and this intolerable delay for any wheelchair repairs. I am in support of 6702, but I believe the alternative language proposed by the consumer advocates and disability rights of Connecticut will better serve people who desperately rely on their wheelchairs for transportation and just mobility in their homes. I have a spinal cord injury and I use the manual wheelchair for work and play. I'm lucky because my wheelchair is basically like a bicycle. No electronics, no diagnostic tools, no electronic tools needed to repair it. And in a pinch, I can Mickey Mouse it and get by. However, when I just need to replace wear items, even for a tire that's going bald, I have to plan 3 months ahead of time because that's how long it takes to get a new wheelchair tire, even for a manual chair. I have coworkers and friends who use power wheelchairs, who at times had the same issues with just regular wearable items. At other times when things just flat out broke, such as a faulty switch or joystick, you had to wait maybe a month or two for the repair with no loaner. It shouldn't be the responsibility for the end user to repair their chair. I ask you, how frustrated do you get when that person at the red light doesn't immediately go within the first 2 seconds? We've all done it. We're guilty. We beep the horn. Now imagine a flat tire on your car and it takes you 3 days to repair it. Now imagine somebody in a wheelchair whose wheelchair is broke and you make a phone call and they tell you the tech can't even come out to evaluate it for a week. I urge you to look at those alternative language. I think they're very reasonable. And the bill needs to be adjusted to reflect that. Another quick way to eliminate some of the delay. Why is it that a wheelchair that Medicaid pay for, why does the vendor need to get documentation from my doctor after the tech saw that I have a worn out tire? And then it takes maybe a week to 4 weeks for my doctor to see the request and send back the paperwork to the vendor. And then the vendor can submit to Medicaid for the approval and then order the part and then schedule the repair. And then 3 months later, I got a tire. Thank you.
Thank you so much, Mr. Famiglietti, for being here and for your testimony.
You're welcome. Oh, and good job on my name, by the way.
I'm trying. Thanks. I said it over and over in my head. Next, is Kevin Callahan with us? Okay, then we'll go on to June Vendetti, followed by Gretchen Raffa.
Good afternoon, Representative Gilchrist, Senator Lesser, Senator Seminara, and Representative Case, and all distinguished members of the Human Services Committee. I am testifying today in opposition to HB 6618, an act concerning medical assistance for certain persons receiving abortion care. I have testified previously on another bill that I am totally against abortion. Taking the life of an unborn child should be illegal. No taxpayer dollars should be earmarked for such a horrific action, such as abortion. That $2 million could be used to fund practical programs which could help women and children, not harm them. I can't believe Governor Lamont would even consider doing this. If women want to kill their child, Planned Parenthood is making millions of dollars doing just that. And so they could certainly pay for the woman who can't afford it. It should not be up to the taxpayer to fund women coming out from out of state. Excuse me. Why is the taxpayer being asked to do this? We don't pay for out-of-state women to come to Connecticut to receive services that may save their unborn child's life. And Connecticut is full with state-of-the-art medical care, which may not be available in other states. What exactly are we paying for besides the abortion itself? Are we paying for her room and board? Are we paying for medical bills that could arise from complications from the abortion? This will have immoral ramifications. Connecticut is quickly becoming Death Valley. Taking care of women who want an abortion because their state does not have it should not be one of those things that we should be responsible for. We need to change the behavior of women who are seeking abortions. We need to find out why they want an abortion. We need to protect the woman to prevent her from having any complications related to the abortion. Planned Parenthood certainly doesn't care. The more babies they kill, the happier they are, which is totally wrong. We live in a very sick society. It's time for people to wake up and learn how to take responsibility for their actions. Killing their child is against the fifth commandment, thou shalt not kill. Perhaps if women sought the will of God more often, we wouldn't be having this conversation. Respectfully submitted, June Vendetti.
Thank you, Ms. Vendetti. I don't see any hands. Thank you for your testimony and your time.
Thank you.
Next up is Gretchen Raffa. Go right ahead.
Good afternoon, Senator Lesser, Representative Gilchrist, and honorable members of the Human Services Committee. My name is Gretchen Raffa, Vice President of Public Policy Advocacy and Organizing with Planned Parenthood of Southern New England, testifying in support of Raised House Bill 6618, an act concerning medical assistance for certain persons receiving abortion care, and House Bill 6617, an act promoting equity and coverage for fertility care. As the state's largest provider of sexual and reproductive health care to over 50,000 patients last year at 14 health centers across the state, we believe that every person should have access to quality, affordable, and compassionate health care as a basic human right, regardless of who you are, where you live, your income, or if you have health insurance. We are very grateful for this administration's continued commitment and action to protect and expand access to comprehensive reproductive health care, including allocating funding in the FY24 budget. As our state continues to lead in advancing reproductive freedom, we must continue to invest in solutions that increase access to abortion and pregnancy-related care, and invest in the infrastructure and long-term sustainability of abortion care providers. Access to care has never been more vital. 1 in 3 women of reproductive age in the United States and more trans and non-binary people no longer have access to abortion care in their state because 18 states have banned or severely restricted abortion, one of the safest and most common medical procedures, and more states are likely to do it this year. In the most recent 7 months since the United States Supreme Court Dobbs decision, Planned Parenthood of Southern New England health centers in Connecticut have seen a small increase of 30% in patients traveling from states that have banned abortion to access abortion care in our state. We look forward to working with the committee and DSS on House Bill 6618 and do everything we can to remove barriers, including financial barriers for people in Connecticut and those who are forced to travel here to access safe, legal abortion care. Abortion is an economic issue for pregnant people and their families. Forcing people to have children forces them to take on additional financial responsibilities. When people are denied the freedom to access abortion or birth control, they're denied the freedom to make decisions about their own lives and futures. It is also our responsibility as a reproductive health care provider and advocate that our work must be inclusive to ensure that people have access not only to abortion and contraception care, but also people have access to pregnancy care and equitable access to infertility evaluation, treatment, and care. The reality is, for many people, they require fertility assistance to have children, yet it's often out of reach due to the cost, such as healthcare, which ranges from thousands to tens of thousands of dollars. House Bill 6617 will address a critical need by eliminating barriers to fertility care coverage, including expanding it to public health insurance and making it inclusive of all families, requiring insurance coverage for LGBTQ+ and single individuals who need medical care to build their families, as well as people who are diagnosed infertile. The Medicaid program's lack of coverage for fertility assistance has a disproportionate impact on women of color. Planned Parenthood understands how important it is for all people to have access to high-quality, non-judgmental healthcare that affirms their identity, their family, and their sexuality, as well as the ability and resources to make their own healthcare decisions with dignity. We won't stop fighting for the rights of all people to make their own decisions about their bodies, decide what their families look like, and live healthy and self-determined lives. Thank you for your time and consideration of this important legislation. I urge you to support House Bill 6617 and 6618. Thank you for your time.
Thank you, Ms. Raffa. Representative Master Francesco.
Thank you, Madam Chair. Thank you, Gretchen, for your testimony. I appreciate it. I just quick question for you. Does Planned Parenthood, they do get a lot of funding. You get a lot of funding from the state, government, and so forth. And I'm sure the Planned Parenthood takes in a lot of private funding as well. Does Planned Parenthood pay for abortions for people from out of state with your own funding as opposed from getting it from the taxpayers?
We see our patients and provide care regardless of their ability to pay full cost for their care. That's why it's essential for us as a healthcare provider that we have state and federal grants to help cover the cost of care so that everyone, specifically people that are shut out of the public and private health insurance programs, or for people that are forced to travel out of their state, out of their own community to access healthcare because state politicians have banned it in their own state, that they can get the care that they need. So yes, we see people regardless of their ability to pay.
Okay, and so I'm just curious, if the state of Connecticut did not fund this program as they want to, would you still provide the services and you pay for it, Planned Parenthood pay for it themselves? Would you provide that?
Well, any cost that a patient can't provide, or if they don't have public or private health insurance coverage, we do end up absorbing the cost of care. And as the largest reproductive healthcare provider that sees 50,000 plus patients every year, it is essential for our long-term sustainability that people get the healthcare they need, number one, but have health insurance coverage or funding to cover the cost of that healthcare.
Right. Yeah, no, I understand that. The problem is that the state of Connecticut, the taxpayer here has to pay for services. So what I'm saying is that why doesn't Planned Parenthood just do that and not ask the state for money? Why? I guess my question to you is, why do you feel that it's necessary for the taxpayers to pay for out of state abortions as opposed to your corporation, your Planned Parenthood just doing it? Why should the taxpayers fund it?
Because we're in unprecedented times, Representative. Respectfully, we are living in a country now where the Supreme Court stripped us of our fundamental right to be able to control our own bodies and make decisions about our own lives. And state legislators across this country have banned a safe medical procedure that 1 in 4 women in America need as part of comprehensive reproductive health care. I think it is imperative that as we continue in our state to ensure that all people can make the best decisions about their health care, have the resources they need to actually be able to control their bodies, plan their families, and be able to have not only healthy pregnancies and healthy birth outcomes, but also to make the decision to have an abortion if that is the best decision for that person. And that should be made in consultation with that person and their healthcare provider.
Right. No, and I understand. I just want to make one clarification. The Supreme Court did not ban abortion. The Supreme Court gave that power to the states to make that decision. And clearly the state of Connecticut allows abortion. So that's really not an accurate statement. I guess just my concern is I just don't think the taxpayers should be paying for something like that. If Planned Parenthood is so concerned about women's reproductive rights, as they so call it, then you pay for it yourself, is just my opinion. But I thank you for your testimony. That's it, Madam Chair.
Thank you, Representative. Thank you so much, Ms. Rappa, for your work and for being here today.
Thank you. Have a good afternoon.
You too. We are going to the videos again. And no, nope. Oh, nope. Should we just keep going? Sorry. To the video.
Years ago, I was diagnosed with MS. And within a couple of years, I have found myself basically stuck in this wheelchair for about 80% of my life. This thing needs to work all the time, and I'm having problems keeping it that way.
You never know when your chair's gonna break down and you need a quicker response time. If people had to wait that long to get their car repaired, they wouldn't go to that service station. But we really don't have that many choices for chairs, so we're kind of stuck.
I lost this arm a while back. The linkage in the back broke, and this arm was just swapping on the side. So I called the company that handles my repairs, and it took them a week to give me a call back, a whole week just to call me back. So then it took them a month to come out and to look at the chair. It was like a $5 component. It ultimately took 3 months to repair it. So Al, what's wrong with this picture?
When I go long distances, this chair is my life. It's difficult just having two companies that come out here to repair chairs, and there should be more.
This whole industry needs a shake-up, I think. Give me a choice to pick 2 or 3 guys, and whoever does the best job, I will stick with them the next time. There's some bills out there that are wanting to address this issue and give us wheelchair people a bigger choice, a better choice, and I wholeheartedly support these bills.
So that was David Parker, and now we're going to hear from Kathy Hamilton.
I was born with cerebral palsy. I was born 2 months early, and as a result of being born premature, I suffer from the disability of spastic cerebral palsy, but I try not to let that stand in my way of living my life. I first started using a power assist scooter when I moved to New Horizons Village way back 14 years ago, and my wheelchair vendor was not the greatest.
Like if my chair breaks down or all of a sudden stops working, I have to wait a few weeks before they come look at it, then another few more weeks to have them fix it.
You may have to wait maybe a couple, 3 days to maybe a month, maybe longer for repairs. Like I've had to wait weeks and weeks to get one thing repaired.
There needs to be more options for us within the state of Connecticut right now. There are only 2 options. Whereas if we had, say if we have just something where like a seatbelt needs to be repaired, we could go to a local repair shop where you're not waiting for what feels like an eternity for a part to show up just so they can fix your chair so you can, go out and enjoy your life to the fullest. Why not do that?
I would like to be able to explore that. If I can't get, fast enough service from one company, I could go to another one.
They don't realize, because some of us can't move without our chairs, they don't realize that our chairs are a part of us, and if we don't have those, then we can't fully function. I support the upcoming legislation that's going through the Connecticut General Assembly right now to give us more choices and options for wheelchair repair.
Thank you so much. And we're going to go to one final video.
I really started using a wheelchair at around the age of 7. I started having difficulty transferring from the manual to the electric, which I needed for outside. So I had to choose, either use one or the other. So I chose the electric. It's vital to me, otherwise I'd be stuck in bed. And that's an even worse option.
I have had to stay in bed for days because my chair needed to be repaired. So our chairs are very important to us. They're like a car to us. So we need them fixed as soon as possible.
You call to make an appointment, and it takes forever to get to a human being. It takes you at least 3 weeks to get an appointment. Then when they get there, they tell you they have to order the parts because they don't keep any spare parts anymore. It takes at least 2 months for them to get the part, and then it's not the right part. And long story short, a basic repair can take you 6 months or more.
I've been waiting so long to get this wheelchair repaired. My tires are so bald. I slide anywhere, even on flat ground. I'm just really in a dangerous mode, and I'm hoping that I get this done soon. But it's been 3 months already.
To get new batteries or tires, you need priors from your doctor every time. Imagine for a minute if you went to a garage to get new tires put on your car, and they told you, we can't put the new tires on the car till we get a prior from the car dealers. I'm gonna need the chair for as long as I'm on this earth. My disability is not gonna change, so I don't know why we need priors to get everything done.
You have to have a way to function. They need to improve what they're doing because the system that exists now is useless.
Thank you so much to those who submitted videos in lieu of testimony. We really appreciate it. It's so important to hear your experience. Next, we will go to Giselle Carlotta McDonald. Okay, we don't see her on. David Reynolds, followed by John Tylisak.
Okay. Yes, members of the committee, my name is David Reynolds. I am Associate Director of Public Policy for the Connecticut Catholic Conference, and I'm here today to speak in opposition to House Bill 6618. Let you know the conference stands in strong opposition to this bill. This opposition is based on 3 concerns. First, the proposed bill advocates for the spending of taxpayers' dollars on an act of violence that results in the termination of an innocent and defense of human life. The taxpayer funding of abortion would force people of good conscience who strongly oppose abortion on moral and religious grounds to participate in this grave evil against their will. Second, it would redirect funds that are vitally needed in our own state to address issues such as homelessness and mental health services. And finally, the bill as written appears to raise more unanswered and critical questions that remain unanswered and should be answered by this committee. A commonly used word by advocates of this legislation is choice. They believe a woman has a right to choose whether the human life in her womb lives or dies. Their viewpoint treats this unborn child as nothing more than property and totally disregards its humanity. However, in crafting this legislation, its supporters have given taxpayers no choice in funding an activity that many feel is completely immoral. The conference also believes that the $2 million placed in the governor's proposed budget to fund this legislation will be better spent on meeting critical needs of citizens of our state. The Christian faith calls for to help our neighbors in need. Our state has many people in need of roofs over their heads, mental health services, addiction services, and food for their families, to name only a few. Connecticut can better serve the common good by prioritizing policies that comprehensively assist men, women, children, and families in need. Passing this legislation will merely allow Connecticut to become an abortion destination state. We believe Connecticut residents would rather have their tax dollars used for better purposes. Right now, there are millions of dollars in funds raised by private nonprofits that can be used for this purpose. Taxpayers' funds are not needed to fund women traveling between states. Planned Parenthood of Southern New England itself is also very strong financially, with approximately $15 million in endowment funds and other financial stock investments. And as a nonprofit, can easily assist these women in these costs for coming into Connecticut. The conference also has some critical questions that it feels should be asked about this legislation. If a woman arranges to travel to Connecticut for having an abortion and then changes her mind at the clinic, would she still be eligible for the funding to cover her travel and lodging expenses? Or would the refusal of funding be used as pressure for her to receive the abortion? Another one is does having out-of-state woman receive a medical procedure that could result in complications leave them with no options for following up with the provider should they go back to their home state? And if a woman does have a complication and has to go to an emergency room, will the state cover the expenses? Additionally, the term abortion care and related services is used throughout the bill, but never really defined. And then there's another term, limited access, a state with limited access.
Reynolds, your time has expired. Can you please summarize?
I will do that. Is a state with limited access, does that mean a state that has parental notification laws? Also, and one last comment, that this bill kind of makes a misleading statement and implication to the public and legislators that federal funds are available. Federal funds will not be available under the Hyde Amendment to fund anything in this bill. So the conference urges this committee to reject HB 6618. Thank you.
Thank you, Mr. Reynolds. Seeing no questions, thank you for your testimony and your time.
Okay.
Next, we'll go to John Tylazak.
Am I on?
You are. Go right ahead.
Well, first, good afternoon to Senator Lessers, Representative Gilchrist, Senator Seminora, Representative Case, and all the members of the Human Services Committee. My name is John Tylashak, and I am a program director for CLASP Homes. CLASP is an organization that provides residential and vocational services to adults with intellectual disabilities and autism. To begin, I'd like to thank you for the opportunity to testify for you in support of House Bill 6612. That bill would do two main things. One is prohibit the practice of cost settlement, which is the clawing back of surplus funds. This was clearly the intent of the legislature to end the practice of clawing back these unspent funds, but the policy has not been implemented in a way that's been helpful. However, a number of people prior to me have already spoken to this matter. So in the interest of brevity, I'll move on to the second point, which is the fact that I'm supporting in section 4 of the bill, which would index the rate the state pays for contracted nonprofit health and human services to inflation, a COLA clause, so that we have automatic increases when inflation occurs. I have been with CLASP for 30 years. From 2007 to 2017, there was about 2.5% consumer price increase inflation a year. There was 0 increases in our budget. For reference, in 2007, the iPhone 1 came out. Anybody still using it? Now, we are very appreciative of the one-time funding shots that we got most recently to increase the salary of our direct care staff. Those are much appreciated and very good. However, they also bring with them different issues such as wage compression. Wage compression occurs when you have somebody who's been a dedicated employee for 10 years making the same amount as somebody who's been there for 6 months. Wage compression also impacts the level of skills that we require people to have. So we need to recognize that with our staff, there is a learning curve. We want people to stay with us because a number of people early on talked about efficiency. It's hard to get efficiency, but you can get quality service. And quality service comes with having staff who have been with us for some length of time. And in order to have staff who can stay with us for some length of time, they need to be able to earn a living wage, hopefully working only one job. But it is very difficult. Many people have spoken to the staffing crisis. Right now, we are in a staffing crisis. We have people who are working multiple jobs, and we are still unable to attract enough people, quality people. We want people who can provide services for the people we serve in a way that respects their human dignity. So I would urge the members of the committee to support House Bill 6612, and in particular, the COLA section. Thank you.
Thank you so much, Mr. Tylasak. I hope I am saying that right. Okay, thank you so much. Is Lisa with us? Lisa Rosenthal?
I am here. Yep.
Wonderful. Go right ahead.
Thanks so much. Thank you for hearing me today, Senator Lesser, Representative Gilchrist, and members of the committee. I'm here to speak in support of Raised Bill 6617. My name's Lisa Rosenthal, and I'm the patient advocate at Loom Fertility, a practice with 4 offices in Connecticut, led by 8 board-certified reproductive endocrinologists who specialize in assisted reproductive technologies. And Loom Fertility also has an internationally recognized Gay Parents to Be program that specializes in LGBT plus family building, having been recognized for the last 6 years as a leader in healthcare equality by the Human Rights Campaign. My testimony is based on my 30 plus years in the field of infertility, both personal and professional. And while my own personal journey began when I tried to build my family, I discovered that although there was reproductive disease, my insurance carrier specifically stated that reproductive disease would not be covered, despite the treatment available that had been proved successful. That experience changed the course of my life, and I've been honored to work at Loom Fertility for 16 years. I also sit on the executive committee of the board of directors of Resolve New England. I'm a member of the American Society for Reproductive Medicine, the New England Fertility Society, and I'm currently co-chairing Resolve, the National Infertility Association's Federal Advocacy Day, a volunteer committee. I'm here in support of expanding access to fertility care in Connecticut. The Affordable Families Coalition has been working for 3 years on a bill to expand fertility care coverage to single people and the LGBTQIA+ community. I'm happy to support a bill that goes even further than that with Raised Bill 6617. Including participants in Medicaid/Husky would set a precedent in our country. And in reference to Senator Lesser's question earlier, there is no precedent in any other state for funding through the state. Just as Melissa's law set the precedent for fertility preservation in 2018, thank you, Senator Lesser, we would welcome the increased coverage. Our doctors regularly see prospective patients who would benefit from the scientific and medical treatments that have been proved to be effective, as confirmed by the American Medical Association, ASRM, SART, and many other scientific and medical associations, only to hear that there is no fertility treatment coverage available for these patients. And like many of us, they cannot afford to pay for it out of pocket. Our doctors then need to deliver devastating news, ending someone's hopes and dreams for a family. Please keep in mind that the American Medical Association defines infertility as a reproductive disease affecting 1 in 5 Americans, according to the Centers for Disease Control, and is often specifically excluded from medical insurance coverage when other diseases are covered. There are several aspects of the bill as it's been presented that concern me that I would want to see addressed so that we don't inadvertently or purposely restrict access that is currently afforded to those seeking treatment in Connecticut, namely regarding the enrollee. Davina Fankhauser, Fertility Within Reach, also of the Affordable Families Coalition, specifies those concerns much more clearly than I can. So I yield to her expertise and would respectfully ask that you focus on her statement carefully, particularly on those who benefit. If we are promoting equity and coverage for fertility healthcare as stated in the name of Bill 6617, then we want all people in Connecticut to be able to access fertility care to build their families, including our LGBT community and single people. Despite the fact that gay men must rely on third-party reproductive services
Ms.
and pay for—
Rosenthal, your time has expired. Can you please summarize?
So despite the fact that gay men must rely on third-party reproductive services and pay for medical insurance coverage they cannot use, this bill does not go far enough for them, as they are not permitted to assign their benefits to a third party who can assist them. This bill, as it is written, does not change the lack of access that a gay man now faces. I thank you for hearing both my support and concerns with the bill.
Thank you. Senator Lesser.
Yes, thank you, Lisa. And I just wanted to see if you could expound a little bit more. Obviously, I would love to expand coverage beyond what we currently have, but would be wary of anything that restricts our existing laws in any way. Can you just sort of speak to a little bit more detail about your concerns?
Yes. So for right now, there is a certain there's a certain ability for a patient to assign benefits to someone else, which specifically addresses enrollee. And what we want to make sure is that we don't go backwards with that. What we're asking for is to expand the ability for somebody to, again, for services that they are already paying for, but they cannot use themselves, for them to be able to assign those benefits. Specifically, if a gay man can't go through stimulation and retrieval of eggs, clearly, but he can assign those benefits to someone who can, and so be able to use the IVF coverage that they pay for in their insurance by assigning their benefits to someone else. I'm not sure that exactly answered your question, Senator Lesser, but I tried.
Thank you. And you did mention Melissa's law. I know that the way that the bill is drafted repeals our existing insurance statute. I don't know if there was a reason why we did it that way as opposed to amending the existing statute. Does the bill in any way restrict access to iatrogenic services?
It can. It has proven to be a little problematic. As welcome as it absolutely has been, it has been proven to be a little problematic. But, for those patients, there are a lot of other resources and there's a lot of other support. And quite frankly, so it doesn't affect them as much. But when you look at the LGBTQ population, and I want to just remind you also the single person population, that's where it becomes more of a problem because they don't have the same resources that, say, a cancer patient might face.
I'm sorry, I'm not following. What you said, the resources a cancer patient might face what?
Well, the resources that a cancer patient can utilize. The LGBTQ community doesn't have a Livestrong, for instance, who picks up some of the funding. So while Melissa's laws has created some problems, it solved many more problems than it caused.
I'm sorry, and I don't mean to go afield, but how did
That's
it?
okay. I'm sorry, what's the question?
How did it? You said you said Melissa's law created problems. How, in what way?
Because of the fact that we didn't alter a mandated law, and as a precedent setting, many other states chose to do it slightly differently without the problems that were created. I'd be happy to look into this information and send it to your office.
That would be great. Thank
Sure.
you very much.
Of course.
Good to see you. Thank you, Madam Chair.
Thank you.
Thank you, Senator. Thank you, Ms. Rosenthal.
Thank you.
Next, we'll hear from Lydia Bennett.
Hello, members of the Human Services Committee. My name is Lydia Bennett, and I am here in strong opposition to HB 6618. I am opposed to this bill because it requires taxpayers to pay for services for people that don't even reside in our state. People that support the concept behind this bill could personally give towards the things they are concerned about, rather than using state money to do so. However, the greater reason I was compelled to take time today to speak on this is that abortion is wrong and should not be supported. Support for abortion presupposes that when a woman becomes pregnant, it's only her body involved and she can do what she wants with it. However, if the developing child inside a woman's body was merely an extension of her body, then that would mean that a pregnant woman has 2 hearts, 2 brains, 20 fingers, and 20 toes. The reality is that once a woman is pregnant, she doesn't just have her body to consider, but also the body of the child she is carrying. This fact is implicitly acknowledged when women are advised not to drink alcohol or consume drugs while pregnant for the safety of the developing child. And that this is a human being growing inside the womb is undeniable. Here are just a few of the stages of fetal development, describing the stage at which the majority of abortions are performed. During weeks 7 and 8, the heart has formed. Webbed fingers and toes develop. The arms bend at elbows. Ears, eyes, eyelids, liver, and upper lip begin forming. Weeks 11 and 12, bones begin hardening, skin and fingernails begin to grow. Early sweat glands appear. That is not a description of just a clump of cells. The development is too specifically detailed. But what I found most startling about that information is that I read it on Planned Parenthood's website. Those descriptions weren't written by some pro-life advocacy group who was trying to make a point. But the point gets made. We're talking about a human being. The size or stage of development of a child should never be a reason to dispose of that child. For these reasons, I ask you to reject HB 6618. Thank you.
Thank you so much, Ms. Bennett. I'm not seeing any questions. Thank you for your testimony and your time.
Thank you.
We'll go to 62, Marie Allen.
Good afternoon, Senator Lesser, Representative Gilchrist, and the members of the Human Services. Thank you for this marathon session. I do appreciate your time and your willingness to hear from the community. My name is Marie Allen. I'm a representative of the Area Agencies on Aging, or Aging CT as we're now called. We're asking for your support of SB 1052. The bill calls for state funding of 5 service navigators to be located at each of the 5 area agencies on aging. Unfortunately, older adults and their caregivers often find that they need help and guidance when they're in a crisis. And the crisis could be a hospitalization, a fall, a nursing home stay. Long-term care services are incredibly complex and confusing. How to get in-home care, Meals on Wheels, adult day services, nursing and personal care. It's a real complex maze. And what the area agencies on aging do is help them connect to the right services, figure out how to pay for them. Even individuals with funds struggle with how to get these services paid for. We use person-centered counseling and guidance to help guide these individuals. And so we're asking for your help and support of SB 1052 so that we can bring service navigators to the community. Referrals come from our local senior centers, hospitals, healthcare systems, and actually from many of our legislators when an older adult or a caregiver calls your legislative aid and asks for help navigating complex systems like Medicaid and Medicare. In addition to SB 1052, we respectfully ask for your help with HB 6703, an act concerning low-income home energy assistance. Also, we support the recommendations from the advocates regarding a consumer's right to repair a wheelchair. We hope that you will support Raised Bill 6701. Legally liable relatives really struggle to pay for funeral services for their loved ones. And of course, we support Raised Bill 6612, where we advocate for a fair and equitable funding of the human services network that supports so many of Connecticut's vulnerable residents. Finally, I would ask you to strongly support Raised Bill 6676. We are an access agency in the Department of Social Services care management system for people in the Connecticut home care programs, representing older adults, people with acquired brain injury, and personal care assistance. Passive Medicaid redetermination for individuals who have outlived their assets, are on a fixed income, and meet the clinical definition of nursing home level of care is so important. Medicaid eligibility is a long, complex process of recreating 5 years of financial records. Older persons and persons with disabilities are tasked with getting banking records, many from banks that have closed or
Ms.
merged
Allen,
with other.
your time has expired. Can you please summarize?
Yes, thank you. So we are asking for your support because the complexity often results in them getting pushed off of Medicaid and no access to care. Thank you so much for your time.
Thank you for your testimony and your time tonight. Next, we'll hear from Maureen McIntyre.
Good afternoon, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Maureen McIntyre. I am the CEO of the North Central Area Agency on Aging, one of the 5 area agencies on aging comprising Agency T. I am here in support of SB 1052, an act concerning area agencies on aging. In deference to our time together and the amount of testimony you've already heard today, I'd like to just simply share a quick story that is illustrative of the types of calls we work on every day. A gal in her 50s called us from out of state regarding her 80-year-old uncle. He had been estranged from his family for pretty much the duration of his adult life due to what is likely an undiagnosed personality disorder. The niece talked candidly about her desire to do right by him in his older years, but just simply was not sure where to start. Housing was the primary reason for her call because she was concerned about whether it was truly meeting his needs. We talked about the AAAs of housing, specifically availability, accessibility, and affordability, or lack thereof, but that's a different public hearing. We did some robust benefits counseling and eligibility screening, connecting him to many of the items and services you've heard about today, including energy assistance, durable medical equipment, community mental health services, and actually diapers and other incontinence supplies. Getting him set up with these services was just in time because an overdue trip to the doctor revealed a serious underlying health condition that was going to require unplanned and very invasive surgery, which led us into a deep dive into healthcare, and down the Medicare rabbit hole we went. We talked about what to expect and what not to expect, and what he would need when he ultimately returned home, wherever that happened to be. The most telling moment of value for the navigator came when she said, wait, can you say that one more time? Because I want to be able to repeat it exactly the way you just said it. Elder care does require a special handshake and a secret password, as my colleague Bev Kidder alluded to earlier in her testimony about the jargon and the acronyms. But this is what caring for our older adults looks like. It can be messy, it's rarely a straight line, and it's different for every family. And that's why the navigators at the area agencies on aging are so critical. We ask you to please support SB 1052 and allow us to maintain our commitment to providing free, unbiased, and trusted assistance to our shared constituents and help them remain in their homes for as long as they choose to be there. Thank you very much.
Thank you so much, Maureen. So good to see you.
Good to see you as well. Thank you for your patience and your fortitude.
Thank you. Thanks for your testimony and your time. All right. Next up is 68, Heather Gates.
Good evening. Senator Lesser, Representative Gilchrist, and members of the Human Service Committee. I am Heather Gates. I'm the president and CEO of CHR, which is Community Health Resources. We're one of Connecticut's largest and most comprehensive mental health and substance use treatment providers. In addition, we provide supportive housing, foster care, and a range of other services to address social determinants of health. We employ over 900 individuals and serve about 25,000 children, families, and adults every year. I'm here to testify on two different bills related to revenue retention and indexing. Despite the legislature's clear intent to end the practice of clawing back unspent funds or cost settlement, the policy has not yet been implemented in a way that's helpful to organizations like CHR. This proposal has always been very simple. Nonprofits should be able to reinvest savings they achieve while meeting their contractual obligations to better serve their clients. The last 3 years have been beyond taxing, with high staff vacancy rates and at the same time increased costs for salaries, health insurance, utilities, etc. We need to be able to invest in our workforce to reduce vacancy rates and meet the unprecedented demand for our services. We could use funds for tuition assistance, internship stipends, and retention and hiring incentives. We can't do this unless we can predict our revenue. We just received approval for a carry forward from one state agency 8 months into the fiscal year. We have not heard from the other state agencies yet, with very little time left in the fiscal year to use the funds. This is really a false promise to date. We need to invest in capital projects to expand services and improve existing locations. Currently, we have 3 capital projects that need funding: renovations to our methadone clinic in Putnam to treat opiate dependence, development of supported housing site in Enfield to meet the needs of the homeless, and the establishment of a subacute crisis program in Norwich to serve children in crisis. If we were able to retain revenue, we would be able to move forward with all 3 of these critical projects without relying on borrowing or the limited state funds for bonding for these kinds of projects. It makes absolutely no sense to return funds to our state agencies year after year, leaving us with no capital or ability to plan beyond 1 year or to have any equity. This is really no way to run a business. I would challenge anyone who's a business person to figure out how to do it with zero-based budgeting year after year after year. Despite the support from the committee, the legislature, and the nonprofit community, since 2017, the Innovation Incentive Program has not been implemented in the way the legislature intended. I'd also like to testify in support of Section 4 of the bill, which would index the rates the state pays for contracted
Your
human
time has
services.
expired. Can you please summarize?
Yep. In short, it would allow us to make financial decisions proactively, not reactively, and our staff and the people we serve deserve this from the state of Connecticut. So please consider both these bills and sections. Thank you.
Thank you so much. I don't see any hands. Thanks for your testimony and your time. Next, we'll hear from Jamie Hannay. Don't know if I pronounced that.
Thank you. Yes, pronounced it right. Good evening, Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Jamie Hannay, and I'm testifying tonight in support of SB 991, an act concerning Medicaid reimbursement for community health workers. Since 2007, I have worked with the YWCA and a coalition of health education and service providers to empower youth in New Britain through a program called Photo Voice. We found that teens are natural advocates, able to see and document disparities in their own neighborhoods, and then take powerful action and speak out powerfully to address those health inequities. So in 2015, inspired by these examples, we folded those assets into an innovative community health worker training program for high school students in New Britain. We attracted the attention of outside funders, including the Centers for Disease Control and Prevention that's funded us for 5 years. With that money, we were able to establish an out-of-school time training academy for community health workers in partnership with Southwestern AHEC, which actually provides the classroom 90-hour training. We've also approached the high school to see if they could incorporate the program into their health academy as a career track. So since 2020, through this out-of-school health academy, the CHW Academy, we've trained 12 youth in 3 small cohorts of 4 youth and 1 adult co-learner. And we'll be starting another training in the spring with that CDC support. The impact on youth has been tremendous. And several of them have provided written testimony about the importance of the program to them. Just to quote one, I would like everybody that has the opportunity to become a community health worker to please take advantage of it, because that is one of the biggest opportunities someone could have. No one will ever regret being part of the CHW family. What these teens have done in just less than 2 years in the field since they completed that training is nothing short of astounding. They carried out a COVID campaign in New Britain's East Side that has increased vaccine access, not only within the community, but also within their own families. One stated, if it wasn't for the CHW program, I could never have convinced my parents to get vaccinated so they could protect our family and our community. They have dispelled COVID myths and misinformation through thousands of flyers and social media messages in English, Spanish, and Somali. They have partnered with Health Equity Solutions on COVID Real Talk panels and have trusted
Your time has
messenger.
expired. Can you please summarize?
Okay, so what we know, they are having a tremendous impact on the community, but we need your help. We need more paid internships, apprenticeships. We need people to hire these entry-level CHWs. And most of all, I'm speaking out, we need SB 991 to show that our youth, that they have actual career paths to a viable career as CHWs. We found that once they're trained, they often, rather than continuing on a career path, take jobs in the fast food industry because it pays more. So we don't want to lose these tremendous workers. So I urge you to pass SB 991. Thank you for your time.
Thank you so much. Yes, Senator Seminara.
Thank you so much for your testimony. I think it's incredible that you have provided this opportunity to the youths in your area. And I am so sorry to hear, though, that they are being better paid at McDonald's or a fast food restaurant than after going through the process of being trained, are unable to find employment where they're able to make a living, essentially. So I applaud you for this work, and I applaud you for coming to advocate for them and for them advocating for themselves. And hopefully we can do something this session to increase the program. Thank you so much. And thank you for the work you do.
Thank you. Thanks for your support.
Great. Thank you so much. Have a wonderful evening.
Thank you.
Next, we'll hear from Amy Sorensen.
Good evening, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the Human Services Committee. My name is Amy Sorensen, and I'm the Director of Human Resources for CLASP Homes in Fairfield County. We have 11 group homes and a day program that service individuals with disabilities that we own, operate, maintain, and staff. Our homes are staffed 24 hours a day, 7 days a week, rain or shine or snow, holidays, weekends. So I'm here to testify in support of HB 6612 and specifically Section 4, which would index the rates the state pays for contracted health and human services to inflation and provide increases automatically when inflation increases. I'm relatively new to this industry, so as you can imagine, I'm used to receiving a COLA raise yearly. So I fully support Section 4, but would also like to see these increases be given to everyone at the agency, not just direct care or office workers or managers. Between full-time and part-time We employ about 160 employees ranging from the main office, direct care providers, managers, assistant managers, et cetera. We don't have extra staff. In fact, we're short-staffed, as I know most other agencies are too. But everyone here at CLASS plays an important and vital role in the lives of the population we serve. Picking and choosing who should receive a raise and when seems unfair to me. Everyone at this agency cares deeply about the people we serve, and all of us have one goal in mind: the safety and well-being of the people we serve, of our residents and DATE program participants. It is our job as an agency to make sure they are cared for, healthy, safe, and given social and learning opportunities whenever possible. You will not find a more dedicated and caring group of people, and they all deserve to be treated equally, which includes an automatic raises when inflation increases across the agency. And I thank you for your time.
Thank you, Ms. Sorensen. Seeing no hands, thank you for your testimony and your time tonight.
All right, thank you.
Next, we'll hear from Richard Zablocki. Richard, are you with us? Can you please unmute?
Yeah, can you hear me now?
Yes, we can. Go right ahead. Yep, we can hear you. Go ahead.
I registered to oppose the abortion tourism bill that's been debated now. And I'm calling in to say that it's unconscionable to have people who recognize or believe that the unborn child is actually an unborn child to spend state money. If some private people want to do it, that's another story. But to spend taxpayer money, I'm a taxpayer here, to aid and abet people from other states where other legislatures across the country, about half of them, forbid it now. They don't have any Planned Parenthood or other abortion facilities. And for us to pay their way into our state so their unborn child can be killed is just, it's beyond the pale. That's it. That's all I want to say.
Thank you, Mr. Zablocki. Have a wonderful evening.
Bye.
Next is Deb Poulin.
Good evening. Good evening, everyone. For the record, my name is Deb Poulin. I'm the Executive Director of the Connecticut Association for Community Action. We are the state association that works with the state's 9 community action agencies, and they serve about 200,000 low-income residents across the state each year in all of your districts. I have submitted testimony on behalf of the network on 4 bills before you today. Senate Bill 1052 regarding the area agencies on aging, House Bill 6703 regarding the Low-Income Home Energy Assistance Program, House Bill 6612 regarding nonprofit rates, and Senate Bill 991 regarding Medicaid reimbursement for community health workers. For the sake of time, I'm going to limit my remarks just to the community health worker bill. I want to thank the committee for its leadership on this issue and for recognizing the value of community health workers, and also to lift up the work of Health Equity Solutions and the CHWs and others who have been working in coalition on this bill for the last couple of years. You may be aware of all of the work that community health workers do, and especially those who are in healthcare environments. I'm also so proud as well of the work that the community health workers do in non-healthcare environments, including those provided at community action agencies. Our community action agencies have been employing CHWs since 2019. And many have been certified, dozens and dozens have been certified since the certification program was started just a couple of years ago at the State Department of Public Health. The legislature wisely provided funding in the state budget for community health workers at community action agencies to support the work. That funding is getting underway right now and will expire at the end of December in 2024. That should be right in time for Medicaid coverage to kick in and provide a sustainable funding source for this very valuable program. We are happy to work with the Department of Social Services, with this committee, and with other partners to work out mutually acceptable language to move this initiative forward. And of course, I'm happy to answer questions on this bill or any of the other bills on which I submitted testimony tonight, right now, or offline at your convenience. Thank you so much.
Thank you, Deb. So good to see you, and thank you for the work you do.
Thank you.
Have a wonderful evening.
You too.
Next, we'll hear from Kate LeBlanc.
Hello. Good evening, Chair Lesser, Chair Gilchrist, and members of the committee. My name is Kate Weldon LeBlanc, and I'm the Executive Director of Resolve New England. Resolve New England is an independent nonprofit organization that provides emotional support, education, and advocacy for all those in New England that are struggling with fertility or family building. R&E strongly supports House Bill 6617, which will ensure that more Connecticut residents have equitable access to fertility treatment and fertility preservation so that they can grow the families of their dreams. Connecticut is a leader in fertility coverage, including a willingness to revise existing law as needed. We remain ever grateful to Melissa Thompson and to you, Chairman Lesser, and others for the incredible leadership that led to Melissa's law in 2017. I do not believe that this law has created problems, but rather that its scope needs to be clarified in statute, and that's part of what this bill would do. House Bill 6617 provides an opportunity for Connecticut to lead again. This bill proposes a new section rather than revising the existing law, because infertility is not a term that applies to everyone who needs fertility care, including LGBTQ and unpartnered people. I am passionate about family building in part because my husband Joe and I struggled for years to become parents. We ultimately did IVF and are extremely grateful to have our daughter, who is now 15. I want to speak briefly about our experience in contrast to other people that I've had the privilege of getting to know in my work at R&E. To access insurance coverage for fertility care, Joe and I had to self-report that we had been trying to conceive unsuccessfully for at least a year, which cost us nothing. With this, we went to what I call the starting line, which is receiving diagnostic care so that we and our medical team could try to understand what was happening and, most importantly, what the recommended treatment course would be. On the other hand, Connecticut residents, like a wonderful married couple named Shannon and Megan, have been forced to pay out of pocket for multiple cycles of intrauterine insemination in order to meet the state's current definition of infertility, which is limited and heterosexist. Each IUI costs them about $2,000. This is an expensive, challenging road to just get to that starting line, which is not equitable. And for couples covered by Medicaid, currently it can be nearly impossible to access any fertility treatment. As you heard earlier, diagnostic care may be covered, but then they have no coverage for the care that's recommended for the diagnosis they have received. It breaks my heart when people like these who have no access to fertility coverage reach out to Resolve New England. They dearly want to become parents, but cannot afford to pay out of pocket to even try to conceive. These are examples of the inconsistencies that House Bill 6617 will help address. I know you have a packed hearing, so I have submitted written testimony and am available anytime for more information.
Thank you so much, Ms. LeBlanc, and perfect timing.
Oh, good. Thank you.
All right. Thank you. I don't see any questions. Have a great evening.
Thank you. You too.
And another person with perfect timing is Chris Herb. You're up next.
Can you tell my wife that? My name is Chris Herb. I'm the president of the Connecticut Energy Marketers Association. We represent 600 heating oil, propane vendors, many of whom participate in the Energy Assistance Program. We're in support of House Bill 6703. I submitted written testimony. I'll depart from it. We're here in support of this bill for two primary reasons. Number one, the program as it's constructed is discriminatory against family-owned businesses, and it is significantly out of date. I believe that the program started in 1981. In the 90s, a margin over rack program was instituted that at the time was keeping up with the needs of family-owned companies that were trying to serve their customers in their communities that are in need of this program. And then that has no longer kept up. What dealers are experiencing today are a couple of different things. They're experiencing extreme price volatility that has never been seen in history. I mean, we're talking about price swings that are happening that can be 30, 40, 50, 60 cents a gallon. And when you're experiencing that type of price volatility with a reduced margin that is not applicable in many other states where dealers are paid their full price, which means that they have no problems with keeping up with their ability to make deliveries to low-income energy assistance customers. That's something that we need to have addressed here. The other thing is, you heard from previous testimony, dealers are encountering midday price changes. I've never seen a midday price change where the price goes down, but is where they continuously go up. So if you already have had a price that was set by DSS and you get a midday price move or two of them, that's also another problem. The margin over rack is based on the New Haven rack average. That New Haven rack average no longer represents the price of fuel in Canton, in Groton, in Wethersfield, in the other dozens of terminals throughout the state. So if you were a marketer who is not picking up in New Haven, which is probably 70% of the state, then you are not getting the pricing that DSS is basing that on. So we made a change in the early 2000s to depart from the Journal of Commerce to move to the Oil Price Information Service because the Journal of Commerce was no longer functioning. Unfortunately, about 15 years later, the OPIS price that this is set on through the state plan is no longer keeping up, and that's why it needs to change. Again, other states pay full price. We're not asking for that. We're looking more towards something like a discount off of retail that's offered in Vermont and a couple of other states, New York. So we're looking to try to find the right pathway to serve your constituents in need, our customers. The reason why dealers are willing to take a loss on this program is because they care about the people in their communities. They see them at church, they see them at the grocery store, they see them at the baseball game. So we're not trying to be the bad guys. We're trying to find a way to continue to be good partners with DSS and the community action agencies. The model for 10-day payment, we appreciate the commissioner including the 10 days. We do agree with that. We can work with it, even though most dealers get either money EFT'd out of their account by their wholesaler on delivery when they pick up the fuel or within 5 days. The rest of it's in my testimony.
Thank you so much, Representative Cook.
Well, Chris, so since your timing was impeccable, do you have anything else that you would like to get out there?
Yeah, there's just a few other things. I use the word discriminatory and I don't use it lightly, but when you think about utilities, natural gas and electric utilities who are paid their full price for fuel, yet small family-owned businesses have to provide these deep discounts. And it's not only when you compare us to other people, other entities like the utilities and the energy assistance program, but even if you look at SNAP, right? SNAP doesn't require Stop and Shop, a Scandinavian-owned company, to discount the price of milk, but they're requiring a family-owned company to make that discount. And that's why we think things like putting into statute EFT payment, the option for EFT. I know the commissioner said we don't want to mandate that, but putting that option in would ensure the quickest movement of it. It's a President's Day weekend and that check just doesn't get there. And now wholesalers are cutting retailers off. So EFT shouldn't be a program option. It should be statutorily required to be administered. We think that the electronic submittal of delivery tickets, if they can email them in, should be part of statute. We shouldn't be having to batch them and put them in the mail. If a dealer wants to do that, that's fine, but it should be provided as an option. And then, like I said, we do agree. We asked for 5-day payment terms just because it's more consistent with the way that we pay our wholesalers. But DSS has taken a good step forward and offered that olive branch of 10 days. And I think that our industry can work within that. So thank you.
So thank you for that. And then I do have a question. So if we don't rectify this situation, and we know that we've seen people drop off of the participation in the program year after year after year for exactly all the reasons that you're saying, and then some, how many groups or how many delivery companies do you all represent at this point? Or do you know?
Yeah, in terms of participating in the program, yeah, I'm going to say 400. There are 600 in total. I know that DSS said that was ample, but we have seen an erosion. More and more high quality dealers are continuing to make those hard decisions, like the one you heard from Ives Brothers this earlier today. We don't want your constituents to fall down to the last of the remaining companies. You want them to have options, right? You want them to have choice. And unfortunately, the more erosion and as people drop out of the program, we're taking away choices of your constituents' of companies that they may have done business with for 30 years, and now it's no longer an option to do business with them because of the way the program.
And then the other question that I have for this, and this will be my second one, is, so we recognize that in the very outskirts, as opposed to the corridors, so my neck of the woods, further to the west, or very much to the east, the options are limited, and then it also takes time, right? So it's gonna take an hour and a half from the corridor to get from here to the west side of the state and vice versa to the east side of the state. That's not taken into consideration either, especially when we talk about delivery charges. Is there a proposal that you have to rectify that?
Well, I think that if we address those core issues, timeliness of payment, a more fair pricing system, getting away from the margin over rack opus pricing, I think it will address those things. I see dealers coming back that have been out for a number of years and ones that dropped out more recently if we can address those things. So I don't think we need something specific to address that.
Thank you, Representative. I have a question. Is there a dry zone in the state?
Not that I'm aware of. I know that our members have anecdotally, that are still in the program that have reported back to us saying that they do see themselves going further to try to pick up gaps where there would have been gaps, but I'm not going to say that everyone can get served today, but I'm not sure if that's going to be the same case next year or the year after that.
Yep. Thank you. Representative Case.
Thank you, Madam Chair. Chris, so I heard Rep. Cook ask the question. I just want to verify. So in the state of Connecticut, you cannot add delivery surcharges onto a petroleum delivery ticket. Is that correct?
That's correct. Delivery surcharges are prohibited by law. We have to, our industry is, since 1979 is required to do what's called unit pricing. All costs are rolled into the price of the fuel.
Correct. So everything you do, when the price goes up, price goes down, diesel goes up, all those costs are figured into the price of that day that you deliver. So when you deliver fuel for energy assistance, well, I lost my train of thought. Sorry. What is the timeline that when a company gets the call that they have to have the delivery out to the customer?
I believe that they have to deliver within 48 hours of that authorization, might be 72. And a lot of them right now, where before they would hop on the truck and they would get those deliveries made, now they're playing games where they're holding back to see if the price will correct in those next couple of days and running right up against it. So it's unfortunate. You know, I also know that the commissioner talked about that they already price regionally. They have not changed the regional pricing in years. So it was a little disingenuous to hear that DSS said, we already have a regional pricing system that accommodates for that 60-cent difference between Groton in New Haven or Wethersfield or Canton in New Haven. And so I just wanted to make sure that it was known that hasn't changed in a number of years.
Well, Chris, thank you. And when we mandate and we have in statute that it's 48 to 72 hours, we have that on the side of getting the person a delivery, but getting the company paid. We don't have anything of 48 to 72 hours to get a company paid.
Yeah, correct. I mean, it's again, we understand that the community action agencies, just like everyone else, is under a lot of pressure with finding labor in their finance departments and getting those checks out. So I do think that those terms are something that we could work with to help everybody. Again, we're all partners in this. All we're trying to do is make sure that our customers are served.
Well, thank you. And hopefully we can work on something for this year, because it's concerning, as I spoke earlier, you know, Operation Fuel has suspended for a month, and we're hoping this doesn't give a huge uptick of energy assistance, but they needed to catch up on some deliveries and some paperwork. Are you aware of that?
Yes, and obviously that's putting a lot of pressure, especially on customers that fall outside of the program. We're hoping that additional funding comes and they're able to reopen that part of the program.
And my last question, Madam Chair. So what is the difference between a propane delivery and an oil delivery as far as pricing?
So if you're delivering propane, you get paid your full ticketed price. You know, they're picking up fuel, they're putting it on their truck, they're delivering it to an energy assistance customer, and they get paid their full price. An oil dealer goes to their wholesaler, picks it up, and they're told by the state what the price is. Again, there's not equality in this program, and it's kind of funny that that would be the case. You would think that you wanted consumers to be treated equally under the same block grant program.
Thank you. And thanks for sticking it out, Chris.
I will just say, you said that you hope you get it addressed this year. So do we. I mean, it seems like we always get to August and everybody's scrambling, and then we just have to push something through because we need a program. This is the right and appropriate time to address it. So we ask for your help.
We hear you. Thank you so much for being here.
Thanks.
Next is Tammy Waranowitz. How did I do?
It's Wasanowitz.
All right, there we go. Go right ahead.
Hi, my name is Tammy Wasanowitz. I'm the operations manager for McGuire's Oil in Preston, Connecticut. We are a first generation oil company and are in our 6th year of operation. We service the New London County area. I'm here today in support of HB 6703 and that concerning the low income home energy assistance program. We've been a vendor for the energy assistance program since 2017. I would like to speak today regarding our experience with the program. With respect to payments, we are very fortunate that we deal with TVCCA as they cover the New London County area. Since we began participating in the program, we've always been paid by EFT, and it's always made within 5 to 7 days of dropping off our tickets. Even with that prompt payment, consider this. A delivery is made on a Monday. That ticket is dropped off the following Monday with a batch of tickets for that week. The payment will be received the following Monday. So 2 weeks after that delivery is made, the payment is in our account. At this point, this is the best case scenario as payments are made once a week by TVCCA. To be fair, we have not had a problem with this. I'm just giving you an idea of how payments work with TVCCA specifically. Now, it should be noted that the payment terms with our specific suppliers are net 10. I think that we must be fortunate in hearing some of the things that I've heard today. So after 10 days after we load the fuel, the supplier drafts the funds out of our account. Clearly, if payment is not made by TVCCA in a timely manner, it could cause a problem with payments to our suppliers and could even lead to our suppliers cutting off our access to fuel. With regards to DSS setting the price, the margin, in the past year, we have experienced unprecedented market volatility. In March and April of 2022, we were receiving midday price increases from our suppliers ranging from 30 to 60 cents a day. These midday price increases were not reflected in the daily rate that is posted by DSS. At times, the amount we were allowed to charge by DSS was less than what we could purchase the oil for, and which forced us to hold off on deliveries until DSS pricing would catch up, and even then it was substantially lower than where it should have been. Current DSS pricing is based on the New Haven rack average. The main terminal we use is located in Groton, which can be anywhere from 7 to 25 cents higher than New Haven pricing. The current county differential set up by DSS does not come close to filling this gap. At the beginning of this heating season, we had to really think about our participation in the program. It was not an easy decision to make due to the volatility. However, we did end up participating. The volatility still exists today. Just last week, we received 2 midday price increases on 2 separate days from inland suppliers, and that was on 2 separate days. In addition to the volatility, we're still dealing with increased operating costs, which include but are not limited to insurance, repairs, maintenance, payroll, the cost of diesel fuel. The 9.1 cent addition to the excise tax on diesel fuel in July did not help matters. Heating oil is the only product that DSS dictates the price that can be charged. Kerosene and propane are both at retail pricing. This is an outdated and unfair situation for oil vendors.
Your time has expired. Can you please summarize?
So in summary, this year we lost some vendors, 3 big vendors in the New London County area. My concern is that if something isn't done, that we are going to lose more vendors. We are a very small company and we have picked up a lot of customers this year, but there's only so much that we can do. So, and customers are upset to have to switch companies because they've been with these companies for a long time. So that's all I have. Thank you.
Thank you so much for being here tonight and for your testimony. Next, we'll hear from Bruce Stovall.
Good evening. Can everybody hear me?
Yes, we can. Go right ahead.
Thank you, Senator Lesser, Representative Gilchrist, Senator Seminara, and Representative Case, and the other members of the Human Services Committee. My name is Bruce Stovall, and I represent Oak Hill. Oak Hill was established in 1893 and currently is the largest private provider of disability services in Connecticut. We provide residential, educational, and recreational services to the IDD population. We employ approximately 1,700 people and operate over 100 sites. Many of these sites are located in your district, and please know you have a standing invitation to come visit the sites and see the nonprofits in action. I'm here to testify in support of, as you probably expect, HB 6612. Again, many of my colleagues have talked about the clawback provision, et cetera. You'll hear a little bit more about that piece from Oak Hill's perspective from our president, Barry Simon, in a little bit. In the interest of time, I want to jump down to our support of Section 4 of the bill, which would index the rates to the rate of inflation. Indexing rate levels to inflation would be a wonderful and constructive step in stabilizing the nonprofit system. Our recent ability to pass on a 3% salary increase to our staff was functionally wiped out by the current surge in inflation. Real wages essentially went down, making us even less competitive in the job market. Gasoline and utility prices have put additional pressure on us to keep the doors open. Oak Hill has a critical need to invest in its workforce. We currently cannot adequately staff a number of our programs. We currently have temporarily vacated 2 of our group homes based on safety issues and do not have the ability to fill over 35 vacancies throughout our agency. These beds could certainly be useful in addressing the waiting list for services. We struggle with recruiting and retention based on inadequate funding over the years. Currently, we have over 175 vacancies of our 800 direct care positions. Oak Hill and our colleague agencies could be so much more efficient and planful with our funding indexed to inflation. It simply makes sense and it's the fair thing to do if the state truly wants to partner with the nonprofits. We save the state considerable funding in providing these services as opposed to the state option. Now is the time to act. I appreciate your time tonight and your dedication and happy to take any questions.
Thank you, Mr. Stovall. Senator Seminara.
Thank you, Madam Chair, and thank you, Mr. Stovall, for your testimony. Could you please repeat again the vacancies that you have available?
I spoke to our direct care force, which is slightly over 800 direct care workers. We're currently approximately have 175 vacancies. We fill that gap with currently 4 different temp staffing agencies, which again is a highly expensive option with hit or miss quality. So again, indexing to inflation would really be a great idea.
So are you able to fill that 175 gap with, are you able to fully fill it?
Not at this point. Again, I've been with Oak Hill for 34 years. I do not think I've ever seen our staffing situation and our colleague agencies in this situation. We're competing against Targets. We're competing against restaurants. You would start at $17.25 an hour. Again, that's with the recent increases. That's up from $15.65, I believe, a couple of years ago. So again, this is a major problem where we're not able to safely take referrals now. We're not able to safely operate all our group homes right now. This also reflects on our residential side, where we serve about 120 students, and I believe our census is down about 20 students there for the same staffing issues.
Okay, thank you so much for that information. And just a little shout out to you. Oak Hill has always been a great provider of service. I've always admired everything you've done, and I'm so sorry to hear that you can't fill your vacancies. More sorry for the people that need the service and you being unfortunately unable to provide it. But thank you so much for your testimony tonight, and hopefully we can do something to help the situation.
Thank you very much.
Thank you, Senator. Thank you, Mr. Stovall. Have a great evening. Next, we'll hear from Siobhan Horan.
Hello, thank you very much to the senators and representatives on the committee. There really is nothing that I can add than maybe to highlight the same concerns that everyone prior has spoken regarding HB 6612. I've been in the field for just about 40 years, and I have also never seen a staffing crisis so challenging. I could spend your time telling you 40 years worth of stories about wonderful, dedicated staff and the low turnover rate that CLASP has been able to maintain for all of these years because we've been able to support our staff. But it is becoming more and more challenging. And when people leave, we're not able to fill the vacancies. The COLA, the cost of living increase tied to inflation would be a big help, considering the issues of compression when we are given increases would also be very useful, and just continuing to work on the historic underfunding and give us the opportunity to pay a living wage to our staff. It means everything. Thank you for the time, and I will yield the rest of my time to my colleagues.
Thank you so much, Ms. Horan. Thank you for being here tonight and for sharing your testimony. Next, we'll hear from Jose Rivera, followed by Stephen Lyon.
Hello, Madam Chair. I just would like to go on record saying that I'm here to speak about the SB 991, but I also would like to voice my opposition on HB 6618. I speak as the sitting chair, vice president for ABC Women's Center here in Middletown, Connecticut, also known as the A Better Choice Women's Center. I agree with everyone that spoke before me on opposition of this bill. And I would like to go on record on that, but I would also like to read my submitted testimony for SB 991. Dear Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Jose Rivera, and I live in the town of New Britain, Connecticut. I stand in support of SB 991 and Act concerning medical reimbursement of community health workers. I am a case manager who provides community health work at Ministerial Health Fellowship, which our mission is to service the BIPOC and Latinx communities within the state of Connecticut, connecting them to resources unknown to them, but also advocating for said population in matters such as this one. Currently, Connecticut's Medicaid program does not reimburse community health worker services or incentivize healthcare providers to work with CHWs. Community health workers are an effective way to address inequities and promote health, particularly for low-income households served by Medicaid. This is an important matter to me because the people I encounter every week out in the field are in need. They need us to be their voices who advocate for them. They need us to be their navigators in making appointments, etc. Our people are kept in the dark from many programs available to them. And the only way they find out about them most of the time is through a CHW. In doing this work, I keep this quote close to my heart, written by Dr. Martin Luther King Jr. Make a career of humanity, commit yourself to the noble struggle for equal rights. You will make a better person of yourself, a greater nation of your country, and a finer world to live in. Let us make the right decision here for the betterment of our communities and in turn, our nation. Medicaid reimbursement for community health workers should center community and CHW voices in all stages of design and implementation. Reimbursement at rates high enough to employ CHWs at a livable wage and to cover the cost of supervision, billing, and routine training. Cover a comprehensive list of CHW services. I would like to thank you for the opportunity to testify in support of SB 991, an act concerning Medicaid reimbursement for community health workers. Thank you.
Thank you, Mr. Rivera. I don't see any hands. Thank you for your testimony and your time. Next is Stephen Lyon.
Good afternoon or evening, whichever it is.
Thank you, Senator Lesser, Representative Gilchrist, and honored members of the Human Services Committee for accepting my testimony. My name is Stephen Lyon from Willimantic, Connecticut, and I'm providing testimony in opposition to House Bill 6618, an act concerning medical assistance for certain persons receiving abortion care and related services in Connecticut, because the legislature should not allocate funds to be expended on behalf of those outside of Connecticut at the expenses of the taxpayer in Connecticut. Connecticut does not have a revenue problem, it has a spending problem. From raising taxes to proposals for tolls on state roads, the legislature seems to be constantly trying to figure out ways to increase our revenue. However, instead of trying to find ways to trim expenditures, proposals like this get made, which would result in an additional $2 million being added to this year's budget. This would be an issue even if we were just talking about funding procedures for Connecticut residents, but this proposed expenditure doesn't even benefit the individuals who are paying for it. There are so many unaddressed issues to handle in Connecticut. It is inexcusable to be pouring our limited resources into other states. To use an analogy, passengers on airplanes are always told to make sure that their own masks are on securely before providing aid to their children or other passengers who are struggling to put on a mask. We cannot truly help others until we have taken care of our own issues here. On a more technical note, this proposed legislation is irresponsibly drafted based on vagueness in the language. The term, quote, and related services, unquote, is used throughout the bill, but is undefined. If Connecticut taxpayers are going to be forced to pay for something related to abortion for individuals from other states, they should at least know what they're paying for. What is actually covered? Are airfare, hotels, and prepared food covered? Technically, these are all, quote, related services, unquote. And while it may not be the intent of the legislation, how are we to know? If this committee and the legislature as a whole wants to pass something this controversial, there's a responsibility to be clear about what is actually being proposed. Additionally, there's one section of this legislation which is misleading at best and dishonest at worst. Under section (4)(b) at line 25, the raised bill states, quote, the commissioner shall apply for a waiver under section 1115 of the Social Security Act and any other federal approval required to secure federal financial reimbursement for the cost of such care and services, unquote. For those who are unaware, federal funding of abortion is prohibited by law due to the Hyde Amendment. With this being the case, there can be and will be no reimbursement for expenditures for, quote, abortion care and related services, unquote. The taxpayers of Connecticut will be footing any such bills in their entirety. There are several other issues with the proposal, including the eligibility verification, income eligibility limit, and other ethical and moral concerns, but others have and will address those issues eloquently, and I join with most of their concerns. So for the reasons I have stated, I oppose HB 6618 and request that you vote no on any such proposal now or in the future. And I join with the majority of written testimony, which, to say conservatively, trounces any written testimony that has been submitted in support of this bill. Thank you so much for your time.
Thank you, Mr. Lyon. Representative Master Francesco.
Thank you, Madam Chair. Thank you, Stephen, for your testimony, for hanging in there through the day. I know it's been a long day for everyone. I just had a couple of quick questions. I don't know if you can clarify it for me through your profession as an attorney. I see here. There was a little discussion today around, the concern is we have the child sex trafficking, right? And it does happen in every state. And there was a concern that children from other states coming into Connecticut to get abortion services, that we didn't have any data to show that that is happening. And I was just wondering if you, in your professional practice, have experienced anything that people trying to get information, because from what I understand, the state does not have any oversight for Planned Parenthood or anybody to actually report that. In my opinion, we should be asking the age, are you here under duress, and so forth. And it appears that we don't have that. So of course, there is no data available, because if they're not keeping track of it, right, there's no data. I was just curious, in your professional opinion, if you've ever ran into someone trying to get some information, maybe through Freedom of Information, to get that data and have not been able to get that information. Would you have any experience with that?
I don't have any personal experience with that. However, it is my understanding, similar to yours, that we do not track such information, so it is not available if it were to be pursued.
Right, that's what my understanding is. I was just curious. Thank you very much. I don't have any further questions, but thank you so much for your testimony today.
Well, thank you.
Thank you, Representative. Next, we'll move on to Carolyn Bennett.
Members of the Human Services Committee, my name is Carolyn Bennett, and I am testifying in strong opposition to HB 6618, which would pay for abortions for out-of-state residents who cannot afford to pay themselves. I don't believe it is right to spend state resources to benefit non-state residents, but I believe even more strongly that before agreeing to this, it is important for the committee to understand exactly what our state would be spending money on. You must understand what abortion actually is. I'd like to give you a brief explanation of the second trimester D&E abortion procedure, which is legal in Connecticut. This is an unembellished medical description presented in a video I watched by an OBGYN who performed over 1,200 abortions. I recommend that all committee members watch the entire video, which is linked in my submitted testimony. As explained in the video, a D&E is usually performed between 13 and 24 weeks in the pregnancy. In the procedure, the abortionist uses an instrument to grasp and pull the developing baby's arms and legs, tearing the limbs from the child's body. He continues to grasp and tear out intestines, spine, heart, and lungs, finally crushing the baby's skull and removing the pieces. The abortionist then collects all of the baby's parts and reassembles them to make sure that all the pieces are there, and then the abortion is complete. Please understand that when you talk about abortion, this is what it is: the violent taking of an innocent, helpless human life. To quote Carrie Gordon Earl, a woman who had an abortion as a teenager, "The world is not a better place because of abortion. It's created a world where you're almost expected to abort if you're pregnant at an inopportune time. And it's created a society in which it's easier to push women to have an abortion rather than accommodate them and their needs as mothers. Abortion feels like your only choice if you want to keep your place in school or the workforce. That's not empowerment for women. That's bondage. Please oppose HB 6618. Thank you.
Thank you, Ms. Bennett, for your testimony and your time. Next, we're going to Emily Morrison.
Hello, thank you to members of the Human Services Committee for taking time to hear from us tonight. My name is Emily Morrison. I'm the Director of Development at United Services, and I'm a Putnam resident. I'm speaking tonight in support of HB 6612. United Services is a community behavioral health center, a nonprofit provider, providing more than 30 programs to residents of Northeastern Connecticut living in 21 towns. We provide outpatient mental health, outpatient substance abuse treatment, including medication-assisted treatment, as well as an array of other wraparound supportive programs, parenting programs, youth services, youth service bureau, juvenile review board, parenting programs, crisis services, and the region's only domestic violence program. We operate outpatient clinics in Dayville and Mansfield Center. In the last 2 years, we've experienced a 45% increase in children seeking mental health services through our child guidance clinic, a 22% increase in adults receiving outpatient mental health services, and a 24% increase in substance use and medication-assisted treatment programs at our programs. Quite frankly, we are struggling every day to keep up with the demand of individuals reaching out for help in the wake of the COVID pandemic. We are grateful to the state for the cost of living adjustment that us and many other nonprofit providers received in the last 2 years. But to be frank, so many years without a COLA has left us still far behind. We support HB 6612 as it will index the rates the state pays for nonprofit services to inflation, providing an automatic increase when inflation increases. We struggle to recruit and to retain professionals because our state contracts, quite frankly, don't pay the cost that we need to keep people, recruit talented staff and keep them working for us. And when we continue to battle against inflation, that battle is even harder. The same with Medicaid rates. When they don't keep up with inflation, we can't keep up with our costs. We are grateful to the support the state has given us in the last 2 years and plead to continue that support to nonprofits who are providing critical services to residents across Connecticut, including United Services. Thanks so much.
Thank you so much, Ms. Morrison, for being here and for your testimony. Next, we'll hear from Susan Beck.
Thank you, Madam Chair and members of the committee. I live in Milford, and I would like to speak today in opposition to House Bill 6618. The ability to coexist amicably and respectfully with those who hold beliefs that differ from our own is essential to the flourishing of a democracy. But sadly, I think this ability is in very short supply today. The issue of abortion, as you all know, is one of the most divisive in our society. A crucial element in maintaining civility around this issue in Connecticut, where abortion is legal, is respecting the rights of conscience of those who are opposed to abortion. This means that while all those who desire the procedure have legal access to it, those who find abortion antithetical to their system of belief should not ever have to be complicit in it. If House Bill 6618 were to become law in this state, the tax dollars of all citizens would be used to fund abortions, making those who oppose abortion complicit in that act against their will and in opposition to their conscience. Passage of the bill would thus demonstrate disregard for the rights of conscience of all citizens who don't believe in abortion. But worse than that, House Bill 6618 would make abortion the first and only medical procedure for which our state's government would fund travel for people unable to obtain it in their home state. Connecticut does not pay for people to come to Smilow Cancer Hospital to get a cancer treatment they can't get where they currently live, or pay for families to bring a child with a heart malformation to Connecticut Children's for a surgical procedure not available in their home state. So to single out abortion as the one procedure that the government will help out-of-staters obtain here would do more than just ride roughshod over conscience rights. It would communicate a level of disrespect and antagonism toward those suffering, those of different views, that would really seriously heighten the level of uncivil discourse in our state. Now, cancer patients who need financial assistance to travel to and pay for treatments regularly turn to the nonprofit community for this kind of help. And there actually are a number of nonprofits that provide financial assistance to women who cannot obtain an abortion where they live and who want to travel to another state for one. So if Connecticut citizens who support abortion feel strongly that underprivileged women who must travel for an abortion deserve help, I suggest that they donate to one of these organizations. Such a non-governmental approach would accomplish the purpose of House Bill 6618, but without forcing any Connecticut citizen to go against his or her conscience more than they already do, and without furthering the uncivil, rancorous atmosphere in our politics and among our citizens generally. So please, let's respect all of our citizens' rights of conscience and not pass this bill. Thank you.
Thank you, Ms. Beck. Senator Seminara.
Thank you, Ms. Beck. I just wanted to thank you so much for your testimony this evening and hanging in there with us and acknowledging that there are differing views here in the state of Connecticut and acknowledging that we should respect everybody's view. Thank you so much.
Oh, you're very welcome. Thank you.
Thank you for your testimony and your time. Have a great evening. Next, we'll hear from Cassandra Creface.
Good evening, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Cassie Kerfasi. I'm a resident of New Haven, Connecticut, and I'm an MD-MPH student pursuing my public health degree at Yale School of Public Health. I'm testifying today in support of Raise House Bill 6617, an act promoting equity and coverage of fertility care. This bill addresses a critical public health need by eliminating barriers to fertility care and ensuring that all Connecticut residents have equitable access to the reproductive health care they need to build their families. One of the reasons I decided to pursue a medical degree is the incredible magic of medicine. In my career, I've borne witness to the effects of life-changing medications and life-saving surgeries. From the development of vaccines that we use to teach our immune system about pathogens that we may encounter before we've been infected, to the development of therapies that support our autonomy in determining when and how we start our families and the number and spacing of our children, I've been able to learn about how far we've come as a species in our understanding and command of the human body. One of the reasons that I decided to pursue a master's in public health is because I've also seen that medicine's magic and power is not accessible to all of us. As the state has previously recognized, fertility care is healthcare. The law as written requires only private insurance providers cover fertility treatment and only for people who meet a limited definition of infertility. These restrictions and whom they exclude make a statement about who the state believes ought to be able to reproduce. I support HB 6617 because I fundamentally believe in the right to reproductive autonomy or the power to make and act on decisions of reproduction. I believe that we all ought to benefit from the understanding and command that we have gained of reproductive physiology, as it did not come without cost. The practices of obstetrics and gynecology in the United States were built on an abusive and inhumane experimentation on enslaved Black women. The foundations of sterilization and fertility procedures are tied to Nazi pseudo-medical experiments, and our understanding of oral contraception, as well as the role of HPV and cervical cancer, can be traced on unethical, uninformed, and unconsensual human subjects trials. We cannot undo the atrocities or injustices that inform our medical knowledge, but we can pay homage to Anarcha, Betsy, Lucy, Henrietta Lacks, and the countless lives that have been compromised in its pursuit by ensuring that all are able to benefit from it and the treatments and therapies it resulted in, no matter how they're insured or with whom they choose to start a family. For far too long, we've allowed poor people, disabled people, queer people, and people of color to run into barriers when they try to exercise their reproductive autonomy. Connecticut is a national leader in protecting reproductive rights and keeping LGBTQ+ families secure, and it's time for our laws on fertility care to catch up. Thank you for your time and consideration of this important bill.
Thank you so much, Ms. Kerface. Did I get that one that time? I think I did. Thank you so much for your testimony and for being here tonight. Next, we're going to hear from Barry Simon.
Thank you very much. So good afternoon. Thank you for hanging in. I am Barry Simon. I'm the president and CEO at Oak Hill. As you are aware, we're the largest purchase of service provider in the state. We normally employ 1,700 employees, currently 1,500 with current vacancies. I am here to tell you it is really hard to do business with the state of Connecticut. We are funded by DDS, DSS, DMIS, DCF, Department of Education, and other state agencies. Medicare and Medicaid, long-term services and supports are our primary specialty. Thank you for the opportunity to testify in support of HB 6612, allowing nonprofits to retain savings and reinvest them in provision of services, as well as indexing the rates that were paid with inflation. As it stands now, we actually subsidize the state by approximately $5.5 million due to the historic underfunding, while we want to maintain paying our employees good wages, reasonable benefits, and the ability to retire. If the state paid for services, however, for reasonable rates for our services, however, being able to retain any earnings would be wonderful. I am also here to testify in support of Section 4, which indexes our rates. The increase that we received last year, while we very much appreciate it, does not cover the rising cost of doing business, nor the increases needed to attract and keep professional staff. We have RNs, OTs, PTs, behaviorists, teachers, social workers, group home managers. Many positions needed 15 to 20% increases just to stay at the low end of market rates, yet for whom we received 0 to 3% increases over the last 2 years. Indexing our rates to inflation would allow us to run our agencies and pay our staff with a lot more certainty. We deliver the state's core services, yet we're forced to operate on repeated historic underfunding, while the state sits on massive surpluses derived in part from our services and the rates that the state was paid for our services. 17 years of no increases for administrative and general costs such as gas, oil, electricity, business insurance, human resources, malpractice insurance, facilities maintenance, electronic health records has continued to exacerbate our challenges to run our agency. The last time we received anything more than wage pass-throughs, gas was $1.67 a gallon. The governor's budget proposes 2 years of 0 increases to our rates. How is this just, equitable, or inclusive for our employees or the people we serve? Remember, we are not able to raise taxes or raise our rates to cover costs. We are rate takers. You set the rates. Our staff, homes, and equipment are tired. Would you expect hospitals to give inadequate raises to staff and ask them to do procedures on 17-year-old equipment? Would you want to go to that hospital? The ability to avoid strikes, another issue for us. The reality of equity, equality, and change is in your hands. In the political process, you often ask us for our votes. In the budget process, we're asking you for your vote. To make equality and inclusion for our staff and clients an imperative. I implore you to see us not as beggars, but as a wise investment in state resources into the local economies of 169 towns that will lift our employees, lift our businesses, lift the services that we provide. You hold the power, please use it justly. Thank you again for the opportunity to provide my perspective and to testify in support of this important bill. Please support HB 6612. I'm happy to answer any questions and provide additional information.
Thank you so much, Mr. Simon, for sharing your perspective and this great information. Thank you for all you do. Have a great evening.
Thanks.
Next, we'll hear from Christina Emery, followed by Kathy Hamilton, who I called on earlier. My apologies. Christina?
Good evening, Senator Lesser, Representative Gilchrist, Senator Seminaria, Representative Case, Representative Cook, and distinguished members of the Human Services Committee. My name is Christina Emery, Executive Director of Primetime House. I hope you can hear me okay. I'm having some technical issues when I turn on my camera. One of the challenges in the state of this part of the state working remotely. But I do want to thank you for the opportunity to testify and for your service to the most vulnerable of our friends and neighbors, especially those with a serious mental illness that we support at Primetime House in Torrington. At our Demas-funded Clubhouse program, 1 year of holistic recovery service is provided to participants for the same cost as a 2-week psychiatric hospital stay. Our members can connect with a community of peers, achieve independence, and realize personal growth. Like many before me today, I am here to provide testimony in support of House Bill 6612. Despite the legislators' clear intent to end the practice of clawing back unspent funds, this policy has not been implemented in a way that's helpful to our nonprofits. While my agency did not realize a surplus this past year, we have been forced to return thousands of dollars in prior years, largely due to staff turnover. In our case, having the ability to keep a surplus will allow us to offset losses in other programs that are chronically underfunded and make much needed investments in our staff to help with training and retention. It will also help us to create savings towards capital improvements to improve efficiency, ensure our buildings are renovated for safety and accessibility, and replace aging vans, which are necessary due to the lack of public transit available in Litchfield County. Despite support from this community, the innovative incentive program has not been implemented in the way the legislator intended it. I am also strongly in support of Section 4 of the bill, which would index the rates the state pays for contracted nonprofit health and human services to inflation. Like all businesses and households, we are dealing with increased costs of insurance, fuel, utilities, transportation, and food items, which are essential to fighting food insecurity among our members. At the same time, we desperately need to increase wages we pay to our dedicated staff who are dealing with inflation themselves and deserve a living wage in exchange for the life-saving work they provide daily. Thank you for the opportunity to testify in support of HB 6612 and for your support of Connecticut nonprofits working to provide essential services.
Thank you so much, Ms. Emery. Representative Case.
Thank you, Madam Chair, and thank you, Christina, for coming forward. You have a model program out there, or here in Torrington, I should say, and the Demas Commissioner has been out there and noted the program, and just so people realize how many facilities or houses do you call it that you have on the campus?
We own a 4-building campus, and they are aging buildings. We've done a lot of capital improvements with fundraising dollars, with grant dollars, and unfortunately, we have been unable to retain surplus funds in years past to make some of those improvements.
And I appreciate all your efforts because you guys do a lot of fundraising and, you know, a lot of unique things around the holidays, and that's to help with offset some of the costs with that. You're correct, with an aging facility. How many people are in the clubhouse? I'll wrap it up, Madam Chair. Hold on.
Sure. We support over the course of the year close to 180 unique individuals in our clubhouse program. On any given day, that number can vary anywhere between 25 to 40 people on a daily basis.
So I thank you for all your efforts, and you hit it on the head too, because you are one agency that has, I believe, 4 or 5 vans plus the bus that help with transportation around the northwest corner, because your agency and your clubhouse basically covers 900 square miles in the northwest corner. So thank you for all you do, and we'll hope we can get this clawback fixed and get things going. But thanks for hanging in here, Christina.
Thank you.
Thank you, Representative Case. Thank you, Ms. Emery. Have a wonderful evening. Next, we'll hear from Kathy Hamilton, followed by Alyssa Balika.
Good evening. My name is Kathy Hamilton, and I'm the president and CEO of the Home Medical Equipment and Services Association of New England. We've been in existence for 35 years, serving all 6 states. We have DME providers throughout Connecticut. Here today, speaking in opposition of HB 6702. We've heard a lot of testimony about that today. Not the least of which has been the proposal to maybe rewrite this in a more favorable manner. In my written testimony, I'd actually included information, as had many, about trying to put together a work group to work on something that was more realistic and would achieve the desired goals that everybody has to get more timely repair of these wheelchairs. We recognize that there have been issues with repairs. One thing that hasn't necessarily been mentioned today is that these issues with repair have been exacerbated by consolidation, which you heard about, but also by the impacts of the public health emergency, the pandemic, particularly with supply chain, getting product timely, those sort of issues, and cost increases. Not only have the raw material costs, the parts for these chairs gone up significantly, but the freight in getting these expedited has also increased considerably. So those are things that we need to consider as we work toward a viable solution in this bill. We've also had the same components of labor challenges that other people have had. And I think you heard that earlier today when you heard from Tony from Agawam in terms of, the difficulties with the wages and the ability to find trained personnel. Those are some of the basic issues, but there's other issues that I'd be remiss not to mention. When we're first looking at right to repair, what has been left out and hasn't been considered is the fact that these wheelchairs are Class 2 medical devices. So they're regulated by the FDA. Everything that's done on those has to be documented and be available in case of recalls. And during this pandemic, we've seen recalls in a lot of products, from CPAPs to infant formula. So it's very real being able to know what's there, the serial number of that part in the event of a recall. So all those things are very important. But we want to be part of the solution.
Ms. Hamilton, your time has expired. Can you please summarize?
Sure. We want to be part of the solution. We would like to work with everybody and have the opportunity to solve the problems that exist. Thank you.
Thank you, Ms. Hamilton. Representative Case.
Thank you, Madam Chair, and thank you, Mrs. Hamilton. I appreciate you coming. I did speak earlier on this. I appreciate your view on this and having a group so that we could work together and your willingness to work. It's something that really can't wait because when you have a down chair, you want to get it fixed. I see the willingness of the industry wanting to go forward and help work through this problem. I can understand in every industry there's been holdups of product and getting things on the supply chain and things like that. But I think that we're getting a working group together so that we can actually sit down and see how we can expedite and get things done. I didn't realize they were a class 2 medical device, so therefore it does make a difference as far as the warranty stuff and when there are recalls, because if you do have stuff work done to it, it's not done by a certified, that recall might not be able to be replaced if it's done outside prior. So I get it. I hope we do some more work on this bill. And I just really wanted to say I appreciate you and the industry wanting to work together, because I wasn't hearing that earlier. But that's the way we can get a solution and get these people who have these chairs fixed in a reasonable time. And I think statute, as an industry person, that is your responsibility and the solution we need to come up with.
And that is what we're looking to do. We really have embraced this issue throughout this year. It's been huge throughout last year. It's been a huge topic of conversation. You know, you heard earlier about some of the inabilities of some providers to get parts to people timely, to do the repairs timely. This has been a problem we've been addressing for quite a while. You know, but there's potentially, you know, several 20,000 or I'm sorry, 2,000 different SKU numbers of parts from different manufacturers that go into this.
How many
And
providers and suppliers are there in the state of Connecticut? for these chairs?
so I don't necessarily have all of them as members, but we have the two big ones as members, New Motion and National Seating and Mobility that you've heard about. Agawam, that you heard from earlier today as well, is a local provider that does significant work in both Massachusetts and Connecticut. There's a couple of others that are doing a little bit more limited work, not quite as high end as some of the other chairs are, but that there's a shrink that's going on. And part of that, in all honesty, has been related to the reimbursements. I don't know if you're familiar with DME reimbursement, but right now the DME rates have been in place by and large since 2018. We just were able to meet with Medicaid for the first time in several years, just a couple of weeks ago. And I've spent the last couple of weeks putting together documentation that they were looking for to address some of the reimbursements, wanting rate comparisons with all of New England and New York, line, code by code.
But the bottom line, Ms. Hamilton, and I'll wrap it up because it's getting late. The bottom line is you're in the industry, and what I'm hearing is you want to help be part of the solution and
want to be
help
part
these
of the
people so
solution. Absolutely.
they can be the ones to stay in their chair and have it when they need it and get it repaired when they need it. And that's encouraging to
Absolutely.
hear. So I thank you very much for coming and staying tonight.
Thank you.
Thank you, Representative Case. Thank you, Ms. Hamilton. Next is Alyssa Balika.
Hi, good evening, everyone. My name is Elisa Balika, and I'm the owner of Price Right Oil, LLC. We're based out of Watertown, Connecticut. We serve probably about 80% of Connecticut, and we've been in business for 9.5 years. What I'm here to talk about today is the HB 6703, the act concerning the Low Income Home Energy Assistance Program. We've been working with them for about 9 years now, and the first couple of years were pretty good, but these last few years, I would have to probably say the last 5 years have been a struggle, especially now. The main thing that I would like to touch upon is the way we get paid. So with the market being the way that it is, the volatility of the prices, it's very hard for small businesses as myself to really stay in business because, we have a huge overhead. We have diesel costs, wear and tear on our oil trucks because our oil trucks run at least a good 16, 17 hours a day. We have employee costs, insurance costs. So the price that we are getting right now for for the profit margin is not enough to sit here and take care of everything that we have to take care of. I myself was not planning on coming back to energy assistance next year, especially because of everything that is going on. Also, the fact that the way we get paid is absolutely outrageous. As of right now, I'm probably close to maybe $100K with the state of Connecticut owning me the money through energy assistance. I definitely support the EFT electronic payments. Probably maybe one energy assistance program that I deal with out in the New Haven area does it. Everybody else decides to not do it. And we have to constantly sit there and call for our money, which we shouldn't have to. We have to put our own money on the line so that we can go ahead and deliver, to customers. And I don't think that that's honestly fair, because then that cuts our costs on things that we can do. As of right now, I probably don't see checks for about 3 weeks to a month, and they're technically supposed to be every 2 weeks from what I'm hearing. When I do get a check, it's barely for nothing, and I hear that it's because the state of Connecticut is not giving the money on time for these energy assistance programs to pay us, and it's the same thing over and over again. As of right now, my clientele and customers through the energy assistance program has probably grew about 50% for all the other vendors that have not decided to participate this year. So it is very hard dealing with the situations that we deal with. I deliver to Litchfield County, Hartford County, New Haven County, the Fairfield County.
Lisa, your time has expired. Can you please summarize?
Yeah, so I'm in support with hopefully getting a change on us being able to get our money quicker and, a bigger percentage in our profit margins, because as of right now, it's not doing anything.
Thank you so much, Ms. Belika. So appreciate you being here, and we do hear you. Senator Seminara?
Yes, thank you, Madam Chair, and thank you, Ms. Belika, for your testimony. We hear you loud and clear of the difficulties, and we are hopeful that thank you for hanging in there this season, and we're hopeful that we are able to make some noticeable change, that you will continue to be a provider to the LIHEAP program, because as you well know, the people that you provide services for are desperate for it, and if we keep losing providers, we're going to have a huge problem. So I just wanted to thank you, and thank you so much for hanging in there this season, and I'm hoping we can count on you next time too.
I hope so too. I hope that things change and then I can be, of assistance.
Thank you. Thank you so much.
Thank you, Senator. Thank you, Ms. Belika. Have a wonderful evening. Next, we have Swan Hui Wong, followed by Susan Zabahansky.
Hello, everyone. Good evening. Thank you for the opportunity today. My name is Shen Hui, and I'm a teacher at a public school. I want to say that I'm against the Bill HB 6618, that the taxpayer pays money for out-of-state women seeking abortion in Connecticut, because I don't think Connecticut residents should be forced to pay money for out-of-state people. It is not okay for me, since every single person in Connecticut is already in debt for more than $60,000 in long-term obligation, and because of the decade of government mismanagement. Besides special cases, why should we have to pay people who want to get abortion, especially when they are not even from this state? I don't think politicians should use this kind of topic to manipulate people. The bill makes me feel the government only protects certain type of people like me, who do not fit into any special category, are being taken advantage of. my rights and my opinions are being ignored, but I'm still forced to pay taxes that I disagree with. Thank you for listening, and thank you for your time.
Thank you, Ms. Wong, for your testimony and your time tonight. Next, we'll hear from Susan Zabahansky.
Members of the Human Service Committee, thank you for your time today. One thing we've heard all day today, and we could all agree on, is that the cost of living in Connecticut has skyrocketed. Even in this committee, we had people testify and speak about those in our state struggling to maintain 501c3 nonprofit revenue, purchase diapers, funding Medicare patients in nursing homes. Yet the majority in this body continues to propose legislation that benefits out-of-state people and illegal immigrants who are not contributing to the tax base. I'm here today to oppose one such piece of legislation, HB 6618, which proposes to allocate $2 million to pay for an elective procedure for an out-of-state resident. The vast majority pushing this legislation have been representatives of Planned Parenthood, as I sat here today. This organization claims to be one whose purpose is women's health care. No matter where you stand on the abortion issue, I'd like to make it clear that Planned Parenthood is anything but health care or reproductive care, as some have called it. I personally had a situation in my lifetime where my insurance did not cover pregnancy, and I thought I could go to Planned Parenthood to seek out some medical care. I was shocked to find out that I couldn't even get a basic ultrasound unless my purpose was to abort my child. As a single only parent to my daughter, that was very shocking to me. And it caused me to have to take responsibility for my actions. No one is forcing women to have children. The woman has a choice, as does the man, before they get into those situations. No matter where you stand on abortion, I think it's unnecessary for taxpayers to fund someone else's decisions for a procedure that for 98% of women is elective. And I thank you for your time.
Thank you for your testimony and your time, Ms. Zabahansky. Have a wonderful evening. Next up is TJ Clark.
Good evening to the chairs, Representative Gilchrist, Senator Lesser, and members of the Connecticut General Assembly, Human Services Committee. My name is TJ Clark, Executive Director of the Connecticut Oral Health Initiative. Our mission is to strengthen and safeguard access to quality, affordable oral health services for all Connecticut residents. We desire that all Connecticut residents will have equal opportunity to obtain services needed to maintain good oral health. COHI, as we're called, is the only statewide organization that solely advocates for equitable oral health policies. And tonight we are asking you to support House Bill 6616, which would extend access to Husky Health to all income eligible Connecticut residents under the age of 26, no matter their immigration status. Making sure that all residents can access healthcare makes sense from an economic and health perspective. That's why other bills in previous years to expand Husky to immigrants has sustainable public support. The past 2 years, this committee held public hearings for the reference bills that have resulted in over 300 testimonies in support of each bill. This is not a controversial issue for voters. Not acting on this issue would be a choice to look the other way and ignore the sizable support that exists for ensuring immigrants have access to healthcare. We also need to remember that undocumented immigrants in Connecticut alone pay roughly $145 million into the state and local taxes every year. These taxes fund Connecticut's Husky program, as you're aware. Yet, despite their contributions, many immigrant communities cannot access health coverage due to Husky's limiting eligibility rates for immigrants. In closing tonight, we urge the Human Services Committee to support House Bill 6616 and equalize health access for all of Connecticut's residents. We believe our great state can have a future that includes healthy families and a stable, thriving, growing workforce that is ready to meet the needs of its present and future residents. Yours in service.
Thank you so much for being here. Have a great night.
Thank you. I appreciate the time.
Next, we're going to hear from Nicole Paquette.
Good evening, Representative Gilchrist, Senator Lesser, Senator Seminara, Representative Case, Senator Gaston, Representative Dathan, and the distinguished members of the Human Services Committee. My name is Nicole Paquette. I am a licensed funeral director, embalmer, and the legislative chair of the Connecticut Funeral Directors Association, CFDA. We are one of the oldest and nationally recognized associations with over 220 member funeral homes. Thank you for raising House Bill 6701, an act concerning funeral assistance for persons of limited income. CFDA submits this testimony in support of this important bill that will provide a modest increase of $450 towards the allowance for funeral and burial expenses upon the death of a beneficiary under the state supplement or the temporary family assistance program. $450 would restore the allowance to $1,800, which for many years, from 2006 to 2015, was the allowance paid for funeral assistance. State budget cuts have unfortunately eroded the original $1,800 allowance to the present day allowance of $1,350. Those budget cuts and reductions have consequently negatively impacted funeral homes' decisions to accept the care and responsibility of persons of limited income upon their death. In some cases, affecting hospitals, healthcare centers, and police departments who are charged with finding a funeral home to release the remains to. Regarding costs to provide a simple cremation, and I believe you should have this handout with the testimony, third parties or cash advance items and funeral home expenses combined to total approximately $4,692. Less the proposed state allowance of $1,800 produces a negative estimated balance to a funeral home of approximately $2,892 per person. Not all deceased persons have relatives or friends that come forward or that can contribute funds to provide for the shortfall. In some situations, the decedent is unfortunately abandoned, estranged, or leaves no next of kin, and the allowance from the state is the only amount that a funeral home will receive. Restoring the allowance to $1,800 helps increase the likelihood of a funeral home to take on the responsibility of caring for a deceased person of limited income while not profiting from doing so. CFDA respectfully asks the Human Service Committee to return this allowance to $1,800. Together, let us not forget the forgotten, the impoverished, the poor, the destitute, the penniless, and the paupers. These individuals are as deserving as you and me to be treated in death with dignity and respect, and to have a cremation with honor or a proper burial. Thank you for the opportunity to testify. I make myself available to your questions or comments.
Thank you, Ms. Paquette. Representative Case.
Thank you, Madam Chair. Ms. Paquette, hey, thank you for coming forward. I do remember when it was $1,800, and when it got cut down to $1,200. They wanted it to go lower at that time, but we were able to manage $1,200. Now it's $1,350. But not only, the question I have for you, what is the cost of cremation today?
Well, there's a huge discrepancy in the state, coming, whether you're in Fairfield County or in the Putnam area. So it really varies depending on what part of the state that you're in. Where I am in New Haven County, it's in the area of around $3,600. But that's with a significant discount. That's our direct cremation package. But again, there's a huge discrepancy in the costs throughout Connecticut, again, with the different counties that we have.
And I think what we don't understand is dealing with this in appropriations for years. There's a lot of other things other than the cremation that you do. It's the paperwork you have to do the finalization with the town halls, with what have you, and doing the complete thing all the way through. And the interesting thing I find is these funeral homes don't have to take the body, the deceased when they're actually called. So if there are some backlog, it basically can go back to the medical examiner, which will cost us on the state level anyway. So we appreciate you and your industry taking in what you can, and we will do everything we can to plead this to the appropriations, because if it was 1,800 5-6 years ago, costs haven't gone down. So
That's
I
correct.
appreciate you coming forward, and there's a lot more into it than just the cremation. You have to transport the body, you have to pick up the body, there's costs of your vehicles, there's a lot of other things involved here. We have to take that into perspective for the indigent people. So thanks again for your services. Thank you, Madam Chair.
Thank you, Representative. Thank you, Ms. Paquette. Have a wonderful evening.
Thank you. You too.
Next, we'll hear from Valerie Weissman, followed by Joseph Short.
Hello. I was going to say good morning, good afternoon, good evening. Anyway, thank you for the opportunity to speak. And I want to say thank you to our Senator Lisa Seminara, we are so happy she's joined our reps and our senators to represent the state of Connecticut in our little corner. Anyway, I'm, testifying with regard to the bill that Lisa has put forth, the Bill 208, as far as expanding access to low cost or free transportation for persons with disabilities. I'm a lifelong resident of the state of Connecticut. I'm currently a member of the board of directors of the ARC of the Farmington Valley. And in addition, my husband and I have been on the board for over 25 years. We have 3 children. Glenn is our middle son who has an intellectual disability. And my statement today will focus on the critical importance of low cost or free transportation on the ability of individuals with intellectual and developmental disabilities to find meaningful employment. To start off, I want you to know that our son Glenn's challenges are such that he is not able to work or hold active employment. So our motivation for testifying is not self-serving, as Glenn, would not benefit from this legislation. However, my reason for testifying is in support of individuals with IDD who can and do hold meaningful employment. There are a large number of individuals with IDD who have the ability, the motivation, and the desire to work. Employment allows individuals with IDD to do what most people aspire to do, which is to earn a living with dignity, to be actively engaged in our communities, and to be accepted members of a team contributing to a business's success. Well, as I stated, there are numerous individuals with IDD who can actively work. They face many obstacles in achieving their goal. One such obstacle is reliable and affordable transportation. It is frustrating and truly heartbreaking when you see an individual with IDD who has the desire, the motivation, and ability to work, but cannot do so due to lack of transportation. This also impacts families who may decide that they cannot work so that they can transport their loved ones to work, or basically that their loved ones cannot work because they need to work. Many of us take transportation for granted, but for these individuals, reliable, affordable transportation can be life-changing. It can be the difference between being active and engaged members of our community, leading a full and productive life, or being at home with limited options. Therefore, I urge you to support this bill and support individuals with intellectual and developmental disabilities. Thank you for your consideration, and thank you, Senator Seminara.
Thank you, Ms. Weissman. Senator Seminara.
Well, thank you so much, Val, for your glowing support for me. And I also thank you for putting me here so that we can address these needs. And I know both you and Tom are very much aware of, you've been pillars in our community for people with disabilities. And I know that you are very well aware of the issues that are highlighted in both of these bills. And all I can say is I very much appreciate your support. And I know that you have done everything you can in your capacity and working with FAVAR, who really does incredible work in the community in training people with disabilities to go out to work. And now we just need to get them employed, and we need to get them transported to where they need to be. So I very much appreciate you coming out to support these bills, and I thank you so much.
Just a segue. Also, we support the credits for businesses. I didn't speak to that, but, you know, and speaking to the person in charge of trying to find employment for people with IDD at FAVAR, she thinks this would be awesome and would really open up some doors. So let me just say, we support that also, obviously.
Thank you so much for that as well. You know, as you are well aware, there are many people with disabilities. We have talked this today and every day in this session about there being a workforce shortage. And I think an overlooked population is people with disabilities. They are so very much willing to work and want to work, so that anything that we can do to help support people with disabilities to get employment and once again get them to where they need to be would be very helpful. So again, thank you so much for your testimony this evening and hanging in there until 7:20 at night.
Thank you.
And hang on a little more, actually, because Representative Case has his hand raised. Go for it.
Sure.
Thank you, Ms. Wiseman, and thank you, Madam Chair, for the few minutes. So, Ms. Wiseman, a lot of people don't understand, or some do, but when you're in the northwest corner, you're near the area of FAVAR and Lark, our transportation is very minimal. And it's very hard for people to get out and about, even without disabilities. So this part of the bill, this part of our legislation that Senator San Manera put forward is very, very important, because we can do all the training we need to at FAVAR or at LARC or at any ARC throughout the state. But if we don't have the transportation to get them there, where are we? So it's a very robust program. How many people are in training out at FAVAR in order to get out into the field and waiting to get out in the field? Do you happen to know that number?
I don't know the actual number, but they do a great job as far as transitioning kids from high school, getting them ready to work. But, not everybody has the funding for the transportation. So like I said, they're, either they are left without being able to get to work, or their parents are, left with, how are we going to manage this? Do I have to quit work? Like I said, which is, as we've discussed, is not good for the economy, obviously. So
yeah, and when we're in different parts of the state where they have mass transit, it's a different
right,
story.
Totally
And
different.
We enjoy where we live. We're out here in the country, but we have to look at some better ways to get
Right.
people, especially those, to give them the dignity to get out there and do what they want to do during the day. So I thank you for
Absolutely.
coming forward.
Absolutely.
And thank
Anything
you,
I
Madam
can,
Chair. Oh, go ahead.
anything I can do.
Okay, thank you, Madam Chair.
Thank you, Representative. Thank you so much, Ms. Weissman. Have a great evening.
Thank you. You too. And good for you. I mean, you've been there like the whole time.
Got my coffee.
Do you need some throat lozenges? And
Thank you so much. We're going to hear from Joseph Short and then go back to Jan Ponchin. Joseph, you're muted. You just have to unmute.
There we go. Can you hear me now? Good evening. My name is Joseph Short. I'm here to testify on House Bill number 6702, an act concerning a consumer's right to repair a powered wheelchair. I greatly appreciate your acknowledgement of this serious problem. And although this proposed bill is certainly well-meaning, after careful consideration, I support a different approach as contained in the alternative language, which has been mentioned already. I've been a quadriplegic for over 20 years due to a spinal cord injury. I rely on a custom wheelchair for mobility and independence. Over the past 20 years, I cannot begin to tell you how many times I've been left without a functional wheelchair because of broken parts for weeks, months, and one time well over a year. Unfortunately, I've been hospitalized multiple times due to injuries that occurred because of broken parts on my wheelchair. For example, I've had stitches from falling because of a broken footrest, multiple pressure sores, which some of have required surgery and hospitalization because of broken lateral supports, a concussion from flipping over backwards because of a rear tire that fell off, and crashed my vehicle once because I was driving from a wheelchair that was broken and unsafe to operate. These would have all been preventable injuries had I been able to get my wheelchair fixed in a reasonable amount of time. Fortunately, my only options are to use a piece of broken equipment and hope I don't end up getting hurt, or lie in bed for an unknown amount of time while I'm waiting for parts, insurance, technicians, and the host of other issues one encounters while trying to get their wheelchair fixed. Considering I've got a $60,000 wheelchair that's custom made for my needs, I know I can't be provided a loaner while I'm waiting for parts. I'm not completely against the right to repair bill, but in all honesty, the amount of money it costs to repair even the simplest thing on a custom wheelchair far exceeds the average person's budget. That's why I fully support the advocate's alternative language for this bill. The key features of this alternative language are that wheelchair suppliers must come out and assess the equipment and repair it in a timely manner, which has been an ongoing issue with the two major wheelchair vendors. Second, the consumers have the right to bring an action in court if a supplier does not comply in a timely manner. Third, manufacturers must stock parts and have a contract with another company to provide needed parts. Fourth, the suppliers must have a staffed 24-hour call center for urgent repair needs. And the final piece of the advocate's alternative language, and in my opinion, the most important aspect of this bill, is that it prohibits prior authorization by insurers, including Medicaid, for wheelchair parts. This last provision has been the number one reason I've been given each time I've had to wait for repairs, and is also designed to cut down on the supplier's burden. Thank you for your time, Senator Seminara, Senator Lesser, Representative Case, Representative D'Amica, and all the other committee members who recognize the serious problem that myself and so many other wheelchair users across the state have been dealing with. With your support and the advocate's alternative language, wheelchair users can avoid preventable injuries and have repairs done within a reasonable amount of time. And once again, thank you guys for sticking through this whole night. I know you guys have been around here all night.
Thank you so much, Mr. Short, for you sticking around and for sharing your experience. Senator Seminara?
Yes, I just wanted to thank you, Mr. Short, for your testimony. Again, we are so very well aware of the problem, and we are hoping this will be the session that we address this and we address the needs of wheelchair users and owners, because as you testified, you're laying in bed for a month because you cannot get the parts for your wheelchair, and you're makeshifting repairs on your own that have caused you injuries. So that's a huge issue, and no one should have to deal with that. So thank you so much for your testimony and making us aware.
Thank you.
Thank you, Mr. Short. Have a great evening.
You as well.
We're going to go back to Jan Ponchen.
Thank you, Senator Lesser, Representative Gilchrist, and honorable members of the Human Services Committee. Accept my sincerest thanks for your longstanding and steadfast commitment to the needs of children and families in Connecticut. I am Dr. Jan Ponson. I'm Vice Chair for Clinical Affairs at the Yale Child Study Center, and I'm testifying in strong support of House Bill 6612, an act concerning nonprofit health and human service providers. The child's behavioral health care system can be thought of as a continuum of care, and we actually have a strong infrastructure in Connecticut, but it is now riddled with gaps and holes through which families fall. Many families are not even lucky enough to climb onto the system for the chance to fall. And this has been caused in large measure by under reimbursement. The crowding of the emergency room, inpatient units was in large part driven by the unavailability of services on the outpatient or in-home level or other mid-levels of care. And we certainly have data to back up that statement. So the behavioral health system is straining to meet unprecedented demand without foreseeable respite. This is a trend that's been happening and documented over the last 10 years, and the pandemic has simply added fuel to the fire. And the pandemic is neither the cause nor the ending of the panic or the waning of the acute phase of the pandemic, the resolution ahead. So I'm here to stress that we have a problem that will continue and has no foreseeable end, and to make sure that we remember that. We serve over 60,000 visits per year at the Child Study Center. 50% of our clients are Medicaid. And whether Medicaid or private insurance, it does not cover the cost of providing that care. We have operating losses every year, and it's not a sustainable future. Our in-home services or other grant-based services have not had COLA increases. There's no mechanism in place to determine the COLA increase. It's not pegged to inflation. Decisions seem to be made ad hoc, and it's after begging 10 years later that a change is made. That's not an appropriate way to proceed. We have had a doubling of referrals in the last year, twice the number of folks seeking care. We've never had a wait list in our history. Now we have months and months of a wait list. And just in the last week, and this is just a few days ago, I'm living a nightmare. I've been looking for a psychiatrist for months. You're the only place that called me back. These are the things that we hear on a regular basis, and I'm sure many of you hear from your constituents. So in sum, we need to shore up the existing support for the programs that we have, and Medicaid must meet the actual cost of care, a simple mathematical equation, and the COLA process must be transparent and have some form of methodology. And I really thank you for your time, and I appreciate that you've been here for much of the day. And Representative Gilchrist, I heard you encourage members to keep to 2 questions to have us go. So I thank you for that, and I thank members for shortening their questions earlier today.
Thank you so much for your testimony and your time. I appreciate it. We all do. Next, we'll go to Dan Gervich, followed by Pat Ladner.
Good evening, Madam Chair and members of the committee. Thank you so much for the opportunity to express my strong support for HB 6612. I am the CFO for 2 affiliated homeless services agencies in Hartford, My Sister's Place and Mercy Housing and Shelter, that together serve over 6,000 clients a year. So, not so fun fact. For fiscal 2023, our agency expects to return over $425,000 in unexpended funds to the state, even though we will have met all of our program outcomes. This is despite the legislation that was passed 2 years ago and was intended to fix this issue. So just for a bit of background, our programs are supported through a very complex web of funding, like many providers that have testified. Identical activities are funded through multiple funding streams. So 55 of our transitional housing beds, for example, are funded through 9 grants. 165 slots of supportive housing are funded through 11 grants, and our shelter diversion and rapid rehousing program through 9 grants. Unfortunately, and here's the key, these grants fund identical activities at varying rates. So we end up in a situation where you have, in this facility right behind me, 118 Main Street, we might have 10 residential beds over here that are adequately funded, whereas the next 10 beds in the very same facility serving the very same population operate at a deficit. And the unexpended funds for the first 10 beds have to be returned. They can't offset the deficit gap in the underfunded beds next door. So we and our fellow nonprofit providers must return funds even as we experience operating deficits and leave capital needs at our facilities unmet. And as many have said today, these issues have only been exacerbated by inflation and the workforce crisis. So staff vacancies have caused labor shortages and have created temporary surpluses in some of our programs. Staff in those programs have worked hard, risen to the challenge, met our program outcomes, but under the current rules, we're forced to consider cutting essential shelter and food programs for lack of funding, even as we return nearly $500,000 to the state. At the same time, we're unable to offer higher wages to be competitive in the marketplace. So as you can tell, this is absurd. Achieving program objectives efficiently should not be penalized. Nonprofits, as someone said before, are social profit businesses with expenses to pay. It should not be tough to do business with the state of Connecticut. HB 6612 is the common sense solution. Let me just address something that Commissioner Barton-Reeves said way back when at 11 a.m. It probably seems like 2 days ago. She raised the objection that contracts are often a combination of state and federal funds, and therefore cost settlement is a necessary evil. Well, to me, that's a poor pretext for not passing HB 6612. Let's simply decide that the federal dollars get spent first. If the total of unexpended funds exceeds the total of state dollars, I'm sure my colleagues and I would happily return any unexpended federal funds. And there are numerous workarounds that I could talk about if I had more time that are also possible. So in summation, the legislation that was passed in June 2021 was a godsend to agencies like ours. We are pumping our fists. Unfortunately, given the narrow and inconsistent way in which it has been implemented, where it has been implemented at all, it's been restrictive as to be ineffectual. So I urge this committee to fix this issue of cost settlement and savings retention once and for all with HB 6612, allowing flexibility for efficient nonprofit providers to operate in a way that best serves the need in our community. Thank you very much.
Thank you, Dan. So good to see you. And thank you for your testimony and your time.
Thank you.
Next, we'll hear from Pat Ladner, followed by John Staffstrom.
Good evening, distinguished members of the Human Service Committee. Thank you for hanging in there with us. I know it's been a long day for all of us. My name is Pat Ladner, and I am the CFO for CUNE Employment Opportunities. CUNE is a nonprofit agency in Central Connecticut that serves approximately 400 individuals with disabilities each year. Our services support these individuals in finding and retaining employment. Our primary funding sources are the Department of Developmental Services and the Department of Mental Health and Addiction Services. I am giving this testimony in support of HB 6612, and I echo what many of my colleagues have already said to you today. For years, nonprofits have come before this committee to stress the importance of flexibility in funding for nonprofits. Despite the legislature's intent to end the clawbacks by passing laws to eliminate the practice, our contracts continue to mandate the policy of returning unused funds to the state through cost settlement. HB 6612 provides a much clearer direction in contracting state agencies, and if passed, will increase stability so providers can remain financially secure by reinvesting in their programs, just as any other business would have the opportunity to do. Permitting providers to keep the savings would allow us to save for future capital needs, program enhancements, as well as unexpected but urgent expenditures that may arise. It could level the playing field to compete with industries that continue to lure our employees. Investing in our workforce and programs will promote the quality we strive to attain each day. For years, providers have demonstrated their ability to deliver these critical and essential services, not only well, but efficiently. The quality of nonprofit services is regularly monitored by our funding agencies, ensuring the standards remain high. If we are contracted for a mutually agreed fee and services are provided satisfactorily, it makes sense to allow us the ability to keep the entire fee to reinvest in our programs, similar to other state contractors. When agencies suffer a deficit, they are not made whole for the services they provided. In some cases, it must be absorbed 100% by the provider. It's an unbalanced system to expect providers to return funds should there be a surplus. Last year, the legislature recognized the value and commitment of our workforce, and we were able to deliver much needed wage increases to our staff. We are truly grateful for your appreciation of their efforts. However, the inflation we experienced negated much of what was accomplished in providing long overdue increases. I'm also testifying today in support of Section 4 of the bill, which would index the rates the state pays to the inflation index, providing increases when inflation increases. To retain staff, we try our best to leverage competitive benefits to compensate for less commensurate wages that are in other industries. But the rising cost of benefits are at a pace with which we cannot keep up. In fact, escalating costs in all facets of our budget continues to be a challenge. Inflation-tied increases would ensure our ability to keep up with these
Time
costs
has expired. Can you please summarize?
and continue the quality services the state has come to expect. Please continue to show your support for the important work we do by passing HB 6612. Thank you for your time.
Thank you for your time and your testimony. We appreciate it. Have a good evening.
You too, thanks.
Next, we'll hear from John Staffstrom, followed by Ben Shaken.
Hi, good evening, distinguished members. My name is John Staffstrom, and I am the dispatch manager at Springbrook Ice and Fuel, New Britain. Our business is located in New Britain. We service many low eligible income fuel clients, includes the Human Resource Agency, HRA, New Opportunities of Greater Meriden, NOGM, and the Community Renewal Team, CRT. I am currently the fourth generation in the business. I am here in support of HB 6703, an act concerning the Low Income Home Energy Assistance Program. As a vendor in the Connecticut Energy Assistance Program, I'm here today to express my concerns about the way that it operates. My dad and many other fuel dealers have continued to voice our concern to the Department of Social Services and other powers that change needs to be considered. Since the Russian-Ukraine war, market conditions have been unprecedented. Daily price volatility making it difficult, if not impossible, to break even. The New Haven rack average pricing that the program is based on no longer reflects the cost of fuel where many dealers purchase it. If the dealer doesn't load their truck in New Haven, the price difference can be dramatic and significantly erodes the margin set by the state. Due to volatility, midday price increases were prevalent this heating season. It is pretty difficult to deliver fuel to LIHEAP customers or any customers when the wholesale price to load our trucks changes so dramatically on and off in less than a few hours of notice. We all know the cost to run our households has significantly increased. As a business, we have been subject to significantly higher diesel prices to operate our trucks, increasing minimum wage, and having to make drivers' wage increases due to wage suppression. Higher insurance rates, and we need a line of credit often to be extended because we participate in the LIHEAP program. I can speak to this personally. Every day putting in orders for customers that's last delivery still hasn't been paid for by these different agencies. This is a problem that needs to be addressed, and I hope for your support on this bill. Thank you.
Thank you, Mr. Staffstrom. Have a wonderful evening. Thanks for your testimony and your time.
Thank you, you as well.
Next, we'll hear from Ben Shaken, followed by Doris Maldonado Mendez.
Good evening, Madam Chair and members of the committee. Thanks for sticking with us today and tonight. My name is Ben Shaken. I'm the Director of Government Relations at the Connecticut Community Nonprofit Alliance, and I am here to testify along with many of our members this evening in support of House Bill 6612. I'm going to try to, in my testimony today, not repeat some things that have been said by folks throughout the day. It will be difficult, but I want to highlight a couple of things. First, let me start on the piece of the bill, Section 4, that will tie nonprofit funding to inflation. I just want to make the point that we have a spending cap that's grown significantly, and in the discourse at the state capitol, that's often sort of talked about as, look at all this new money that's available in the state budget. I just want to say the budget itself grows. The spending cap is adjusted precisely because inflation increases the cost to deliver government services. And so the budget is allowed to grow to deal with those costs. And that's all that we are hoping to accomplish in this bill. I'll also say the legislature has really recently recognized that costs do increase over time. There's dozens of state contracted services that statute provides for automatic increases each year due to inflation. The legislature's recently required the state's minimum wage increase with inflation. Last year, the legislature even recognized that decades of flat funding caused serious issues with their own salaries and indexed their salaries and those of elected officials to inflation. And so it's time for this smart policy to extend to the state's nonprofit health and human services system. Moving on to the innovation incentive program to revenue retention. Let me just start by saying, we've been talking about this issue. Nonprofits have been talking about this issue for literally decades, since at least the beginning of the Malloy administration. And for 6 years now, we've come before this committee and you've supported us, and the legislature supported nonprofits in 2017, 2019, and 2021. And COVID hit. And let me just sort of highlight that nonprofits were forced in the midst of the COVID pandemic to pay back money to the state. Not only that, but federal assistance came to nonprofits the same way it came to many businesses. And twice the legislature had to pass specific language prohibiting the state from clawing back funds that were supplemented with federal programs like the Paycheck Protection Program. Secondly, you've heard tonight about issues with implementation. And so I want to just provide some specificity there. First, the biggest issue is that nonprofits have not been allowed to use any funds that they have in surplus from one program to bolster any part of their organization that's funded by a different line item in the state budget. And instead, they're really only allowed to reinvest those funds in the particular program that's already running a surplus this year. So that means they continue to run substantial deficits in money-losing programs without the ability to reinvest the funds that they save in one program to bolster their agency as a whole. Secondly, the current law, the one that was passed in 2021, requires that OPM collect a report from nonprofits about how retained funds were
Time has
reinvested.
expired. Can you please summarize?
Yes, I will. That report is required to be provided after the fact. How were the funds spent? Instead, the way it's been implemented is that nonprofits are being required to provide specificity before the funds are spent. How are you planning on spending funds before they're allowed to retain them at all? And that's one of the things that's led to what you heard throughout the day today, that many organizations have only just heard now in the end of February about money they can retain that was surplus money last June. So I will sum up there and just say we really thank you for your support as a committee. For many years, you've supported this issue and brought it to your colleagues across the full General Assembly. We hope this bill will clarify some of the issues that have come up with the implementation of the language that the legislature has already passed, and that we look forward to working with you and the executive branch and the judicial branch to make this legislation happen this year. And so thank you very much. Have a great night. I'm happy to take any questions if there are any.
Thank you, Ben. Yep, Representative Case, go right ahead.
Thank you, Madam Chair, and thank you, Ben, for staying on this evening. Have you been able, as your agency, to get that reporting from OPM on the dollars that aren't spent?
It's a good question. No, not yet. So the law passed in 2021, 2 years ago, and was effective July 1st, 2021. But it wasn't implemented until really until this fall. The OPM issued a memo to state agencies in the early summer or late spring, so prior to the close of fiscal year 22 of the last fiscal year, directing them to implement a policy and providing them guidelines for how to do it, which is some of the things that we're trying to fix in this bill. But state agencies have not implemented the program fully. They issued their directions to nonprofits at varying times throughout the first part of the fiscal year. Many of them didn't issue those directions until November or December of 2022, so almost halfway through the fiscal year. And so, as folks have testified to earlier, really only, this isn't true 100%, but in general, only one state agency has started to approve requests for use of funds, and those approvals have been happening over the last several weeks, and we haven't seen approvals from all of the other state agencies yet. So I don't think that data even exists yet for us to see what the buckets are that folks have told state agencies they're they're planning on using the funds for. But it's been a rocky rollout for sure. And so we're hoping that this legislation can pass and can be much clearer. The legislature can be much more prescriptive, frankly, in how they expect the program to be implemented.
Well, and just a comment, and hopefully you can have an answer for me too. The reason that we looked at this and really wanted to do it is because the monies are budgeted for the nonprofits. And the way it was drafted in 2021 was to make it so that the agencies didn't go and find cost savings with their employees, but if there was something that they could come up with where they had monies that were done at the end of the program, those monies could be used for certain things within their organization. And I guess what I will do tomorrow is try to look at and see where our reporting is, because we should be knowing about that before anybody does. And the bottom line has been the money is budgeted for these organizations. So to claw it back is the wrong thing to do. The organizations deserve to have the money. They are the ones facilitating and taking care of the majority of our catchment networks through the nonprofits. So if you do happen to get that report, please let us know. But I think we will be looking for it on our side, and hopefully we can get something moving a little bit more aggressive this year on those dollars. But thank you again for sticking it out tonight, Ben.
Thanks, Representative. And I will say just briefly, we agree. And I think there is definitely a difference of opinion, perhaps, about that sort of philosophical point, that are these dollars being paid to nonprofits to pay them for services, and then after that point, the services have been rendered, their contracts have been fulfilled, that ends the role of the state's sort of fiscal oversight? Or are these dollars being provided to pay for what's needed and then take back whatever is left? And I think what we have said is similar to every other entity that contracts with the state, that the state buys a service from. The dollar should be able to stay with the organization from whom the service is purchased, because that organization, in particular, the nonprofit organizations, need that support to be able to sustain themselves, to be able to capitalize, save up over time for capital needs, things that they really can't do right now. So anyway, thank you for that support, and I'm looking forward to working with you and the rest of the committee.
And Ben, your nonprofits are the backbone of the state of Connecticut and working with the catchment areas. So I appreciate it and appreciate your agency and all you do. So thank you. Thank you, Madam Chair.
Thank you, Representative. Thank you, Ben. Thanks for staying with us tonight.
Have a great evening.
You too. Doris Maldonado Mendez, followed by Elena Sokolowski.
Buenas noches, Senator Lesser, Representative Gilchrist, Case, Dathan, and Hughes, Senator Seminara, and esteemed members of Human Services Committee. My name is Doris Maldonado Mendez, a Latina born with disabilities, in support of SB 991 as drafted, concerning Medicaid reimbursement for community health workers, as well as SB 208, expanding access for persons with disabilities. Professionally, I am the statewide bilingual health information specialist and certified community health worker for PATH Connecticut, Connecticut's Family to Family Health Information Center. F2Fs are in federal statute, providing crucial services for families, providers, communities, and states serving children with special health care needs. I am also the first Latina chair of the Connecticut Council on Developmental Disabilities, which is entirely funded by the Federal Administration for Community Living to engage in capacity building and systems of individualized service and supports. Well, I look forward to working with you, Senator Seminara, on expanding access for persons with disabilities. I will be testifying on 991. Nationally, I represent Connecticut as a National Promotora, CHW, and serve as the Project Advisory Committee lead of the Family Voices Promoting Equitable Access to Language Services Collaborative with American Academy of Pediatrics and National Association of Community Health Workers. As a trusted messenger and CHW, my lived experiences with socioeconomic determinants of health and systemic inequities have allowed for a voice to support and empower parents at educational and medical provider meetings, for survivors of domestic violence, genocide, human trafficking, educational discrimination, victims in probate court, for children and youth in care, mental health parity, civil and disability, and basic health rights. The bill as drafted requiring a Medicaid state plan amendment to pay for CHW services directly without adding authorization for coverage through value-based payment plan would be a proactive community opportunity to address the issues with the state's workforce shortage, especially for RDD communities. Changing it from a state plan amendment, which would provide fee-for-service payments for CHWs and others, to coverage and bundled payments to providers through value-based paid services, is potentially harmful, but particularly people of all ages with disabilities, especially those with medically complex challenges. Thank you for the opportunity to testify in support of 991. We'd love to invite you for more than an earned cup of café when this is all said and done. Beans and coffee, beans and co, perhaps. Gracias. Good night.
Thank you so much, Ms. Maldonado Mendez. Senator Seminara?
Yes, Ms. Mendez, it's so good to see you again, and thank you for your testimony. And thank you for your support of 208. I look forward to working with you in the future too, to making this come to fruition.
Thank you.
Have a wonderful evening.
You as well. Thank you.
Next, we'll hear from Elena Sokolowski, followed by Doug Ardrey.
Good evening, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Elena Sokolowski. I'm a law student at Yale in our Medical Legal Partnership Program. I'm here to testify in support of SB 991 concerning Medicaid reimbursement for community health workers. I work with the Transitions Clinic Network, which operates in New Haven, Bridgeport, and East Hartford. Transitions is an evidence-based model with locations across the country that provides patient-centered primary care for people with chronic illnesses who are returning home from incarceration. Central to this model is the work of community health workers who have their own lived experience with incarceration. Our CHWs connect with folks prior to release to establish a relationship and begin to understand what each person needs to successfully reenter. They're the bridge between the inside and the outside. They help clients see that they will be able to access the services they need at transitions without judgment, and they use their own stories to inspire and encourage. We know that CHWs work because we see it in our clinic, but this is corroborated by dozens of studies, including 2 new studies on transitions specifically, showing significant savings in costs for reentering transitions members compared to people who received care elsewhere. This bill is an excellent first step, and as written, it will help our CHWs support people who have been released. However, it won't support the work they do inside prisons because it doesn't challenge the Medicaid inmate exclusion policy. The MIEP is a federal law from 1965 that prohibits states from using Medicaid funds for services delivered to people who are incarcerated, either pre-trial or post-conviction. However, states may request permission to waive this policy, and these requests are increasingly common. In October 2021, Montana requested permission to provide incarcerated people with care management services 30 days prior to their release from state prison to be delivered by a community health provider with particular expertise in working with justice-involved members. In May 2021, Arizona requested permission to offer basic care coordination to incarcerated people with serious behavioral and physical health conditions and a high risk of homelessness, starting 30 days prior to release. While these requests haven't yet been granted, the Center for Medicaid and Medicare Services indicated in their most recent letter to Arizona that they are, quote, supportive of increasing pre-release services for the justice-involved populations, and, quote, will continue to work with the state on this component of its proposal. Transition CHWs are already doing much of what these states have proposed, but without Medicaid support. Connecticut has an opportunity here to join other states leading the nation on effective and innovative care models to support successful reentry. I wanted to urge the committee to consider, alongside the issue of amending the Medicaid state plan to include CHWs, directing DSS to submit a waiver request to reimburse CHWs for the services that they provide to people who were incarcerated in state prison, not just following release, but prior to it as well. Thank you for your time, and I'm happy to answer any questions.
Thank you, Ms. Zekulowski. Thank you for staying with us tonight and for your testimony and your time. Next, we'll hear from Doug Audrey, followed by Kathy Flaherty.
Good evening, distinguished members of the Human Services Committee. My name is Doug Ardrey. I'm the CFO for SARA Inc. Our organization provides early intervention birth to 3 services, as well as employment, day support, and residential services to adults with intellectual and developmental disabilities. In our current capacity, we serve approximately 1,800 families in Connecticut and individuals each year. And our organization has been in existence for about 60 years, and we employ approximately 140 Connecticut residents. I am testifying on HB 6612, which would prohibit the practice of state agencies calling back the surplus funds from nonprofits at the end of the fiscal year, allowing nonprofits to retain savings and reinvest them into provisions of services. I echo what everybody else has been saying on this bill today, and there's been extensive testimony on that, so I don't want to kind of recover that area. I think the one area that I wanted to focus on is just the clarity of this bill, because this is the 3rd year that I'm testifying on this bill, and it's still not clear to providers, how we can use these funds, the timing of when we can use these funds, what we can use these funds for. And I just really am just asking for the legislators to clarify this bill so that the uncertainty goes away. Because, I can tell you, there's a lot of service providers last year that spent their surplus money because they were afraid that it was going to be taken away from them. And I think that's just, fiscally not a very sound thing for them to do, because those funds are now gone. And they could have been used for future projects. They could have used to strengthen the balance sheets of these companies, rainy day funds, things along those lines, and things that they don't even know that are going to come up with, over the next couple of years. So I'm just asking for your support on this bill, and hopefully that we can get this thing clarified once and for all, and everybody can kind of move on this. So I thank you for the time and your support of the HB 6612. Thank you.
Thank you, Mr. Ardrey. Thank you for being here and for your testimony.
You're welcome.
Next, we'll hear from Kathy Flaherty, followed by Martina Seminara.
Good evening, Representative Gilchrist, Senator Seminara, Representative Case, and all the members of the Human Services Committee. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project, and we provide legal services to people who are eligible for mental health services from DEMIS. I submitted written testimony on 6 different bills, so I'm just gonna rattle them all off, say a couple things, and if there are questions, great. If there are not, that's great too. Senate Bill 420 about the tax credit. My concern is why we incentivize things that people are actually already required by law to do. 6702 about the wheelchair repair. I definitely encourage the committee to support the substitute language that has been developed, and you heard very fantastic testimony from lots of people earlier in the day. 6587 Medicaid coverage for diapers to the extent it's available. 6612 for the nonprofits being able to keep their savings. Our clients depend on those nonprofit service providers. Our folks spend years in our state hospitals because the providers don't have capacity in the community to provide community-based services. We need to do everything we can to support those private nonprofit providers. 6776, the passive redeterminations, especially given the fact that DSS does not seem to be able to handle the workload that it currently has. And then they're going to be unwinding the public health emergency. They are shutting down their call center at before noon on most days. Whatever can be done to relieve some of those administrative burdens is going to be critical for people who remain eligible for coverage. And the last bill is 991, the community health workers. If you keep the bill as it's written and don't use it to change any payment models to value-based payments or alternative payment considerations, do that state plan amendment And having just heard the testimony from transitions about getting services to people before they transition, the state should explore that, because we all know the issues with healthcare and DOC, and making sure people are connected to the community as they're leaving and returning to society. Making sure they have access to healthcare is super important. Thanks.
Thank you, Ms. Flaherty. It's good to see your testimony and your time. Next, we'll hear from Martina Seminara, followed by Elizabeth McDowell. Martina, you just need to unmute, please.
I apologize. Hello, my name is Martina Seminara. I would like to take this opportunity to thank Senator Lester, Representative Gilchrist, and Representative Case, as well as the other distinguished members of the Human Services Committee for allowing me to testify in support of SB 208 and SB 420. As a person with a physical disability who is unable to drive, I can speak to the necessity of having access to transportation. I was able to get my first professional job in early October, and I immediately started the process of applying for transportation provided by the state, knowing that it would take some time to get it in place. On December 7th, I got my interview with the ADA paratransit section of the Department of Transportation. During that interview, I was told that I do not qualify for two of the services offered because of the area in which I live. Luckily, I qualified for one called Encompass, a cab service that was run out of the M7 cab company. I was able to start using Compass on January 27th. All told, it took 3.5 months for me to start being able to use state-funded transportation. I consider myself lucky because I have family members that were able to help me get back and forth to my job until that was put in place, and I was able to start in October as the position required. However, I know people that do not have family members that are able to help them, and therefore have to delay or turn down a job altogether. And I think this is heartbreaking. SB 208 would greatly diminish the possibility of this happening. I am also in support of SB 420 because I think the population of people with disabilities is an untapped pool of talent. It would allow potential employers to create a further diverse and equitable workplace. As I mentioned earlier, I was able to get my first job in October, and it took me 1.5 years to get any type of employment despite having a bachelor's degree from Trinity College. I cannot help but think that part of this is based on the fact that I have a disability, and it makes people nervous to hire people with disabilities. So I'm in support of this bill because I think it would only have upside for potential employees and employers. Thank you.
Thank you, Ms. Seminara, for being here and for your testimony. Representative Case?
Thank you, Madam Chair. And Martina, thank you so much for coming forward and giving us your personal experience, because you live it every day. And I'm glad that you found a ride. I'm glad that you have a job. You've made some great successes, and I don't have any questions for you, but I just want to say thank you for coming forward, and thank you for sharing your mother with us as a senator. So she might have been your ride before, but now she's stuck in Hartford. So thank you.
Yes, thank you.
Senator Samanara.
Thank you, Ms. Seminara, for your testimony. I'm very proud of you, Martina. Thank you so much for your testimony. I am hopeful that all of my committee members will take it into consideration, which I'm sure they will, and recognize that people with disabilities are still thwarted from time to time with employment and definitely with transportation. So hopefully we can do something this session to improve that. But I thank you for taking the time to prepare your testimony, and I thank you for coming tonight and hanging in there. And I most thank you and love you very much. See you later.
I love you too, Mom.
Thank you so much for being here.
Thank you.
Next, we'll go to Elizabeth McDowell, followed by Kim Forte.
Good evening, Madam Chair and committee members. Thank you so much for taking the time to stay late and listen to our testimonies. My name is Elizabeth McDowell. I am a resident of New Haven, Connecticut, and I'm a public health professional with a college degree in biology and economics. I just wanted to testify and say that I'm strongly opposed to the passing of HB 6618, which would use my tax dollars to pay for medically induced abortions for out-of-state women, because I have both moral and scientific objections to this practice. I would specifically like to agree with Nick Smith, Micah Flashman, Rashad Gibson, and Robert Hale's testimonies, among many others. I'm a young woman and I agree with what they said, and I would like to add my own testimony. The $2 million that have been proposed for this program should not be permitted. I volunteer weekly at a charity that provides free groceries to New Haven residents in need, and many of the people that I see face to face every single week struggle with homelessness and food insecurity. Our tax dollars should go towards programs that help disadvantaged Connecticut residents, such as initiatives that address homelessness, hunger, and mental health. This bill specifically targets and financially incentivizes medically induced abortion for pregnant, low-income women who are particularly vulnerable members of our population. As a woman, a scientist, and a Connecticut taxpayer, I believe that abortion is always the wrong choice, so please do not use my tax dollars to incentivize it. Thank you very much for your time, and please vote no on HB 6618.
Thank you for being here, Ms. McDowell, and for your testimony. Next, we will hear from Kim Forte, followed by Janet Alfano.
Good evening, and I just thank you all for your steadfastness and your commitment to hearing all of us this evening. I've appeared before this committee professionally, but tonight I appear personally. My name is Kim Forte, and I am a resident of Norwalk, where I am raising my 7-year-old twins with my spouse, Tina, and we absolutely love living here. I'm testifying tonight in support of House Bill 6617, which will expand coverage under the law for fertility treatments for my community, which is the LGBTQIA community. When I first started to seek fertility treatments, I was 40 years old. I was recently engaged, and I was so excited to start my family. And when my doctors met with me, they were sure that IVF was my solution. But when they applied for my benefit, the insurance company told me because I hadn't engaged in heterosexual sex for 6 months, that I would therefore be denied my benefit. So I had to undertake a cost of my own to prove to my insurance company that I was infertile at the age of 40, even though I was already covered by the infertility law of the state of New York, which is very similar to the state of Connecticut's infertility law. I and my spouse at the time underwent a cost of over $20,000, and in the process, great heartache over 6 months. I had to not only bear the cost of what it would cost for 6 months of IUIs, but I also had to bear the emotional and physical pain of that as a person. There were unlimited blood draws. I underwent 2 painful, both emotionally and physical miscarriages during that 6 months that my insurance company was requiring me to prove my infertility. One of which required me to have what they call a DNC. So I was required to go on anesthesia. As a result of that, my doctors knew these procedures would not be successful, but I was still required to undergo them. The second miscarriage I had to suffer was at the end of my first trimester, and I was so hopeful. And every month I was hopeful. And that month, after 3 months, it didn't work. And that was the 6th try. So then after 2 IVFs, we were able to conceive, and I have these great kids. But what we knew the whole time, and what my employers knew the whole time, was that what the application of the law was discriminatory towards me. And my employer fought for the benefits. They fought my insurance company. I fought my insurance company. And I felt that the corporatization of my body, because I couldn't engage in the sex they chose me to, afforded them the ability to deny me something that my heterosexual friends were able to go in and just say, we can't make a baby. And they got IVF right away. And we knew gay couples who would go in with their known donor and claim to be couples, and they would get IVF right away. But because we chose an anonymous donor and couldn't pretend to everybody, they wouldn't let us have the benefit that everybody else around us was getting. And so the financial and emotional costs to us were what we thought would be unbearable. Fortunately, we were lucky and we're able to stay through it and have the financial means to do it. But I'm here to plead with you that my community and single people who choose to be parents shouldn't have a law stand in their way when science is clear and they know what works and the law tells them they can't do it, or a corporation tells them they can't do it. By passing this bill, you can really change the lives of families and really make more diverse families in Connecticut. And in a state when we're pleading for people to live here, this is a good investment in families, and it's a good investment in equity and diversity for our state. Thank you. I'll answer any questions if anybody has them. I'm a pretty open book about this.
Thank you so much for being here and for sharing your experience to help others. I really appreciate that you shared that with us.
Thank you, Representative Gilchrist.
You've got 2 beautiful children. So have a wonderful evening. Thank you.
Thank you. You too.
Next, we will hear from Danielle Blackstone, followed by Megan Smith.
Good evening, Senator Lesser, Representative Gilchrist, members of the Human Services Committee. My name is Danielle Blackstone. I am the Finance and Administration Manager at the Diaper Bank of Connecticut, presenting on behalf of Janet Stalti-Alfano, the Executive Director. I appreciate the opportunity to testify before you this evening on her behalf, and we extend our sincere apologies as she cannot be here. Thank you for sponsoring HB 6587, an act concerning Medicaid coverage for diapers. Since 2004, the Diaper Bank of Connecticut has been helping families meet this basic need. We know the impact not having enough diapers has on families. While we are a well-established leader and one of the largest diaper banks in the country, we are only meeting a fraction of the true need in our state. We are serving over 6,000 infants and toddlers each month, yet the need, as indicated by the Connecticut DSS data portal, there are approximately 89,000 children through age 4 who are covered by Medicaid. Diaper need impacts the health and well-being of the entire family. Diaper need has been documented to be the #1 predictor of postpartum depressive symptoms above and beyond food insecurity. Extended periods in a soiled diaper or even reuse of previously soiled diapers can increase the risk of urinary tract infections, hepatitis, eczema, and severe diaper rash. The Diaper Bank of Connecticut is helping to reduce the incidence of diaper rash, which in turn has reduced medical expenses for families. Additionally, by providing a supply of diapers needed for childcare, we are helping parents get to work. Incidences of diaper rash declined 33% among children whose families receive supplies of clean diapers, plus babies experienced 77% fewer days of diaper rash. More than half of parents using childcare to go to work have missed work because of inadequate supply of diapers. Parents unable to access childcare because of lack of diapers missed work or school on average 4 days per month. We are working to provide a basic need that is essential for the optimal health and development of infants and toddlers. Providing diapers improves health outcomes by reducing the incidence of diaper rash and associated health risks in babies and decreasing stress in mothers. While these are significant accomplishments, we know there is more work to be done and many more families who need help. Ensuring diapers are covered under Medicaid is a logical next step given the significant negative health outcomes and associated costs related to not having an adequate supply. Diapers for infants and toddlers should be considered as essential for optimal health as diapers for children and incontinence supplies for older adults are. We are encouraged by the state's increased attention to this issue and will work to do whatever we can do to help families and infants and toddlers at the most significant time of their development. The simple fact is that diapers are a basic health need for optimal health and well-being of children and families. To address an earlier issue, There is a precedent being set in other states of the Centers for Medicaid and Medicare covering health-related social needs like diapers and food. States can get these health-related social needs covered through Medicaid by applying for a state plan amendment or a Medicaid 1115 waiver, like Connecticut has for other services. CMS is likely to approve given focus on health equity and the coverage of health-related social needs in other states as they recognize the value in addressing upstream drivers of healthcare costs like diaper needs. Thank you for your time, and I'm happy to answer any questions.
Thank you so much, Ms. Blackstone. So good to see you. And thank you for your testimony and for the Diaper Bank's advocacy on this important issue.
Thank you.
Next, we will go to Megan Smith, and Representative Comey is going to step in for me for just a few minutes. Thank you. Go right ahead.
Thank you, Representative Gilchrist and Senator Lesser and distinguished members of the committee. I'm Megan Smith. I'm the Senior Director of Community Health Transformation at the Connecticut Hospital Association, and I'm here to testify in support of House Bill 6587, an act concerning Medicaid coverage for diapers. As you're aware, Connecticut's hospitals continue to meet the challenges of the COVID-19 pandemic, providing steadfast, high-quality care to anyone who walks in the door, regardless of the ability to pay. Diapers, like food and housing, are a basic material need that impacts health. We are faced with a maternal health crisis nationally and also here in Connecticut. We know that the #1 driver of maternal deaths is maternal mental health, so things like postpartum depression. As Danielle referenced, diaper need is highly correlated with postpartum depression. And in fact, one study, a large study done here in Connecticut of low-income mothers, found that diaper need was the largest predictor of postpartum depressive symptoms, actually a larger predictor than food insecurity and housing instability. In addition, diaper need impacts infant and child health. Diaper need is correlated with a higher incidence of diaper rash, urinary tract infections, and also poor infant sleep. In addition to these health impacts, diaper need has tremendous economic impacts on families. New data emerging from the National Diaper Bank Network suggests that families are missing, on average, 5 days of work a month due to diaper need. That kind of economic effect of missing 5 days a month for diaper need equates to an average lost income of $6,000 a year. And the economic shock that losing $6,000 a year of income has on families' health is tremendous. It means not being able to put food on the table, support rent, pay for prescription medications, and all of these have really detrimental health impacts. Because of these reasons, the Connecticut Hospital Association has partnered with the Diaper Bank of Connecticut through Department of Housing funding to launch the first of its kind in the nation statewide approach to address diaper insecurity, led by hospitals and their community partners. Since Diaper Connections started in November 2022, Connecticut hospitals and their partners have served over 600 families through Diaper Connections. Expanding the coverage for diapers through Medicaid would allow us to address key issues in maternal and child health in our state and allow us to address a key social driver of health equity. We strongly support House Bill 6587. Thank you.
Thank you so much, Megan, and thank you for highlighting the important work that you do with the partners around the state. I don't see any questions, so thank you for hanging the long hours with us.
Thank you.
Next, we have number 126, Hannah Strager. Hi, Hannah. Welcome to the Human Services Committee. Go ahead.
Hi, dear Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Hannah Schreier, and I'm from New Haven. I'm the organizing director of Tight Lift, which is a grassroots organization by and for people with vulvovaginal and chronic pain. I'm testifying in support of raised House Bill 6617, which addresses a critical public health need by eliminating barriers to fertility care and ensuring that all Connecticut residents have equitable access to reproductive health care that they need to build their families. As a queer person with a documented disability, pelvic floor dysfunction, also known as chronic vulvovaginal pain, that prevents penetration, if passed, HB 6617 would allow people like me to receive the insurance coverage that I need to treat my chronic pelvic floor dysfunction and start a family. I've lived in many states and struggled to find insurance coverage to treat my chronic pelvic and vulvovaginal pain. Over my lifetime of dealing with this condition, I've spent over $10,000 seeking treatment. Because of consistent care and a patchwork of financial support, including family and credit card debt, many of my symptoms are now manageable. But as I think about starting a family in Connecticut, which is the state I've decided to settle in, I know that I'm going to need additional treatment like pelvic floor physical therapy or Botox injections in my pelvic floor in order to have a child. And I cannot imagine navigating the stress of trying to start a family while also dealing with mounting medical bills as I manage my chronic pain. And vulvovaginal and pelvic pain is very common. Up to 1 in 4 women will develop this pain at some point in their life. And they're very, very stigmatized, as you can imagine, right? It is difficult for so many to speak publicly, especially in a format like a public hearing. About 25 to 50% of infertile women have endometriosis, and 30 to 50% of women with endometriosis are infertile. And up to 35% of women with vaginismus cannot conceive without medical intervention. Many of us suffer in silence. And as the organizing director of Tight-Lipped, I receive messages all the time from members with these conditions who want to have children but cannot afford the medical care that they need to treat their vulvovaginal pain. A member named Naomi, her story stands out to me. She and her husband spent all of their extra income trying to start a family, trying to have her become pregnant. She told me that she basically stopped doing anything out of the house together, no movies, no vacations, no eating out, to pay for treatments for this condition so she could become pregnant. She now has a very, very cute baby, but it cost her and her partner everything to afford their dream of having a family. So I strongly support raised House Bill 6617. As someone who has a vulvovaginal pain condition that constitutes a barrier to conceiving and bearing children, I strongly support coverage for these conditions as a form of fertility treatment. Thanks so much.
Thank you so much, Ms. Strager, for being here and for your testimony. Next up is Beth Fisher, followed by Lori Snell Savage.
Good evening, members of the Human Services Committee. My name is Beth Fisher. I'm the CEO of CUNE Employment Opportunities. We're a nonprofit agency that has been helping individuals with disabilities to find, get, and keep jobs throughout Central Connecticut for the past 60 years. Our agency contracts with both DDS and DEMIS. I want to touch on the clear intent of the legislature to prohibit the practice of clawing back the unspent funds. You've heard some excellent testimony from many of my colleagues tonight. I would like to add my voice to support of this bill. The implementation of this has not gone, I think, as the legislature intended. As nonprofit agencies who saw a surplus, often on the backs of our employees who had to pick up extra work because of staffing crisis, we are not able to use that money without approval. We are asked to put together detailed budgets, exactly what we're going to spend it on. Our plan was submitted. We are 8 months into the fiscal year. We have yet to seek any, to get any approval on that. With any business, needs cannot wait, and what is most urgent can change over time. So this practice is unrealistic, and we need a better way of managing this. So I urge you to pass this bill. I also want to add my support to Section 4, which would tie nonprofit rates to inflation. This is something that nonprofits have needed for a very long time. I have testified before the legislature many, many times asking for increases just to keep up with the cost of inflation and to cover the cost of doing business. Our agency is seeing increases in medical costs. We provide a lot of transportation for individuals to get to and from work. We are currently more than $25,000 over budget just on van repairs this year. And to replace a vehicle for our aging fleet, we're paying $10,000 more a year this year than we would have for the same vehicle last year. And then in closing, we are an agency like all of my colleagues who have high quality marks in delivering services. We meet the DDS expectations as a qualified provider, and we regularly receive high marks in our fidelity reviews from DEMIS that are designed to ensure evidence-based practices are followed. So we really don't need to be micromanaged. We need to be able to address the needs in our agency. We can't go through another year putting our budget together, looking at, well, what can we cut to make up for inflation? There's just simply nothing left to cut. So I thank you for the opportunity to testify and for hanging in there with us this evening. I know it's been a long day for all of you. Thank you so much.
Thank you, Ms. Fisher, for your testimony and your time tonight. Next, we'll hear from Lori Snell Savage, followed by Monica Dawkins. Oh, no, not that.
Thank you, Senator Lesser. Thank you, Representative Gilchrist, and to the members of the Human Services Committee. Again, my name is Lori Snell Savage. I represent the Ministerial Health Fellowship. I know we talked tonight about how great of a need it is for the community health workers to be on ground. And that's what we do. We are the trusted messengers on the ground, and we are the advocates. We are also the support and the peer support for the people in the community that we aid. People assume that people know how to access their needs and resources that might be in aid for them whenever they need to go to the doctors or whenever they need to be affiliated with helping them with accessing the computer. But not everyone knows how to access the computer, especially the senior and the aging. We go out into the community and we go door to door and we assess people to see what their needs are. We try to meet people where they're at. And without that connection of going out into the community, it seems like that there is no ends and no means where we can get the people to come to us, because people have become complacent with what they have. They don't realize what is out there that they can utilize. And by us going out there and reaching them and giving them the information that they need to address their needs, they're able to go to their dentist appointments. They're able to understand what they need when they go to their doctor's appointments. We also address the barriers that they have when they do go to the doctor appointment, how important it is for them to be an active listener when you are with the individual that you're with. So when we go and we tend to their appointments with them, the peer support that we give them for emotional distress, people sometimes just need to know that somebody is going to be there and they're not going to leave them by their wayside. They have been affiliated with so many different programs that have made promises and made commitments that have not been kept. And we don't make promises. All we do is be there for emotional support, and we follow through with whatever goals, with whatever plans that they have intended for. So I look at this and I said, yes, a community health worker is essential. Health equity is essential. Health disparity is a storm. And the SB 991 is which we're supporting. The Act of Concern and Medicaid reimbursement for community health is, we need this. We need to come together and put that storm out, at least to stop it. So being supportive of the SB 991, and thank you for allowing me to share my testimony.
Thank you, Ms. Savage, for being here and for sharing your testimony with us. I was incorrect. We're going to go to Michael Hubert, but I do want to shout out to Deborah Hudo Benko. Please accept the, what is it called again? The promotion to panelist. It's been a long day. And so now we'll go to Michael Hubert.
Thank you. Good evening, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services. Again, thank you all for sticking with us. It's been a long day. I'm here to represent the Area Agencies on Aging. I am the Executive Director at Western Connecticut Area Agency on Aging in Waterbury. We serve 41 towns in Western Connecticut. So Connecticut's Aging CT represents the 5 independent nonprofit area agencies on aging, and we're here to testify in support of Senate Bill 1052, which is an act concerning area agencies on aging. Area agencies carry out mandates of the Older Americans Act 1965 as amended through an area plan approved by the State Unit on Aging and Disability Services. Aging CT assists local public, nonprofit, and private agencies in the development of programs, distribute federal and state funds for such purposes, and help consumers navigate and obtain needed long-term care services and supports. SB 1052 proposes to appropriate funds to the 5 AAAs in the sum of $500,000 to the Department of Aging and Disability Services General Fund in each of the fiscal years, June 30th, 2023 and June 30th, 2024, to fund not less than 2 persons, but to provide the navigator to help us support our consumers, our caregivers, and our persons with disabilities to remain independent in the community. Although Connecticut has information and referral programs like 211 and My Place CT, these services do not assist directly consumers, persons with disabilities, and or caregivers to explain these services in great detail, to help with eligibility requirements, and to help with the application processes, which are very complex. Frequently, these consumers call our area agencies seeking assistance to make sense of these programs, and this is where the service navigators come in, to listen, identify the myriad of needs, and walk with the consumer to help them secure these long-term services and supports to maintain their independence. This is very evident with the state health insurance program choices, Senior Medicare Patrol educating consumers on fraud protection, state and national family respite care programs for caregivers seeking respite care to keep their loved ones at home safely, locating congregate and home delivered meals programs, identifying nutritional risks, identifying specialized transportation services and wellness programs and in-home services, all things that we've heard throughout the day today. With the rising cost of and the issues around food insecurity, affordable housing, rising fuel costs, available transportation, and even vaccination services for the past few years. Service navigation is the glue that holds these services together and helps these consumers sort out the maze of programs such as Social Security benefits, Medicare, Medicaid, prescription drug costs, SNAP benefits, housing applications, just to name a few. Area agencies provide free, non-biased support to these consumers to help them select what service options are best for them. We ask your support to help us build this capacity to support the growing number of consumers statewide, and the ability to provide one service navigator at each of the AAA handles the thousands of calls that we handle annually. So that's the difference between us anecdotally and those other listservs, is that people get a list of resources, but they need to be connected with a live person. And throughout the pandemic, we took thousands of calls from consumers frustrated by being bounced around and not getting a direct answer to their question, and trying to deal with the complexity of the system. So I want to thank Representative Case and others that met with us last week to hear why we feel this is so important in Connecticut. And we only see the need to pursue this further. Thank you for your time.
Thank you so much for your testimony and your time tonight. Have a good evening.
You too.
We're going to go back to Deborah Hudobenko, and then we will go to Monica Donkins.
Hello. Good evening, Senators, Representative members of the Human Services Committee who are joining us today, and for all their patience throughout this testimony. I appreciate the opportunity to speak. My name is Deborah Hudobenko. I join others today in strong opposition to House Bill 6618. I morally oppose the practice of abortion, find it incomprehensible that our state government would require the use of our tax dollars to fund this practice. I was very dismayed to learn that our tax dollars are already funding 100% the cost of abortions for Medicaid patients living in Connecticut. The current proposed bill intends to expand this abortion funding to women not even residing in Connecticut by covering their medical and travel expenses, as well as other, quote, related services that are not even clarified as to what those services might actually include. To allocate any part of our state budget toward the promotion of abortion services to women living anywhere and everywhere outside of our state, encouraging and actually enticing people to seek abortions in Connecticut, and then funding these abortions and all associated costs of these procedures is a complete misuse of taxpayer money and is not representing the best interests of your constituents. There are so many great unmet needs of our people that deserve priority in fund allocation over what's proposed in this bill. And we've heard so much testimony today about those other great needs of our residents and our taxpayers. House Bill 6618 does not accomplish anything beneficial to the people of Connecticut, and in fact is designed to increase the revenue of the abortion industry, which is already extremely well funded. Abortion is not a victimless practice. Babies have human DNA from the moment of conception, and an abortion is ending a human life. We've already heard from others today about what's actually involved in the practice of an abortion. I'm not going to go into that. That's been well stated already. However, let's look at the women who are also victims. For those of you in support of this bill and abortion services in general, who do so, I'm sure, from a genuine desire to help women, I urge you to dig deeper into the reality of the business of the abortion industry. And yes, it is run as a business, a very profitable business whose priority is increasing revenue, to include productivity goals, incentives for the number of abortions performed, and other business initiatives which have little to do with the rights and the health management of women, regardless of age, race, skin color, sexual orientation, gender identity, or economic status. Despite all of the deceptive rhetoric about serving the reproductive rights and protecting women who are disadvantaged, the truth is that abortion does not protect women, it does not dignify women, and it does not empower women. I can tell you as a mental health provider who has worked with thousands of women across all demographic populations in my career of 25 years, the consequences of abortion are real, and they can and often do persist for many years in women's lives as they struggle with physical, emotional, and spiritual wounds that negatively impact their self-esteem, relationships, and mental health, often experiencing anxiety.
Time has expired. Can you please summarize?
Yep, I only have like a couple sentences left. When they're often experiencing anxiety, PTSD, depression, suicidal thoughts, substance abuse, self-injurious behaviors, and more. The cumulative impact of post-abortion trauma is especially pronounced when women avoid or delay seeking support and treatment for these issues due to shame, regret, or the fear of stigma because of the abortion. In closing, women do not benefit overall from the practice of abortion, and we deserve a better approach as a society to our needs and how we truly affirm women. Please vote no to Bill HB 6618. Thank you.
Thank you for your testimony and your time tonight.
Thank you.
Next, we'll hear from Monica Donkins, followed by Aisha Clark.
Good evening, Senator Lesser, Representative Gilchrist, and esteemed members of the Human Service Committee. My name is Monica Dawkins, and I am a resident of New Britain, Connecticut, and I'm standing in support of SB 991, an act concerning Medicaid reimbursement for community health workers. I serve as a community health worker with the Ministerial Health Fellowship. Our mission is to address the health disparities of those in the BIPOC community. We realize that persons within the BIPOC community are seldom represented equitably in healthcare services. Oftentimes, they feel as though they have not been recognized or adequately informed of specific service coverages in treatment settings. Currently, Connecticut's Medicaid program does not reimburse community health workers services or incentivize healthcare providers to work with CHWs. Community healthcare workers are connecting to our community through outreach to inform persons about healthcare resources that are needful. Services such as regular dental checkups, necessary screenings for all family members, and are often making certain that these persons get to the vital appointments. In my work as a CHW, I have often found that many people do not have proper oral health due to the lack of insurance. They perhaps have needed more extensive services that are not covered by Medicaid. And as a result, many persons with whom I have worked have been encouraged to have a procedure for an extraction when a proper insurance coverage and another procedure could have been used to save their teeth. When oral health has been neglected, many have found themselves having other medical complications, such as heart conditions and other issues. Medicaid reimbursements for community health workers should center community and CHW voices in all stages of design and implementation. Reimburse at rates high enough to employ CHWs at livable wages and cover the cost of supervision, billing, and routine training. They should also cover a comprehensive list of CHW services. Thank you for the opportunity to testify in support of SB 991, an act concerning Medicaid reimbursement for community health workers. I appreciate your time this evening.
Thank you, Ms. Dawkins, for being here tonight and for your testimony. Next, we'll hear from Aisha Clark, followed by Norin Ansari.
Thank you so much for your time today. This is an opportunity, Madam Chair and esteemed members of the Human Service Committee, just want to thank you for staying and listening to us because I know it's been a long day. My name is Aisha Clark and I serve as the Interim Executive Director for Health Equity Solutions, a nonprofit organization with a statewide focus on advancing health equity through anti-racist policies and practices. Thank you for hearing my testimony today in support of SB 991. Research listening to Connecticut residents and conversations with national experts, Centers for Medicare and Medicaid Services staff, community health workers, CHW employers, and other stakeholders have all led HES to prioritize a robust CHW workforce with sustainable funding as one of the most crucial levers for advancing health equity. CHWs are a proven cost-effective intervention to address the barriers to health that disproportionately impact Black, Latino, Latina, Indigenous, and other people of color in our state. We urge you to make Connecticut the 26th state to provide CHW services through Medicaid. CHWs are known by many names and provide a wide range of services. Hundreds of studies have demonstrated that CHW services are highly effective in reducing health inequities, improving health outcomes, and reducing costs across multiple settings and health conditions, and have a high return on investment. They also diversify the workforce and alleviate pressures on other health professionals by providing health education, preventing urgent visits, and addressing non-clinical issues. A coalition of over 100 CHWs and allies convened by HES and Community Health Workers Association of Connecticut in 2022 agreed on a set of principles for Medicaid reimbursement to maximize the potential of this policy. This includes a comprehensive set of services, the need to include CHWs in program design, and lastly, the importance of funding sufficient amount to cover livable wages. We submitted these recommendations in detail in our written testimony. The need for CHWs has never been more urgent. Our health and social systems grow increasingly more complex. Even when the changes are positive and the need to address health needs left untreated during the pandemic-related social isolation increases the risk of preventable illness and death. Inequities remain a significant and consistent concern in Connecticut, and community health workers offer effective, affordable solutions. This is a policy that has high rewards, both in terms of fiscal impact and then improved health equity, and quality for the life of Connecticut's people. We want to acknowledge earlier comments about value-based payment and note two things. First, the CHW coalition of over 100 CHWs and allies that have discussed payment options at length and agreed that a value-based model would better meet the needs. Second, all payment methods, including fee-for-service, cause harm. We encourage the committee to consider the recommendations of the coalition and give Medicaid the flexibility to create comprehensive CHW programs. Thank you for the opportunity to testify tonight. Thank you so much.
Thank you, Ms. Clark. So good to see you. Thank you for your work and thank you for being here tonight. Next, we'll hear from Norin Ansari.
Hi, everyone. Good afternoon or good evening, members of the Human Services Committee. My name is Noreen Ansari and I live in New Haven. I'm a physician in oncology and hematology, meaning I take care of people with cancer and blood disorders. I'm currently a chief fellow for the training program at Yale, and this testimony reflects my own opinion and not my employer's. I'm testifying today in support of House Bill 6617, an act to promote equity and coverage for fertility health care. I support this bill because fertility preservation is medically necessary for some people. My patients receive surprise diagnoses of cancer and require timely chemotherapy, surgery, or radiation. These treatments can affect their future fertility, so for young patients who have not completed their desired childbearing or family planning, as doctors, we encourage fertility preserving procedures beforehand. Fertility preservation is expensive and an unaffordable out-of-pocket expense for most people unless it's covered by insurance. And this bill corrects a significant inequity in our health system. At present, people with private insurance can seek medically necessary fertility preservation procedures, but those with Medicaid cannot. I'd like to tell the story of a real patient that illustrates why this bill is important to me. Last year, I cared for a 22-year-old male student with acute leukemia, which is an aggressive blood cancer that requires urgent chemotherapy. He was counseled on sperm banking prior to starting. Despite his desire for future children, he could not complete it because it was not covered by Medicaid and the quoted cost was unaffordable. I was devastated for him. As we moved forward with his cancer treatment, we were basically crossing our fingers and leaving his future dreams up to chance. Other oncologists can tell you stories of cancer survivors who have not been able to have children years later, and also of patients who have opted for non-standard treatments in favor of preserving fertility and later develop recurrent cancer. This represents a huge shortcoming in our system. When we put young patients through aggressive cancer treatment, we are hoping for survivorship, which includes the ability to lead normal lives after treatment. For many young people, this includes raising a family. And so while it is extremely difficult for young people to undergo fertility treatments and then cancer treatments in sequence, it is much more difficult and disheartening when there are financial barriers that make recommended procedures impossible. These calamities can befall any one of us, our loved ones, or our neighbors without warning, and available medical resources should not be limited to only those with private insurance. It is my hope that Connecticut will continue to be a leader in health equity and access by expanding coverage to include patients with public insurance. I want to thank the members of the Human Services Committee for introducing this bill and discussing this important issue, and I ask you to please vote to support. Thank you.
Thank you, Ms. Ansari, for your testimony and for being here tonight. Have a great evening.
Thanks.
Next, we will hear from Olivia Rinks. I will give a shout out to Michael Daly and Carrie Jaffe. If you're in the waiting room, please accept the promotion. Olivia, please go ahead.
Thank you and good evening, and thank you to the Human Services Committee for the opportunity to testify. My name is Olivia Rinkus from the town of North Stonington. I'm also a student at the University of Connecticut. I'm testifying today in strong support of SB 978, an act concerning expansion of the Covered Connecticut program, HB 6587, an act concerning Medicaid coverage for diapers, HB 6618, an act concerning medical assistance for certain persons receiving abortion care and related services in Connecticut, and HB 6703, an act concerning the low-income home energy assistance program. As a resident and taxpayer of Connecticut, I am in strong support of putting support towards these resources. Healthcare is a human right and can be a strenuous burden, whether the need for healthcare is unexpected or is needed on a regular basis. The current poverty level is at $27,750 for a family of four, which is not realistic considering the exorbitant increases we've seen in rent and other costs of living, especially over the last 2 years. The expansion of Medicaid coverage in SB 978 is more realistic to ensure that individuals who are in need of healthcare services can receive the care that they need, including dental and mental health care, without the concern that their ability to pay for food and shelter will be impacted. Additionally, abortion and other reproductive services are absolutely healthcare needs that are human rights. And considering the precarious state of the right to an abortion around the US right now, it is very important to take steps to protect individuals coming into Connecticut to receive these services, and also to ensure that these services are accessible to them in spite of any financial barriers by passing HB 6618 out of committee. I'm also in strong support of the expansion of Medicaid coverage to include diapers in HB 6587. Diapers are as crucial to the health of a young child as food, healthcare, and shelter and other resources, and they should absolutely be covered by Medicaid. A parent should never have to choose between providing new sanitary diapers and, by an extension, a clean environment for their child and other necessities. Finally, we are seeing huge increases in the cost of utilities, especially in Eversource right now. Utilities are as necessary for a person or family to function in home as a shelter itself. I am fully in support of HB 6703 and ensuring that all individuals are able to afford energy. Thank you very much for the opportunity to testify.
Thank you, Ms. Ranks, for being here and for your testimony. Have a great evening. Next, we'll hear from Michael Daly, followed by Carrie Jaffe. Michael, you just need to unmute.
Thank you. Good evening. My name is Michael Daly. I live in West Simsbury, Connecticut, and I would like to thank all the members of the Human Services Committee for this opportunity to testify. I've submitted my written testimony in opposition to House Bill 6618. And rather than recap that testimony, I'd like to give you a few observations that I've come to appreciate during listening to the testimony that was presented here today. The prospect of spending an additional $2 million on abortions to provide services for out-of-state residents, when we've heard from so many of our in-state residents who need services for wheelchairs and so many other things, when we have clawback issues that prevent not-for-profit organizations from providing the services that are so needed by our residents, I find it disturbing that we would take $2 million worth of taxpayers' money and deprive our residents of the services that we've heard that they need so desperately today, and provided for out-of-state women to come to our state for abortions. The other concerns that I have is I believe that the legislation as currently written is a little bit misleading. We have the Fox running the hen house. We all with abortion providers being the gatekeeper and making the determination. And also I feel that it's a little bit misleading that we talk about going back and seeing about getting Medicare funding, when in fact, currently Connecticut residents are paying 100% of Medicaid abortions because of the Hyde Amendment. So I feel that, at best, there's some problems with this bill that need to be addressed, even if it was to proceed. The other thing is I've heard multiple people today talking about the need for abortion and the fact that people are being deprived of abortion. In fact, the Supreme Court did not take away the right to abortion. It returned us to home rule, which is a fundamental premise of our form of government, that most issues should be dealt with at the local level. So the Supreme Court did not deprive anybody of a right. They didn't take away any right. They put it back perhaps where many people believe it should be, which is with the local government. And I question whether or not we are doing a service, taking citizens from other states, providing them with abortion coverage, and perhaps having to underwrite the care as a result of complications, mental health complications as a result of an abortion and other things. So for all of those reasons, I would ask this committee to not vote and bring this bill out of committee, but rather take those $2 million funds and devote them to services that we've heard so many of our residents need today. Thank you for being here so late tonight, and thank you for giving me the opportunity to testify on this bill. Thank you very much. And if there's any questions, I'll be happy to answer them.
Great. Thank you, Mr. Daly. Senator Seminara.
Hi, Michael. This is Senator Seminara. I just wanted to thank you so much for hanging in there at 5 to 9 in the evening and testifying tonight and taking time out of your busy schedule so that we can hear your opinion. Thank you so much. And I look forward to hearing
thank you, and thank all the members of the committee for taking time and being here so late. I think we all agree government's not a spectator sport, and I thank you for your support and your interest.
Thank you. Thank you so much.
Have a great night, Mr. Daly.
You will. Thank you.
Next, we'll hear from Carrie Jaffe, followed by Nicole Saclemente. Carrie, you just have to unmute, please.
Go.
Oh, you were. Now do it one more time. You muted again.
Okay, thank you. Can you hear me?
Yep, go right ahead.
Okay, fantastic. Good evening, distinguished Human Services Committee members. My name is Carrie Jaffe. I am the clinical manager for ARI of Connecticut. ARI of Connecticut is a nonprofit provider in Stamford, Connecticut, providing residential, vocational, and recreational services for adults with developmental disabilities. I am also an approved provider of positive behavior supports, serving a half dozen families with behavioral services funded by the Department of Developmental Services. I speak tonight regarding HB 6612. Wage increases have been helpful, but by themselves, they have not come close to closing the gap between nonprofit providers and state workers. As a clinician with 2 master's degrees, 40 years of experience, and postgraduate training in applied behavior analysis, I earn a salary at my full-time job that is at least $30,000 less than someone in a similar position with similar experiences and education as a state employee. Oh, God. Okay, I speak wage increases. Okay, as for our direct, that was my phone, sorry. As for our direct care workers, those salaries have increased. They have at best kept up with very recent increases in inflation. Salaries remain commensurate with entry-level fast food or supermarket positions. At the same time, our direct care workers often serve individuals with complex emotional, behavioral, and physical needs besides their cognitive disabilities, needs that would challenge the most seasoned clinician. In my agency, approximately 40% of the individuals we serve have a psychiatric diagnosis and take psychotropic medication. Self-abuse and physical aggression are frequent challenges. Yet despite such challenges, salaries are at the lower ring of the salary scale as compared to other lines of work. In my most cynical moments, which is often my simplistic answer to the present problem of such wide-ranging inconsistency in the quality of service, is to fire half of our staff, but double the remaining salaries of the remaining staff. To be a good direct service worker is a hard and challenging job that requires a skilled professional. The results of not meeting this challenge includes high staff turnover, a large number of positions not filled, leaving the remaining staff often doing double shifts that are 16 hours, or managerial staff filling shifts that are vacant, behavior issues that remain the same year after year that are costly over time, high rates of reported suspected negligence and abuse, and a great discrepancy between the state's principles promoting quality person-centered services versus actual practice. We can do better. And I thank you for your time.
I thank you for your time. Thank you so much, Mr. Jaffe. Have a wonderful evening.
Okay, thank you.
Next, we'll hear from Nicole Saclemente, followed by Catherine Saris.
Good evening, everyone. Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. Thank you for having me. Thank you for sticking with us this evening. My name is Nicole Saclemente, and I am the Policy Manager for the Connecticut Women's Education and Legal Fund, or also known as QUELF, a statewide nonprofit organization that uses a justice and equity lens to advocate for under-resourced, marginalized women and girls in the state of Connecticut. Thank you for the opportunity to testify in support of House Bill number 6617, an act promoting equity and coverage for fertility health care. House Bill 6617 removes barriers to fertility care and helps ensure that Connecticut residents have equitable access to the reproductive care that they need to build their families. The cost of fertility care can range from $1,000 to tens of thousands of dollars, which puts treatment out of reach for the vast majority of people who do not have fertility insurance coverage. Current Connecticut law requires private insurance providers to cover fertility treatment only for people who meet a limited definition of infertility that is defined in reference to heterosexual intercourse, a narrow definition that excludes single individuals and LGBTQ+ families from coverage. House Bill number 6617 would bring Connecticut's existing fertility insurance requirements up to speed with the state's other laws that recognize and honor the needs of modern families. Research also shows that Connecticut's existing law promotes racial disparities in accessing fertility care. The ability to grow and care for the family that you wish for, including access to fertility services for those who need it, is fundamental to reproductive justice. The share of women of color who utilize medical services to help them become pregnant is less than that of non-Hispanic white women, despite research that indicates Black and American Indian/Alaska Native women experience higher rates of infertility. Several factors, such as differences in insurance coverage, income, and availability of services, as well as misconceptions and stereotypes about fertility, affect access to infertility care. Combined with the history of discrimination and racism in reproductive care and decades of harm inflicted on women of color, some may delay or forego fertility care altogether. We also urge the committee to support House Bill number 6618, an act concerning medical assistance for certain persons receiving abortion care and related services in Connecticut. House Bill 6618 will provide funding for people who are in need of financial assistance while traveling to Connecticut to receive abortion care. To date, 18 states across the country have completely banned or severely restricted abortion, forcing patients to travel to other states to seek legal abortion care. Financial barriers should not prohibit them from receiving this time-sensitive, essential healthcare that they need, especially when anti-abortion politicians are outlawing this care in their home states. Abortion bans have the most severe impact on people who already face systemic and structural barriers to care, including communities of color, people with low income, immigrants, LGBTQ+ people, and more communities. QUELF thanks the committee for raising these important issues this year. Advancing House Bill 6617 and House Bill 6618 this year are critical steps towards ensuring that Connecticut residents have the opportunity to start or grow their families on their own terms and eliminating barriers to essential time-sensitive healthcare. Thank you.
Thank you so much, Ms. Saclemente, for staying with us tonight. Have a good evening.
You as well, thanks.
Next, we'll hear from Catherine Saris, followed by Millie Siguenot.
Good evening. Thank you, Senator Lesser and Representative Gilchrist and members of the committee. We appreciate so much you staying so late to hear all this public testimony. I would like to just speak a little bit today about HB 6618. I vehemently oppose this bill, and I would like to explain why. I think earlier in the day, we had some wonderful comments about how this bill has been linked to a big opening for the sex trafficking industry. And human sex trafficking is an area that's very close to my heart personally. I'm a performing artist, and I played the role of a human sex trafficked victim in a production that I was in for 3 years. And in that time, as I had to prepare for that role and research what this is like for young women who go through this type of life, I learned a great deal. And not only is our nation a huge, huge place where sex trafficking happens, but also our state. And this bill is exactly what could be used to exploit so many women across the country. This is not a question to me that this bill opens up a huge door for people to basically lie about it and force women into situations as young as 12, 13 years old. Is when we brought into the state of Connecticut, we would be paying and abetting for sexual abuse to happen to these children, women. And as was mentioned earlier, I think Nicholas Smith was the one who said that the life expectancy for these women is 7 years in this business, and that's on a good day. And the amount of violence that occurs to them is terrible. I also think that the hard-earned dollars of us here in the state of Connecticut should not be wasted to confirm a particular side of the debate about abortion. And whatever your feelings are about abortion, I really think that it's a very politically motivated bill to pick one side and one position. And I just think it's badly written. So thank you so much for listening to my testimony. I vehemently urge you not to allow this bill to waste any more time of our precious time and energy and resources. And thank you for listening to me today.
Thank you, Ms. Saris, for your testimony and your time. Have a great evening. Next, we'll hear from Millie Siguenot, followed by Rick Sebastian.
Good evening, Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Millie Siguenot. I am a resident of Stratford, Connecticut. I am a certified community health worker and executive director of the Community Health Workers Association of Connecticut. I stand in support of SB 1991, an act concerning Medicaid reimbursement for community health workers. Currently, Connecticut's Medicaid program does not reimburse community health worker services or incentivize healthcare providers to work with community health workers. Community health workers are an effective way to address inequities and promote health, particularly for low-income households served by Medicaid. And this is what I have been experiencing with working in this field for many years. With our involvement, individuals from the community have been able to get services and be referred to providers so they can improve their physical and mental health and live a better quality of life. But we won't be able to continue doing this work if we don't have sustainable funding to provide the quality of care that our community deserves. Our communities are constantly changing because people move from place to place, and the needs of the community are changing as well. Community health workers have the knowledge to work with these communities and identify their needs. Without our intervention, individuals in need won't be able to connect with the resources that they need or connect with the correct provider to be able to live a better quality of life. Thank you for the opportunity to testify in support of SB 991, an act concerning Medicare reimbursement for community health workers. Thank you.
Thank you, Ms. Huguenot, for being here and for your testimony. Have a wonderful evening.
Thanks.
Now we'll hear from Rick Sebastian. Go right ahead, Rick.
Good evening, Senator Lesser, Representative Gilchrist, Senator Seminara, and Representative Case, along with all of the other members of the Human Services Committee. I believe I might be akin to Wagner's Brunilda in his 4-opera Ring Cycle where the fat lady is singing. So I appreciate your multiple hours of hearing testimony, engaging with citizens throughout the state on very important issues. I'm the president and CEO of the Kennedy Collective, formerly the Kennedy Center, headquartered in Trumbull, doing business here in Connecticut for 72 years, supporting several thousand people with disabilities in 110 communities throughout the state. We're a residential, day support, community housing, and employment business organization. We hold contracts with DDS, DSS, and DEMIS. In addition, we operate self-sustaining, meaning no state funding, dual bottom line social enterprises that employ people with disabilities and others with barriers to employment. Thank you for the opportunity to speak with you this evening and to provide my testimony in support of HB 6612. I support the two main components of the bill: the discontinuance of cost settlement or clawback of unexpended funds paid to contractors and the indexing of reimbursement rates to inflation. You've heard throughout the day from my colleagues about the impacts of HB 6612 on our operations. I'd like to take a little different approach this evening with my time and talk to you about what you're already getting for your constituents throughout the state and what the state agencies as the payers are getting from the not-for-profit sector in the form of key performance indicators. There are several. The first and most important for all of us is stewardship and fiscal responsibility. For example, the Kennedy Collective, along with other providers who are providing day services, are receiving reimbursement for 45 weeks of service, yet we provide 52 weeks of service to those individuals that require 52 weeks of service. Another key performance indicator is high levels of customer satisfaction. Our customers are satisfied with services that we are providing to them. As it relates to the clawback provision of HB 6612, we're providing efficient and effective delivery of service. We have the ability to meet the needs of individuals for perhaps 95 cents on the dollar, which means that we can retain the 5 cents on the dollar invested into next year, invested into mitigating those people that are waiting for services and increased service delivery. Another key performance indicator that occurs within our sector is transparency. We're a highly regulated, evaluated, audited, and responsive contractor to our state payers. our service recipients, their families, and our communities. The last piece of key performance that I'd like to address this evening, that this bill will also help to create, especially with the provision of indexing our reimbursement to inflation, is that it becomes a critical step in relieving the economic and social distress experienced by our sector for now more than 15 years, exacerbated during the last 3 years by COVID. On March 13th, 2020, when we closed our organization
Sebastian, your
4
time
months,
has expired. Can you
we
please
employed
summarize?
600 employees. Today, we employ 465. COVID devastated the Kennedy Collective. This particular bill, the actions in the bill, will help ease some of that devastation and will help develop a workforce that is able to serve our most vulnerable people in the state. Thank you very much for your time today, as I've already stated. Thank you for the service that you provide to all of us in the state, and we look forward to a very positive outcome for the session.
Thank you, Mr. Sebastian, for your work and for your testimony tonight. That concludes. Nope. Oh, okay. Who are we going? All right, we're going to go to number 24. What is their name? Do we know? Let me pull back the line thing. Okay. Ivelisse Correa. Thank you. Go right ahead.
I'm sorry, but after me, you're done. So I'll be as quick as possible. My name is Ivelisse Correa. You can hear me, right?
Yep, we can hear you. Go right ahead.
Okay, perfect. I'm testifying in favor of SB 208, HB 6587, HB 6701, and HB 6618. So starting first with 208, this bill is near and dear to my heart. I have several friends who were born with cerebral palsy. I hope that the committee does consider the mental health of this population. I hope that they consider the fact that, you know, pouring more funds into these things and our most vulnerable people really will help expand not only their mental health, but, you know, their physical health, getting to appointments, getting to see family members, getting out to the libraries, and, you know, going about in their community. So putting money into paratransit and other types of funds would really help connect them. These funds are about to end. We don't know what's going to happen at the Transportation Committee with low-cost transportation or the free fare transit bill. And at least helping our most vulnerable people, if the free paratransit service does expire, will help keep these people connected. Also for HB 6587 and 6701, people who are low income do, you know, suffer from poverty. And with poverty comes different things in the form of punishments. These people already are dealing with a housing crisis, and any sort of assistance. I'm sorry, I'm just, I'm thinking about different ways that, you know, these people do suffer when it comes to looking for diapers, looking for jobs. Not having access to diapers prevents, you know, families from enrolling their children in daycare. It prevents job searches. So people who can't bury their loved ones in a respectable manner, you know, are forced to do fish fries and raise funds, do GoFundMes, and where, as a society, we should be better than that. So I really do hope that the committee do consider that. And finally, there's been a lot of debate about HB 6618. So I know there's been a lot of talk about things that Planned Parenthood does. And I'd like to thank Planned Parenthood because when I had a UTI after surgery on my bladder, they were able to see me faster than my
Ms. Corey,
urologist. So,
could you please summarize?
yes, I would like to thank them because they don't just do birth control and abortions. And a simple Google search would do these people well who are opposed to giving them more funding. So I'd like to thank the committee very much for allowing me to speak today, and I'm happy to answer any questions.
Thank you so much. And I'm so glad you were able to hang in there tonight. Thanks for being here.
Oh, absolutely. You guys have a good night.
All right, next we'll go to 98, David Morgana.
Can you hear me?
Yes, we can go right ahead. He disappeared. David, we'll give you just a couple of seconds to try and get back on, but it is late. All right, we'll start doing some closing remarks and we'll see if David pops back on. I just want to thank everyone. It was a long day. We had a lot of great bills, wonderful testimony, and I thank all the committee members for a good public hearing. Any sign of? All right, well, did we get his written testimony? If not, hopefully David can submit that written testimony. And again, thank you, everyone. I'm going to adjourn the Human Services